पास रहना बाजू घुमा के दूसरी तरफ से करना। वो करेंगे स्लाइड नहीं है, स्लाइड करना कैसे
Yours is finished, then?
पीछे का आ रहा है, वो भी आ गया, एक उसमें भी लेते। फोटो भी आ रही है ना उसमें, थोड़ा पीछे से ले लेना।
फिर हमें इंट्रोड्यूस करा देते हैं, है ना? हाँ. Good morning, everyone. Let's start with the today's session. Our first session is Management of RH-LO Immunization in Pregnancy by Dr. Priyanka Sharma. I invite Dr. Priyanka Sharma. She is from ESIC Medical College, Faridabad. She is Associate Professor. The chairpersons for this session are Dr. Anandjit Kaur, she is on the way. And I invite Dr. Anita Rajoria as chairperson. She is HOD Senior Consultant, Department of Obs and Gynae. And Dr. Hegdevar Arogya Sansthan, Government of NCT, Delhi. She has achieved Dr. Abdul Kalam Achievers Award and has more than 32 years of vast experience. I welcome you, ma'am. And our second chairperson is Dr. Gitanjali. She is working in PAL Hospital, Ludhiana, more than 25 years of experience. Dr. Priyanka, please start the session.
Good morning, everyone. It is a pleasure to be here in the city of Ludhiana. This is the state where I did my post-graduation, and it is both delightful and humbling to be speaking in front of my own seniors here from Amritsar. So my topic is the management of an RH allo-immunized pregnancy. So before we start that, we need to look at how the RH nomenclature works. So the RH or the DCE blood group system works on what was proposed by Fisher race or the Fisher race theory, which states that there are 3 genetic loci on the short arm of chromosome 1, and since they're very close together, they get inherited together. So there are 45 RH genes, but the RH genes of importance, clinical importance, which cause hemolytic disease of the newborn, of the fetus, are actually 3 important genes, D, C, and E. Now, each has 2 major alleles and 5 antigen types. Now, why not 6? Because the small d gene, when it is not expressed, there's no antibody which can recognize the small d antigen. So for us, practically, the small d antigen does not exist because we cannot recognize it. So there are 5 antigen types that can be recognized with the anti-sera that we have. Now, D is inherited as autosomal dominant, but C and E are codominant, and D is by far the most common alloimmunization that is seen. So there are 8 allelic combinations that are possible, and there are certain potentially sensitizing events that can actually lead to RH, iso, or alloimmunization. The terms can be used interchangeably. So in an index pregnancy, RH, alloimmunization, or isoimmunization can occur in any patients who are Rh negative and have undergone diagnostic or therapeutic procedures through amniocentesis, CVS, chordosynthesis, have APH or uterine bleeding during pregnancy, have undergone an ACV, have had an abdominal trauma, an ectopic, an evacuation of a molar pregnancy, intrauterine death, stillbirth, intrauterine therapeutic interventions, miscarriage, threatened miscarriage, therapeutic termination of pregnancy, but by far the most common reason for Rh alloimmunization is delivery, whether it is normal or instrument or cesarean, which accounts for more than 90% of all alloimmunization. Now, it is very important, first of all, to identify Rh alloimmunization at time, and it is very important for that purpose to ensure that any patient who comes to us has an ABO-Rh and, if possible, an indirect home test for extended red cell antigens like KEL, Duffy, K, J, etc. In any patient where Rh antibodies are detected, we have protocols for monitoring the patient. But where Rh antibodies are not detected, routine immunoprophylaxis with anti-D should be done at 28 weeks. And the same ABO-Rh incompatibility testing should be done once again before administering the anti-D. So routine postpartum prophylaxis, 72 hours between delivery, after delivery, within 72 hours after delivery, and routine immunoprophylaxis at 28 weeks of gestation is the recommended standard all over the world. Additional immunoprophylaxis, in addition to this routine prophylaxis, is given after all sensitizing events with appropriate dose, enough to clear all fetal RBCs from maternal circulation, and this dose is calculated by the KB test or by flow cytometry. So, despite all of us knowing that anti-immunization is so important and can be life-saving for fetuses and for the newborn, there is an extremely unsatisfactory compliance by and large all over the world. So this paper, which is basically a global review of the practice for anti-D, shows us, if you see the global burden of disease region-wise, in Asia and Southeast Asia, so the blue line indicates what is minimum, that is postpartum prophylaxis, and the green line at top indicates optimum prophylaxis, which is antenatal and postnatal. And for Southeast Asia, we are way below even the postpartum prophylaxis. So it is very important to reinforce that despite so much education, there is very little compliance to anti-D immunization, even postpartum anti-D immunization, and this is something all of us should work on. So, if we look at the region-wise distribution, now India falls in a very bad category where the gap of Rh is postpartum Rh immunoprophylaxis is as much as 30 to 50%. So how do we screen a pregnancy? At booking, all pregnant women should undergo an ABO-Rh test typing and an antibody screen, which should include, if possible, extended red cell antigens. Whenever there is a clinically significant antibody screen positive, anti-D, C, and K antibodies should be tested, and testing should take place monthly till 28 weeks, and then twice weekly, every 2 weekly till delivery. For all other clinically significant antibodies, we should consider paternal or fetal genotyping for the corresponding antigen and repeat the antibody screen at 28 weeks. If there are no clinically significant antibodies, we need to repeat the testing at 28 weeks. If there are no antibodies, no further action is required. But if there is clinically significant antibody, again, we have to test accordingly and monitor the patient. So how do we determine the risk of fetal hemolysis when the maternal antibodies come out to be positive? So the first thing we do is we do a father's blood group, or if we have the facility of fetus's father's genotyping. Now, if the father is homozygous, then an MCA-PSV is initiated. If the father is negative and the paternity is certain, no other test is needed. And if the father is heterozygous or paternity is unsure, then cell-free fetal DNA testing needs to be done, or if it is not available, amniocentesis for RHD genotyping can be done, or there are certain antigens for which cell-free fetal DNA testing is not available in all countries. In those conditions, an amniocentesis or a genotyping, for example, K for the K antigen, cell-free fetal DNA testing is not available in many countries. So what we can do is we can try for an amniocentesis for genotyping. If the fetal antigen is present, then MCA PSV can be done. So what are important titers? Now, there are basically three ways titers can be assessed. One is quantitative antibody titer. So if we take a quantitative value, for anti-D it is 4 international units, anti-C it is 7.5, anti-K, the titers do not correlate with the degree of fetal anemia and hydrops. Therefore, in these patients, serological testing is not done and an MCA PSV is started at 18 weeks of gestation. So, the other way to go about is to see the critical titer, which is what most of us are doing. So depending upon what lab you have, the titer, every lab has its own value. The titer can be 1:8 or up to 1:32 could be normal. So once it crosses the critical titer, we start monitoring the fetus for fetal anemia. There is another technique called antibody-dependent cell cytotoxin-mediated cytotoxicity method, which is done only in a few countries, and they estimate the percentage of hemolysis cells which have undergone hemolysis. So once a patient tests positive, has a critical titer, or is quantitatively has threshold antibodies, antibody levels are checked every 4 weeks till 28 and every 2 weeks. For anti-K, there is poor correlation. Even if a patient tests positive for an antibody, it is still important to repeat the screen at 28 weeks because these patients may have turned positive for another antibody by 28 weeks. So just because a patient is positive doesn't mean we don't need to do an ICT for other antigens. When do we need a specialist fetal medicine referral? So whenever our antibody titers cross critical levels, like an anti-D more than 4.5, an anti-C more than 7.5, any level of anti-K antibodies, or if anti-C and anti-E coexist, because anti-E in itself cannot mount a potentially hemolytic reaction, but when it is present with anti-C, even with lower levels of titer, it can cause hemolytic disease of the fetus and newborn. Or whenever the ultrasound suggests fetal anemia, or whenever there is past history of neonatal jaundice, or severe neonatal jaundice, or history of IUT or neonatal exchange transfusions in the previous pregnancy. How do we monitor? So once critical titers are crossed, antibody levels have crossed critical thresholds, weekly MCA PSV testing is done, and any levels greater than 1.4 multiples of medians indicate fetal anemia. This test has a sensitivity of about 75.5% and a specificity of 90.8%, but it has very exacting measurement requirements. So you need to be really trained when you do an MCA PSV to get good results. So this is the Society for Maternal and Fetal Medicine guidelines for how the testing should be done. It should be done in an axial level with the fetal head at the level of the sphenoid bones during a period of fetal quiescence. So the fetus should not be moving. You have to image the circle of Willis with the color Doppler and select the area of the MCA which is very close to the transducer. The entire length of the MCA should be visualized. Then you should zoom the area so that the MCA occupies more than 50% of the screen and sample it with a 2 millimeter gate sampling volume. The angle of insunation should be 0 degrees or as close to 0 degrees. If you cannot achieve a 0 degree angle of insinuation, then angle correction may be applied, but that is not the preferred method. And once you get the trace, the peak systolic value will automatically be calculated or can be manually calculated by the operator. So if the MCA PSV is more than 1.5 times multiples of mean, the gestation age is less than 35 weeks, we do a cotosynthesis to sample the fetal hemoglobin, and if possible, we try to do an intrauterine transfusion in the same setting. If it is more than 1.5 and the gestation is more than 35 weeks, we need to observe the MCA PSV trends. If MCA PSV is stable, we can continue pregnancy and induce labor at 38 to 39 weeks. If the MCA PSV is rising, we should consider induction of labor. If MCA PSV is normal, that is less than 1.5 multiples of median, we can do sequential MCA PSV every week. So on the right side, I marked the 1.5 multiples of median MCA values for each week of gestation. When do we need to do an intrauterine transfusion? Now, it is very important that all delta, OD, 450, optical densimetry, estimation by the Lilly's or the Queenan's curve, all of those are outdated techniques now and are no longer recommended. So if the fetus is deemed to have significant risk of fetal anemia by an MCA Doppler, fetal blood sampling for HP and hematocrit estimation and an intrauterine transfusion should be planned. Fetal anemia, is this a warning bell or? Time is up. So can I have another 2 minutes? Thank you. So fetal anemia is defined as an HP where the HP is less than 2 times the standard deviation for any gestational age, or a hematocrit is less than 30%. We can calculate the transfusion volume as transfusion coefficient multiplied by the estimated fetal weight, and our target, final post-transfusion target is 40 to 50% hematocrit. What kind of blood do we use? We use an O negative, leukocyte depleted, fresh blood, which has less 2,3-diphosphoglycerate. It should be irradiated and leukocyte depleted to decrease graft versus host reaction. It should be negative for the antigens, obviously, against which the maternal antibodies have been mounted. It should be CMV negative, K negative. The hematocrit of the blood should be 75 to 85%. Some operators paralyze the fetus with atracurium bucuronium and give fetal pain medication. Some do not. Strict asepsis is important. The site of transfusion is important. It is important to take, if the placenta is anterior, we should take it from the placental cord insertion because that is a stationary static area. Or we can do an intrahepatic transfusion where we use the intrahepatic portion of the umbilical vein. Needling free loops of cord is not recommended because it leads to intrauterine transfusion-related complications. Now, if the fetus is extremely premature, then sometimes when we give an intrahepatic transfusion or a placental cord transfusion, there can be volume overload and there can be complications. So an intraperitoneal transfusion can be done where the blood that goes into the fetal circulation goes slowly. And the volume calculated is gestational age minus 20 into 10 ml. So this is basically an image showing the needle passing through the placenta. And in the other one, we can see the needle that is passing through the intrahepatic portion of the umbilical vein. Subsequent transfusions are usually done after 2 weeks. The threshold for MCA-PSV in subsequent transfusion, some people say should be higher because now the baby has a significant amount of non-RH blood cells. As a result, the hemolysis will be less. So we can move the MCA-PSV higher. By the end of the second transfusion, almost all the fetal RBCs will be replaced by the donor RBCs. This will resist hemolysis and these have a half-life of 100 days, which means that the interval of subsequent IUDs keeps on increasing because now the baby has more donor cells than its own cells, so there is lesser hemolysis. So after the second transfusion, how do we decide how much to give? After the second transfusion, the daily fall in hematocrit in HB is 0.3 gram per deciliter per day. And after the third transfusion, this fall decreases because now all the cells in the baby are the donor cells and there are no fetal blood cells available. Neonatal outcomes after treatment, short-term outcomes. It's a very good test. I'm just about to wrap up. Total perinatal mortality is only 10%. 90% of babies survive. The babies which are most afflicted are the ones which have hydrops. Procedure-related complications are also low and acceptable. Fetal loss is 3.9%. And procedure-related fetal loss is 2.1%. Long-term outcomes, the LOTUS study was carried out in 2010, which actually saw 291 fetuses with the RH alloimmunization, and the incidence of neural developmental delay was only 4.8%, that too more in patients with hydrops. Non-invasive treatments, IV immunoglobulins can be given. They may prevent and reduce fetal hemolysis, but it does not treat the fetal anemia. It is started at 12 weeks, given every 2 weeks. Therapeutic plasma exchange, where the mother's plasma is filtered out and all the antibodies are removed from the mother's plasma, is also a technique that has been tried, but it is not extremely promising. So it's not giving any therapeutic benefit. What are the take-home messages? Complete and correct routine and post-event anti-D immunoprophylaxis is key for reducing incidence of RH immunization. NIPT can curtail unnecessary administration of anti-D. If you're doing an NIPT, a cell-free fetal DNA, you are saving 40% of fetuses from getting exposed to anti-D, those fetuses which are already Rh negative. MCA-PSV is the gold standard for diagnosis of fetal anemia. Delta OD 450 Lilly and Queenan curves are no longer recommended. IUT is a safe and effective technique for preventing fetal complications. It has good perinatal survival with low, short, and long-term complications. And IVIG is used in some centers to prevent and delay fetal hemolysis. Thank you so much.
Very nice, doctor. You have very clearly highlighted the salient features of RH incompatibility. I know it is very difficult to cover the topic in just 12 minutes, but you have covered all the topics very well, and recent reviews you have added in your presentation. I just want to convey one message that all RH incompatible mothers are not having RH isoimmunization. That
Right.
is one thing. And moreover, MCA has helped all obstetricians a lot to avoid invasive procedures like we used to have
Do
earlier.
earlier.
So thank you very much. If there are any questions, we can take from the floor.
So fetal hemoglobin, usually 5 to 7 gram per deciliter is the level at which hemolysis starts occurring. So that can be used. Any hematocrit less than 30%. So when you send an HB, you send a hematocrit. Any hematocrit less than 30 requires a transfusion. More than 30 does not require a transfusion.
Moreover, there will be features like
There can be
baby should
hydrops,
not develop
features of
hydrops or something.
ascites and all.
Means MCA is also MCA also determines, yes.
So the hematocrit is a good way to find out if you need it.
MCA velocity is more important in when to give intrauterine transfusion.
Thank you so much, ma'am. It was a pleasure.
Welcome.
Thank you very much for inviting me.
Thank you, Dr. Priyanka, for such a beautifully elaborated lecture. I welcome our chairperson, Dr. Nanchit. She is MBBS MD from GMC Patiala. She has worked in ESI and Civil Hospital. She has been awarded Certificate of Excellence by Punjab Government for safe motherhood and institutional deliveries. Now she is practicing in Ludhiana. I welcome you, ma'am. Our second speaker is Dr. Amritpal Kaur for single fetal demise. I invite Dr. Amritpal. She is professor and head of Obs and Gynae in Government Medical College, Amritsar. She is president Amritsar Obs Gynae Society. She has been a master trainer in PPIUCD pregnancies. She is working for more than 30 years and has more than 50 publications. Her area of interest are high risk pregnancy and contraception.
Good morning, everyone. I thank the organizers for making me party to this program, and I thank the chairpersons also. So the topic is single fetal demise. So I'll cover this topic under the headings of incidence, etiology, complications, prognosis, and the management. So what I want to say, this single fetal demise in the first trimester, it's not uncommon, but seems not to impair the further development of the survival one. So this is like quite common in the first trimester, seen like 10 to 40%. One of the studies has given this incidence as 10 to 40%. Another has given it as 29%. So such a high incidence. Before 12 weeks, once when the one fetus dies, it's more common in the twins. And further, once the number of the fetuses increases, the incidence of single fetal demise further increases. So moves on to 53% in the triplets and 65% of the quadruplets. And why this is important to know, this vanishing twin syndrome is when we are doing in ART pregnancies, this should be kept in mind when we are screening for neural tube defects, because there will be higher PAPA levels and the beta HCG levels. And then fetal death in a slightly more advanced period, like more than 12 weeks, at 14, 16 weeks, this may go further undetected till the delivery of the live fetus, as this fetus will be compressed between the membranes and the uterine wall. So this will be as a fetus compresses due to absorption of the soft parts of the fetus, and the liquor also gets absorbed. Now, the one twin loss in the late second and the third trimester, though this is less common, it's variously different authors have reported it as 0.5 to 11%. So it's a much less common than in the first trimester vanishing twin. It is definitely more common in monochorionic than in diachorionic. So various studies has given different incidences. Some of these as 4 times than in diachorionic. Another has given 6 times more common in monochorionic than in the dichorionic. So what is its impact of single fetal demise? In late second and the third trimester, though this is rare, but it has got big impact on the maternal and the fetal outcome. There is psychological stress to the mother also and simultaneously to the attending obstetrician also. There is risk of preterm labor, fetal growth restriction, risk of neurological abnormalities in the surviving twin, even death of the surviving twin, and risk of maternal DIC also. So these are the things that we have to keep in our mind. So what is the cause of this single fetal demise? Most common is the placentation. Which placentation? Monochorionic is the main culprit. Then there may be congenital abnormality in one of the fetuses. Another cause, it may be growth discordance. One fetus is not developing at the rate than the other twin, and then it may be a iatrogenic cause. So finally, what we have seen, it's the chronicity which is more important, that determines the morbidity and mortality in single fetal demise. And it is seen 50 to 70% in single fetal demise, the cause is monochorionic placenta. And in 70% of this monochorionic placenta, the other twin, the one has already died, the other surviving twin may have neurological abnormality, or the second twin may also die. So it's the monochorionic placenta which is the main culprit. In dichorionic, what we see, major morbidity in surviving twin is unlikely because they are not sharing their arteriovenous or arterio or vascular connections. There are 2 placenta in dichorionic, they are hemodynamically independent, so the morbidity is not that major. So that's why what we say, determination of chronicity is mandatory as early as possible once you diagnose twin or multiple pregnancy. So the etiology also varies for dichorionic, diamniotic, monochorionic, monoamniotic. So what we say, the etiology of single fetal demise in dichorionic, diamniotic, the main cause here is the growth restriction. That is more than 30% of growth discordance in one of the twin. If it is associated with Doppler abnormalities also, the fetus, the one of the fetus, there are chances that will die inside the uterus. And the next cause in dichorionic, it may be preeclampsia, it may be abruption placenta, it may be associated maternal gestational diabetes mellitus, maybe intrauterine infections, or it may be placental like cord accidents also. But in monochorionic diamniotic, the etiology is entirely different. In more than 50%, it is twin-to-twin transfusion syndrome that is the cause, because the blood flows disproportionately to one fetus and there is high risk of death. And this monochorionic and these twins, they may be discordant in congenital abnormalities. So one of this, they may be having a neurological abnormality, may be having cardiac abnormality. Then trap may be the cause. And finally, when we treat a patient of TTTS, or we do cord ligation as a treatment for TTTS, that may itself lead to death of the one of the fetuses due to intraamniotic hemorrhage or maybe any other complication of laser treatment. Then in monochorionic, monoamniotic, again there is high risk of single fetal demise, but here the cause is cord entanglement is the main cause. The 2 fetuses are lying in the same sac And in early pregnancy, so 20 to 26, 28 weeks, they are moving freely and there may be cord entanglement of both the fetuses. You cannot track how both the fetuses like they are going to survive or not. Even if we do daily ultrasound, you cannot prevent. But if I say at more than 31, 32, 33 weeks, then the risk of cord entanglement decreases because the fetal movement, they are not that much. And the second, here again, the cause is this fetal anomalies. Then third comes the TTTS or the treatment of TTTS. So there are many complications related to single fetal demise. What is the risk? Is either the death of the co-twin also, or the neurological sequelae even if the second twin survives, or the risk is of premature delivery. So what is the first commonest risk is the death of the co-twin. Again, the studies show it is 3 times more common in monochorionic than in diachorionic. So the other twin may also die. And another study, Hillman has given in systematic meta-analysis and review that it is 5 times more common that the co-twin may also die. This is because of the vascular connections from the one live fetus and the other has died. So suddenly the fluid, the blood from the live fetus suddenly goes into the dead and there is acute hypotension in the live fetus. So that fetus may die immediately. You cannot prevent. Even if you deliver the surviving twin, that damage has already occurred. So it's an acute hypotension. Then the neurological sequelae, which is another complication. In dichorionic, there is rarely, it's like much less common than in monochorionic. And that there are 2 theories, that one is ischemic theory. Because of acute hypotension, and the blood will not go to the live fetus, suddenly goes down to the dead fetus. And the second theory is the thromboplastin, and that means the placental bits, they go through the this AV malformation or vascular connection. This thrombotic focus goes to the surviving twin, and that causes the death of the neurological sequelae of the surviving twin also. So again, this is many times more common in monochorionic than in dichorionic. So but the important point here, the studies, whatever literature is available, they say after 34 weeks, there is not much difference in the neurological sequelae in monochorionic and dichorionic. So how early this neurological sequelae will occur? They may occur as early as 6 days. They may occur as late as 6 weeks. So even after the birth of the baby, this baby has to be followed because of late cerebral palsy, because manifestations or any ischemic damage to the brain of the surviving twin may manifest at a later newborn period. So all these complications, whatever they occur, these are because of ischemia, because of softening of the brain, because of liquefaction, cavitation, or even any other organ may be affected because of acute hypertension. There may be bilateral cortical necrosis in the kidneys also. So any organ of the surviving twin, because of shock in the other baby, this may be manifested. So another risk is a preterm delivery. Again, more common in monochorionic. And after 34 weeks, what literature says, there is not much difference because most of the time we terminate at 34 weeks. And how early the labor will start? This labor may start as early as, like we have abruption placenta that has led to the death of one fetus. It may start immediately. It may take 1, 2 to 3 weeks, or even months have been reported for the onset of the labor. So another risk is a maternal coagulopathy. Though we all are worried about this maternal coagulopathy, but no mortality has been reported in the literature. This is mild form of coagulopathy and it is mostly spontaneously corrected. there is not much worry about. But the things will be there. The fibrinogen levels will decrease, FDP levels will increase. So what we will do? Weekly fibrinogen level, platelet count, and partial thromboplastin time. But once we are terminating this fetus, we have to, like we are planning for delivery or planning for cesarean, then we have to go in for full coagulation of 5. So, how to manage obstetrically? This is a big challenge for all of us. In one side, we are keeping the fetus inside, thinking and in the intrauterine environment, the same environment will continue. The other risk of the surviving twin is there. On the other side, we have to weigh for the risk of the prematurity. So we all have to follow these steps, counsel the couple, give psychological support to the couple, have to manage each and every case individually, know the chronicity, amnionicity for termination, evaluate for fetal abnormalities if it is possible, steroid prophylaxis and max cell prophylaxis as usual we give, and conservative or early management has to go by case, and try to deliver vaginally if possible, and try to do post-mortem of the baby or the placental histopathology. But many a times post-mortem doesn't help us, histopathology doesn't help us because of autolysis of the products, autolysis of the placenta and the changes in the fetus. And the baby needs like long-term follow-up also. So what we have to consider for management: gestational age, presentation, condition of the live fetus, location of the dead fetus, and the mother is having preeclampsia, diabetes, or any other medical abnormality. So if the live twin is leading twin, like it's presenting low down, it is well grown, it is cephalic, prefer for vaginal delivery. If the live twin is having malpresentation, or it is growth restricted, or the dead twin is leading, go for cesarean section. So again, management will differ in dichorionic or in monochorionic or in monoamniotic. So we can delay management in dichorionic to at least 34 weeks unless there is no continuing pathology that can cause demise. Like a woman is having preeclampsia, you may have to terminate that pregnancy early. Of course, during this conservative treatment, you have to do intensive follow-up. Even RCOG recommends at 37 weeks. ACOG also recommends this expectant management. For MC, monochorionic diamniotic, counseling of potential this unfavorable outcome has to be done because of neurological injury. You have to do the fetal MRI after 3 weeks of single fetal demise. You may need to have intrauterine transfusion after doing fetal Doppler. For monochorionic, monoamniotic, risks are many, many times. So you may have to deliver this fetus at 28 weeks. Overall, we say in monochorionic, the prognosis is poor. In dichorionic, it's relatively better. So what is to summarize? It's the chronicity which is most important, and it is mandatory that determines our management. And you have to individualize, you have to counsel and support with intensive fetal monitoring. So with proper care, we should not have panic and deliver it immediately. So we can salvage many, many good number of babies. Thank you so much.
And that was a very nicely explained twins and the complications in multiple pregnancies. And we all come across, papricious, and I have seen like there was no indication of papricious even on ultrasound, and the body heals and corrects all the coagulation problems. And this thing, fibrinogen level decreases, thromboplastins are released, but still the body, usually we do not face many DIC problems in a twin when there is a device. And anomalies also are more common. We all must have come across like even neural tube and cardiac problems in one twin, especially so in monochorionic twins. So chronicity is like it's very important to determine that, and you really dealt very nicely with all the complications and how to do. Thank you so much.
Thank you so
Definitely,
much,
there is
ma'am.
no, no point in panicking and hurrying up delivery. If the other twin is doing well, and especially in chorionic, we can wait and allow the baby to grow well. If everything is fine, the pregnancy should be allowed to continue and deliver. So there is no point in hurrying up the delivery. Thank you, ma'am. Very
Thank you
lucid
so
and
much.
very clear presentation.
Thank you so
Your
much.
last 3-4 slides, summarized it very well.
Thank you so much.
Congratulations.
Psychological counseling is very important, as ma'am said, psychological counseling of the couple. Now, our next speaker is Dr. Dilpreet Kaur for Twilight Zone in second trimester anomaly scan. She is Professor, GMC Chandigarh 32 sector, and she has more than 21 years of experience in obs and gynae.
Thanks, Dr. Mani, for the kind introduction. Good morning, everyone, and respected chairpersons. So I'm going to speak on twilight zone in second trimester anomaly scan. Where we are in dilemma, we are not sure whether we should consider this as anomaly and terminate the pregnancy, or we should keep her on follow-up. So whenever a structural abnormality is detected, the questions obstetrician would like to know are: how severe is the anomaly? Is it lethal? Does the fetus having aneuploidy? What's the cause? Is it salvageable? And to describe these congenital anomalies, I'm going to discuss the malformations, which are the defects due to intrinsically abnormal developmental process. We have various major malformations which are going to affect the quality of the newborn or may be lethal. And minor may just cause some cosmetic problems, not much. So starting from the fetal head, traditionally a routine evaluation of the CNS is performed at 18 to 22 weeks. But now, because of the advances, fetal brain can be imaged at around 16 weeks completely. So first problem is when we get a report of ventriculomegaly. Normal limits between 15 to 40 weeks is 5.4 to 7.6 millimeter, and upper limit up to 10 mm is permissible. Further, it is classified as mild, moderate, and severe when it crosses 16 millimeter dilatation. So where is the twilight zone in this? The gray zone is that normal fetal brain is also quite sonolucent. It may simulate CSF, we may make incorrect diagnosis of ventriculomegaly. So careful evaluation by experienced sonologist is mandatory for the confirmation of diagnosis. But if it is actually ventriculomegaly, then causes can be severe infection, certain genetic syndrome, and may be associated with various other kinds of abnormalities and growth restrictions. So we should perform one detailed additional ultrasound at 28 to 34 weeks to look for all other abnormalities, determine whether this is regressing, persisting, or progressing. Measure head circumference to identify macrocephaly, which is a rare association, but if it is progressive, consult a pediatric neurosurgeon, may need shunting. Severe ventromegaly, neurological, motor, cognitive, all kind of impairment is likely. Survival rate is 88% and only 42% have normal neurological development. Mild to moderate, 90% are going to be normal. And persistence or progression is additional poor prognostic finding, marker of this entity. Next is ventricular asymmetry. If we get a report that two ventricles have a difference of 2 millimeter or more than that, if they are not crossing 10 millimeter in the maximum dimension, means likely outcome is going to be normal. Third one is isolated choroid plexus cyst. 1 to 2% of the normal population can have this, so it's a normal variant, usually disappear by third trimester. Even if it persists, it's likely to be benign, not associated with increased risk of aneuploidy. Choroid plexus cysts, they are sometimes at the risk of, if they have additional anomalies, then they are at increased risk of trisomy 18. So thorough anatomic survey should be done and non-invasive testing is recommended. Microcephaly, head size is smaller, at least 2 standard deviation below the mean can be present with various types of holoprosencephaly, and extracranial malformations are also associated with it. Next are corpus callosum malformations, often associated with both cerebral and extracerebral abnormalities. Corpus callosum takes the complete shape, final shape by 20 weeks. After that, it keeps growing up to 2 months after birth. But if absent, corpus callosum has correlation with various kinds of trisomies. And further, two important clues that corpus callosum needs further assessment is non-visualization of septum pellucidum, and if ventriculomegaly is associated, then we should look even more carefully. Now, what is cavum septum pellucidum? It's a fluid-filled cavity between the two lamina of septum pellucidum. Diameter is less than 10 millimeter, and it's not a part of ventricular system, does not communicate with it, it does not contain choroid plexus. Non-visualization, if it's before 18 weeks and after 37 weeks, it's normal. Mid-trimester non-visualization, you cannot say it's absent. It needs to be relooked carefully by the expert. Usually, it's very rare to be absent. Rarely the cavum septum pellucidum is obliterated or echogenic. Then in those cases, callosum is normal. Now the width in the normal fetus has linear correlation. As BPD keeps on growing, cavum also increases. Value increased from 3 to 6 millimeter near term. Dilated means important sonographic correlation with certain deletion of the chromosomes, and length is increased in hypoplastic left heart syndrome. If both are increased, then dextrotransposition of great arteries may be associated. So in those conditions, it's associated with neurodevelopmental delay. So it's very important to look at sonographically. Vermis, it completes its formation from cranial to caudal by 16 weeks or maximum up to 20 weeks. Sonographically, it completely closes the gap, leaving only a narrow passage foramen and megendie. Only that opening will be 2 to 10 millimeter in second and third trimester. In first half of pregnancy, if we get a report of relatively wide opening, it shouldn't be mistaken with the Vermeer dysgenesis or Dandy-Walker syndrome. We should relook at 20 to 22 weeks of gestation. Next is transcerebellar diameter. It's same as the gestation age up to 20 weeks, more than gestation age after this. If it's less than 2 millimeter, difference is more than 2 millimeter from the period of gestation, and it's less, then it's a matter of concern. Fetal face. Lens is opaque, means congenital cataract. We should demonstrate 2 nostrils and a separate intact upper lip. If the chin is also seen in the same image, micrognathia is ruled out, and mandible and maxilla are almost of same width. Nuchal translucency. It is said to be enlarged if it's more than 3 millimeter, and risk of aneuploidy and adverse outcomes is associated. Nuchal fold thickness, less than 6 millimeter up to 22 weeks is normal. It's very sensitive marker of trisomy 21, and also seen up to 2% of euploid fetuses. It also has association with the sex chromosome anomalies, which can be picked up with the cell-free DNA. So nuchal fold, even in the subsequent scans, may revert to the normal, but the risk of trisomy remains. So we shouldn't be mistaken that it was a false finding. If once it's more, then it is significant. Aneuploidy screening with non-invasive or diagnostic testing is recommended in this condition. Next is nasal bone. Its measurement is 4.4 at 18 weeks and 5 millimeter at 20 weeks. Non-visualization made in the euploid fetus may be a delayed maturation rather than it's totally absent. Shorter hypoplastic isolated nasal bone, likelihood of having trisomy 21 is increased by 6 to 7-fold. So aneuploidy screening by non-invasive as well as diagnostic testing is recommended in this condition. Next is fetal chest and heart. We should confirm visceral situs, internal cardiac structures should be looked into. Echogenic intracardiac focus. It's not associated with myocardial dysfunction, but it is, if it is diffuse myocardial calcification, then myocardial dysfunction may be there. Isolated intracardiac focus, otherwise normal detailed structural survey is a normal variant, especially if cell-free DNA screening is normal. But maybe an indicator of trisomy 21 and seen in 3 to 5% of euploid fetuses, that's the incidence. So non-invasive testing is recommended in this condition. If we get a report of fluid in pericardial sac, up to 2 millimeter, a thin rim, it's likely to be physiological, nothing to be worried about it. Next are fetal arrhythmias. Recently, I got a case. So these are the conditions which we frequently get. I have covered those. It complicates 1 to 2% of pregnancies. It has potential to compromise fetal health by compromising the ventricular filling. Fetal heart is functionally mature by 16 weeks. After that, rate is fixed and rhythm is regular. Fetal arrhythmias, if any deviation, we call it arrhythmias, and mostly it is an isolated finding. But if arrhythmias, tachyarrhythmias, then 10% fetuses will have structural function or functional heart disease, and in bradycardias, 50% are going to have some problem. So 2D ultrasound to diagnose arrhythmias, then evaluate cardiac anatomy and function properly. If there is any abnormality, refer to fetal cardiologist. If it's normal, keep her on weekly follow-up. Most likely it's going to resolve in few weeks. But what all we should monitor in this follow-up, we should look for the signs of hydrops fetalis, which means that is an ominous sign. Fetal heart close monitoring, mother should note fetal movements and evaluate for thyroid disease of the mother and avoid stimulants even like coffee and all. In fetal abdomen, image umbilical cord insertion to look for the abdominal wall defects. One common problem is we get a report of single umbilical artery. In this, a detailed anatomical survey is recommended. 4-chamber heart view with detailed anatomy of the great vessels should be done. Number, location, appearance of kidneys should also be documented. These are the specific problems which can be associated. And non-invasive conventional serum screening or cell-free DNA is recommended. Third trimester scan for fetal growth because there may be growth restriction. These are the common fetal anomalies associated with a single umbilical artery, so detailed anatomic survey is very important in this condition. Next are fetal kidneys. If we get a report of echogenic kidneys in early weeks, that is okay because they gradually become hypoechoic. And fetal ureters should not be ideally visible antenatally unless they are dilated. Persistent or absence of bladder in the by second trimester is abnormal finding. Dysplastic kidneys, they are large and bright. Rarely they are uniformly echogenic without cyst. So isolated multicystic kidney has a good outcome, but if it is bilateral involvement, then there's going to be severe oligohydramnios that can lead to pulmonary hypoplasia and guarded prognosis. Fetal pylectasis is a very common report we get. A normal renal pelvis is up to 4 millimeter in second trimester. Mild is up to 7 millimeter, more than 7, but up to. So in this routine, screening non-invasive is recommended in mild pylectasis because it's usually physiological and transient, resolves during pregnancy or in postnatal period, but in 12% it may persist. So follow-up imaging is recommended at 32 weeks, still persists, postnatal follow-up should be done. If it is severe dilatation, follow-up imaging care should be individualized based on the other sonographic features. Next one is megacystitis and large fetal bladder. If the longitudinal bladder length is more than 7 millimeter by the beginning of second trimester, it's maybe associated with chromosomal abnormalities and certain other urinary tract problems. If we see a keyhole-shaped large bladder, that indicates urethral obstruction. Hyperechoic bowel, increased echogenicity, association with trisomy 21 is known, but may also be seen in euploid fetuses, as well as sex chromosome aneuploidies, which can be again easily detected on cell-free DNA testing. Isolated finding, it's transient. In up to 72%, it regresses, but can be associated with certain fetal and pregnancy complications, including FGR and GI pathologies. So follow-up imaging in third trimester is recommended. If we see in the third trimester, there's appearance of an echogenic loop of large bowel. That is normal because meconium is now present in the colon and can be echogenic. Dilatation of bowel in length more than 15 millimeter, diameter more than 7 mm. It may be a sign of intestinal obstruction, whether mechanical or functional, so should be carefully looked into it. Now coming to the musculoskeletal system, if the long bones are slightly short, means ratio of observed to expected less than 0.9, then 13% may pick up, so those are false positive, but may be association with the trisomies or even euploid. So the shortened. If the humerus is short, that is a better predictor for this. So routine non-invasive screening is recommended, but if significantly short, then maybe association with the skeletal dysplasia, or there may be early onset FGR, or some aneuploidies may be associated. Lethality depends upon these findings. How much is the chest to AC circumference ratio compromised, and how much is the shortening of the bone? Next, our hands should open fully at least once during the scanning time. If remains clenched, associated with trisomy 18, and thumb should not be persistently abducted. Second trimester FGR aneuploidies have been detected in up to 1/5, 20% of these fetuses, so they should be carefully screened. And association with various aneuploidies have been found to be up to 30, 50, 90% in severely restricted. So take-home messages are optimal obstetric outcome can be expected by early initiation of prenatal care. Essential element of prenatal care is early detection of the malformation. That is the primary goal of mid-trimester anomaly scan. It can be achieved only by the interdisciplinary good coordination, and fetal karyotype is indicated when there are multiple structural malformation. Better to know the fetal karyotype during pregnancy, because in the course of pregnancy, if the IUD happens, then we may lose that DNA material for having the culture. And valuable information may be lost for the future counseling for her obstetric career. Thank you. Thanks a lot for your patient listening.
Wonderful, doctor. You put up wonderfully all the, in fact, you have covered all the systems, the skeleton, the cerebral, the cardiac, everything. And you have really covered all the anomalies, and also you've mentioned all the normal parameters. Thank you so much.
इसको
Thank you.
कहते हैं गागर में सागर
सागर,
भरना,
हाँ.
है ना? And you have covered all the relevant points and how to follow, which one are relevant, and they may be a variant of normal, evolution when the brain is evolving. So there may be many which may be a normal finding, but we may consider them as abnormal. So thank you very much. Excellent presentation.
Thank you, Dr. Dilpreet. Now our next session is amniotic fluid abnormalities by Dr. Manpreet Kaur Thalia.
Thank
Dr.
you. Thank
Manpreet
you.
Kaur
I think
Thalia is professor and head of department Obs and Gynae, Amin Medical College, Vijaypura, Karnataka. She has been chairperson of DAS committee, and she has more than 21 years of vast experience.
The next session.
yeah, you have to call the next chairperson. Thank you, organizers, for giving us this
Wonderful.
opportunity.
Thank you so much, man.
हाँ जी, आपका डॉक्टर फैसी सर, आपका पहले करवा दूं? Now I invite Dr. Fassi Lewis for the next session, Hysteroscope, the fourth eye. Dr. Fassi Lewis is Senior Consultant, Associate Professor in Charge, MCH, working in Department of Reproductive Medicine and Surgery, Amrita Ames, Institute of Medical Sciences, Cochin, Kerala. He has received Fogsi Korean Kamini Rao Yug Award, Imaging Science Award, Parveen Mehta Fellowship in Endoscopy, and Rudra Prize in Endoscopy. Anita Satyam, I नहीं Dr. Kavita आ गई ना? Dr. Kavita ma'am is here. The chairpersons for the session are Dr. Kavita Bhatti. Ma'am is professor and head of CMC department. She has more than 25 years of experience, and she is president of Ludhiana Menopausal Society. And our second chairperson is Dr. Anita Sabarwal. She is MBBS CMC Ludhiana, PG DMCH, Diploma Ultrasound, President Forum of Obs and Gynae in South Delhi. She has achieved Fogsi Champion Award and Wonder Fogsian, and she is working in Sabharwal Clinic, Govindpura, Delhi.
So we are feeling really very honored to chair the session where Dr. Fogsi, who is the Vice President of Fogsi, is going to give a talk. So we are eagerly awaiting.
Good morning to you. Thank you, chairpersons, and Foxy, especially the Ludhiana Society, Dr. Vidhu, Dr. Gidanjali, and Dr. Venus. In fact, there was some connectivity issues, so how persistent was Dr. Venus to insist that has to come, and thanks for the wonderful hospitality. And today's topic is histoscopy, fourth eye of the fertility specialist. Till this topic was given, I was considered as a third eye of the gynecologist. But when the name was given, I inquired. The meaning of the third eye is wisdom eye, and the fourth eye, the additional deeper level of vision. That is what the difference between third eye and then fourth eye. So let us look into that, how that is relevant to the histoscopy, especially into my practice of fertility. So to see the definition of histoscopy, it is uterus to view, that is derived from a Greek word. And as you all know, it can be done for diagnostic purposes and also for therapeutic purposes we can do. But the question is, should hysteroscopy be routinely done in the evaluation of infertility? The answer is no. And according to this RCOG guidelines and also the SHA guidelines, they tell among the basic essential tests for diagnosing infertility, hysteroscopy doesn't come. But hysteroscopy should not be considered as a routine investigation of the infertile condition. That was the RCOG guidelines recommendations, grade C recommendations. But the question is, should hysteroscopy be routinely done at the time of laparoscopy for the investigation of infertility? Let us see the evidence. There is positive hysteroscopy findings were found in as many as 15 cases, despite normal HSG and ultrasound, and no suggestion of intrauterine lesions, even from last 20 years back studies to present studies. And if you see, there is a big submucous myoma like this, you can see in the HSG, or if there is a submucous big polyp, you can see. But if there is a big additions in intrauterine like this, that you can see in the hysteroscopy. But if there is a small flimsy additions, you can see here it is a flimsy addition post DNC, or even if some lateral thick band of addition with the other part of the cavity which will be normal, which can be missed in the HSG. So for that we have to do the hysteroscopy. Or also, if there is corneal polyps or the small cervical polyps, that usually we will miss in the SSG or in the HSG investigation. So in most of the unexplained infertility, it can be because of a small endometrial polyp, small cervical polyp, or additions at the corneal cones, or the cervicorneal polyp will be there. So this can be diagnosed only by the hysteroscopy. So the question, and again, should hysteroscopy be routinely done at the time of laparoscopy for the investigation of infertility? The answer is yes. So when hysteroscopy should be done for unexplained infertility, whether it is at the laparoscopy, definitely yes. Before IVF, it's not always mandatory, but previously it was recommended after 3 embryo transfer or 10 good embryos. Now it is after 2 embryos to embryo transfer with good embryos if not conceived, or if something suspicious is ultrasound is different. Or after failed IVF. Some people tell after 2 failed IVF, or now because of frozen facilities there, we can wait up to 2 failed IVF to do a hysteroscopy if there is nothing is suspected. So hysteroscopy done at laparoscopy has low complication rate, high degree of safety, minimal time required, adds little equipment and cost. And indications, abnormal HSG, abnormal uterine bleeding, suspect intrauterine pathology, uterine anomalies, pregnancy wastage, and if you are before labeling as unexplained infertility. So indications is that there is no doubt if there is lesion suspected, we have to do that. So this is a picture of a hysteroscope done with a smaller scope without holding the cervix. That's why the vision is not, it is an integrated small system done immediately post-menstrual, that is ideal phase. We are going through the cervix. Once you are inside the internal LOS, you go inside the uterine cavity, immediate post-menstrual appearance. And once you are inside, we have to identify the ostia, both the ostia, and you have to see all the four walls. Now we have seen the posterior and upper part. Then you have to depress the scope and see the anterior part also. And under vision, we have to come out of the uterine cavity, including the cervical canal. That is the I just put to tell that basic hysteroscopic one video. So what are these hysteroscopic parts? It has got an eyepiece. It has got a barrel-shaped part, and it has got an objective lens. And depending upon the angle of the lens, it can be 0 degree, or if it is angulated, it can be up to 70 degree also. The difference is 0 degree has got a panoramic view. 30 degree or angulated means you will get a view at the lateral part, so the ostial vision is better. So there are different scopes. Are there rigid scopes? Is there flexible scope? Is there? And rigid is most commonly used. Initially, it was 5 millimeter. Now even 3 millimeter is there, or 3.5 with the continuous flow. That is, the difference is continuous means we can, fluid goes in and comes out, so that we'll get a better vision even if there is debris or bleeding or inside. And for resectoscope, usually it is 7 to 8 millimeter. This is a picture of a rigid scope. This is the outer part alone, and inner part alone, which is 3 millimeter. If it is connected, it is 5 millimeter. This is an integrated system. And even with the 5 millimeter, we can put the operative instruments through that. That is the main advantage of now the integrated system. And this is the older type of which has got a separate scope. Is there? You can see the separate scope inside. That is a separate one. The difference of the integrated system, vision may be slightly less, but you can have got a separate flow, so we get a better vision. For resectoscope, it has to be either 7 millimeter or 8 millimeter, where the operative instruments can be put into that. So office hysteroscope, which is a thinner scopes, 3 millimeter, it is very fragile, very costly. We have to handle very carefully. We cannot do much of the operative procedure except for biopsy with this office disposable type. And there is this flexible hysteroscope is there, which is especially to see the inside the uterine cavity. I have got no experience with that. And whatever be the hysteroscope, there must be good light one, that is single chip cameras. Now there are 3 chip cameras, and even higher definition cameras are there. And the principle of the distension media is that whatever fluid you are putting inside the uterine cavity, it distances the collapsed cavity of the uterine cavity, and that is the potential collapse space is being distended, and the fluid inside leaves through the cervix, leaves through the tubes, intravasate to the vessels also. So whatever be that, we have to maintain a pressure. Initially, people were using carbon dioxide, but it can be used only for diagnostic purpose. Because of gas embolism and carbon dioxide intoxication, we cannot use electric current with that. This is a picture of a carbon dioxide hysteroscopy for seeing the septum, but this only can be used for diagnosis. Because of complication, now nobody is using the carbon dioxide. But regarding the fluids, it can be high viscous, dextran, low viscosity, electrolytes or non-electrolytes. But most common is the electrolyte. Saline is the most commonly used. Also we can use ringer lactate, also can be used. And for if you are using a monopolar electric current, we can use the glycine also. But the most commonly used is the sodium chloride, which is isotonic, and the problem is that it is conductive. But we can use the laser and bipolar with that. That is the main advantage, but cannot be used with the standard monopolar current, cannot be used with the sodium chloride. In glycine, it is hypertonic, non-conductive. Better visualization is there, but the problem is that we must be very careful about the fluid overload, especially the hyponatremia in patients when it is metabolized into ammonia. So when you are using glycine, we have to be very careful about fluid deficit. It must not be more than 1 liter. But with saline, we can have a fluid deficit up to 2 liter we can have. Dextran, very few people use it because it damages the instruments. And here also you must be careful about the fluid overload. So whatever be the fluid, there must be a distension pressure to distend the uterine cavity. You can keep a fluid source about 100 centimeters above the patient's perineum. It gives about 70 millimeters of mercury. Or if a simple pressure cuff maintain system we can use, but which can maintain, somebody has to maintain the pressure. But most accepted, most reliable to do if you start in a good hysteroscopy practice, to have a hystromat. It can be either the imported types, or we can even the Indian types are there, which we have been using for last 15 years. So that is one advantage of using the Indian system also. It is not that costly. And when we are telling about energy source, it can be monopolar when we use the needle, hook, or resectoscope. And this, the left side, what we see is the electrodes, monopolar electrodes, which used in a smaller scope. What I showed the integrators is, this is for the resectoscope. Or and this I will show the picture of two videos. And this is the video of a septum being cut by the Collins electrode by using the resectoscope. Somehow the other videos, yes. And this is the other picture where the septum is being cut by the same smaller integrated system with this 4 millimeter. That is a smaller scope. Only thing, both the system, when you are using saline, you have to change into glycine. Here using Collins electrode, we can cut a little faster, but we have to dilate the cervix up to 7 or 8 millimeter. Here, we need not have to dilate. The same sitting, we just change into glycine and use the monopolar color. Only thing, it will cut a little slower. At the end, if you see, you can have a normal cavity. So if you are not anticipating, if you are seeing the septum during the time of surgery also, we can need not have to dilate and use that. If you have a smaller system, you need not have to use the resectoscope as you see in this picture always. And if you are using bipolar, there are two energy sources, Versapi and autocon. The principle of bipolar is that current travels from one part of the electrode to the other. That is what the principle of the bipolar. The tips can be different type. Even the loop electrode are also there with bipolar. We can use a resector, but it cannot be connected with the routine hysteroscope. It has to be attached with that particular hysteroscope. That is one disadvantage. We have to buy a newer system to use that. And the energy source has to be separate, like autocon or VersaPoint. And okay, and regarding the submucous myoma, this is the routine picture of a submucous resectoscope. Resectoscope is used for resecting the submucous myoma. You can see the myoma inside, and you can see the loop electrode. When you are using loop electrode, you have to see under vision from away from your scope towards you, so that you are inadvertently not perforating the uterus. And this second picture is a picture of a bipolar resectoscopy, bipolar energy source used to cut the submucous pedungulated myoma. If you are seeing a pedungulated myoma like that, don't jump and cut the peduncle first sitting itself, in the initially itself. Once you cut the stalk of the pedungulated myoma, the myoma will start rolling inside. So you have to cut, leaving a small tip of the peduncle there. Then you have to use the sponge and take it out, or you can use a resectoscope as you saw in the first clip. So that is I just put it to show the one is about how the bipolar current works. Second is that to about the submucous pedungulated myoma, you must be very careful in removing that. So this is a classification of the submucous myoma. Depending on that, we have to counsel. Sometimes you may have to go for 2 sittings, especially if it is a large myoma, or if it is not a grade 0. So what now we are following is the new Lesmer classification, where we see the position of the myoma, extent of the myoma, size of the myoma, how the topography. Together we give the point. This is a new classification of the Lesmer classification. And if the score is low, then we have to counsel that we may have to go for a second sitting afterwards, or we have to go for a laparoscopic setting. If you are doubt about the extension, we can do a saline sonus salpinga before the procedure and decide and go for a plan of action during the surgery. So energy source laser people are using abroad. I have no experience anybody in India is using that. Then there is mechanical instruments are there, scissors, forceps, grasper, everything can be used with the same histoscope. And regarding the polyp, it can be either the solitary polyp as you see in the first clip, where we can hold the stalk, avulse it and take it out, or if there is multiple polyp, either we can use resectoscope, then we must be careful, the endometrial damage will be more, or we can do a curettage, and afterwards if there is any solitary polyp is there, we have to remove that. The advantage is that at the end we can make sure there is no even a single polyp is inside the uterine cavity. And this is a picture of foreign bodies. This patient, first patient had a tubal corneal implantation using the proline, and proline was inside the uterine cavity. After 10 years, patient came for IVF. That cavity was irregular, and we had to remove that before going for an IVF in that patient. Second, this patient was secondary infertility. Cavity was irregular. Patient was secondary infertility patient. When we went inside, there was a bone piece inside. When you see the bone piece, you must be always try to do the histoscopy and try to remove rather than going for a curettage. When we do for a curettage, the old bone piece inside, it will get crumbled and go inside the uterine cavity, so that it will be still remaining inside. And afterward, once it get embedded, it will be very difficult to remove from the uterine cavity. Regarding tubal cannulation, most accepted is to use the Novi cannula. It has got an outer catheter with a stillet and an inner catheter with a guide wire with platinum tip. And here, first clip, you can see when we use the outer catheter and we push the dye is going, that will clear the mucus plug or some proximal obstruction. The second clip, this clip, you can see when we put the outer catheter and push, dye is getting leaked. Then you have to use the inner catheter with the guide wire. So that will clear the proximal block and make sure tubes are patent. Alternatively, people have used epidural catheter or ureteral catheter also, but Novi catheter cannula by the Cook is the most accepted. Even though it is designed for single use, people use for nearly 7 to 8 cases after autoclaving after each use. So if there is IUCD is misplaced in the uterine cavity, the advantage of histoscope, you can see that and make sure none of the limbs is embedded into the uterine cavity. If it is embedded, you can try to, when the cavity is distended, we can release that limb inside the uterine cavity and then take it out rather than again pushing the limb into the uterine cavity. So that the removal will be difficult. So in difficult IUCD removal, if you cannot just remove just like that with any artery forceps, better to always do histoscopy. So we are under vision, we can remove that, making sure that any limb is not embedded into the uterine cavity. To sterilization, usually it is done under Cydex solution for 20 minutes. Usually no anesthesia is needed, paracervical block or mild sedation can be given. Or if you're combining with laparoscopy, you can go for general anesthesia. It's a usual position, OT settings. And contraindication absolute is current or recent genital infection, profuse uterine bleeding. And I'll just conclude with two more slides. Recent innovations is the chip evacuation system. If there is fibroid, this is one by the Richard Wolf company. There are chips that it is being evacuated continuously. So otherwise we have to remove it and remove the myoma pieces at the end of each resection. Another thing is that hysteroscopic morcellator. The advantage is that if there is a, wait a minute. Okay, even if there is a big submucous myoma, this is a fast-forward version. We can use a hysteroscopic morcellator, just like a nasal debrider. We can debride using the morcellator, no need to change into glycine. We can use it with saline. The only problem is that this hysteroscope morcellator cannot be connected to your system, your hysteroscope. It can be connected to that particular two companies which has brought it. So we have to buy their hysteroscope. That is one drawback. We cannot take them and buy that and connect to that. That whole histoscope system is now costing nearly 25 lakhs. That is the only problem. But even if it is a big submucous myoma, we can resect it using the hysteroscopic morcellator. If it is small polyp, it is much more easy. It is just little fast forward video. Otherwise, it is not so time consuming. So that is the main beauty of having hysteroscopic morcellator if you have in your armamentarium of histoscope. And this last slide, whatever we are, if you are suspecting any lesion inside the uterine cavity, we must make sure you are inside the cavity, especially if you are suspecting polyp, false track or the intrauterine adhesion. This patient had suspected intrauterine adhesion and done intrauterine adhesiolisis from some other center. When they came, when we did histoscope, this was the normal cavity, and what we saw this down was the false cavity. So if you are suspecting intrauterine adhesion, make sure you are inside the uterine cavity by identify the ostia and then only do the adhesiolisis. Otherwise, you will be producing false cavity. As a panoramic view, this looked like a septum. This is one part of the septum, and this was the down. What we saw was the false cavity, iatrogenic false cavity, and this was the normal cavity. So histoscopy, when done by proper technique, incorporating latest technologies, is a simple, valuable, and precise diagnostic and also therapeutic tools in the hands of gynecologists. We are seeing just like a fourth eye for your gynecology practice. Thank you for patient hearing.
Thank you, Dr. Fessi, for such a comprehensive talk on hysteroscopy. It's a very vast topic, but you have covered almost all the basic which is required. I just had a question, whether IVF, before IVF, each cycle, would you recommend hysteroscopy or for recurrent implantation?
No, I don't recommend routinely because the usual implantation is limited. So since it is a small invasive procedure, it is not recommended. Initial recommendation was to do it after 3 embryo transfer or 10 good embryos. Now it is changed. Now it is 6 good embryos or 2 embryo transfers if it is done and not getting conceived, then you have to go for it. As a routine part of IVF, it is not at all recommended. There is no data supporting that. But in recurrent implantation failure or recurrent IVF failures, then it is indicated. So only thing is that doubt is that whether after 1 IVF embryo transfer or 2 embryo transfer. But all the literatures tell that after 2 IVF embryo transfer, if you don't conceive, provided no other suspicious lesion in the ultrasound. If there is suspicious lesion, definitely we have to go before that also.
And one more thing I have noticed, sometimes hysteroscopy we do and the patient conceives.
Patient?
Like conceives if
Yes,
the
yes.
tubes are unblocked. And I think there's a flushing effect.
No. Two
Which,
things are there. It is just like as you told, the flushing effect of the because under pressure, if you are doing the proximal blocks, mucus plugs will get dislodged. Second thing is that just like an endometrial scratching, even though larger studies is found, it is not very useful, but definitely it has got some effect. That's why still some people are doing, even I do endometrial scratching before all embryo transfers. So the same effect will be there when we are doing hysteroscope, that endometrial, that stimulation effect will be there. These two
I
things
used to
together
think,
will
with tubes, the submucous collections would get dislodged and then
more than collections, the endometrial scratching effect plus the proximal tubal opening up effect. About 25 years back, when I was doing PG, there at that time there was no hysteroscope. There the routine, it was a practice to do hydrotubation for the infertile patients, and a lot of patients conceive. It is the same principle. The proximal tube will get the mucus plug will get dislodged, plus endometrial stimulation effect will
even
be there.
after HSG they conceive.
Yes, same.
And endometrial scratching you still recommend?
I still recommend because it is not an invasive procedure. You need not have to give an anesthesia. It is a simple procedure. In your trial transfer, we are doing it. With the same trial transfer catheter, we can do it. So it is just a simple, even a 10-second procedure. So there is no harm in doing that. If something is very expensive, somebody need additional procedure, that is okay. Anyway, we are doing the trial transfer procedure for all IVF patients. So it is, we can do it along with that.
In the pre-IVF cycle, I think.
Pre-IVF cycle. Usually in the previous cycle, that means if you are doing the down regulation, we can do at that time. Or now I modified into do it that before starting the stimulation, I do that. So once the patient get periods in second or third day, if you make sure endometrium is thin, at that time you do the trial transfer. And if it is okay, only we start the stimulation. Before at the same sitting, we can do a small trial transfer with the same ET catheter we can do.
We had a girl who, Dr. Elima was there. She did a thesis on endometrial scratching.
Absolutely. Those patients who did the endometrial scratching, there is no statistically significant benefit.
Yes.
But all the studies tell there is some benefit. At least there are data to tell that even in the recurrent implantation failure patients, there is benefit. So why don't you give that to the other patients also? Because it is not an additional procedure. No?
Thank you so much.
Thank you, sir. And I think I take the opportunity to. Oh, जी, आपको पूछना है?
Very good lecture. My one question.
Yes.
That if you find a very good triple line endometrium on ultrasound, then should we go in for hysteroscopy in infertility, or
No.
should go ahead
No.
with the IUI and all?
Definitely no need. Even if you see a good, that has to be case based. Not, I am not talking about the IVF part. Even for the routine IUI cases, if you are seeing good triple line endometrium, then you have to individualize the case, whether how was the male factor, whether what all the treatment she has taken. If you are done already is done for a lot of ovulatory stimulations and the semen factor is reasonably normal, definitely there is a role for doing the either HSG or SSG. So each thing you have to see. Suppose if there is already they have done already SSG is done.
HSG is normal, but
Then there
otherwise,
is, and already you have done semen factor is normal, already ovulation induction is done. Then definitely there is a role to go for a histolaparoscopy. During laparoscopy, definitely you have to, infertile patients, you have to combine with hysteroscopy. Again, it is not an additional, already the patient is giving anesthesia. So you need to have an hysteroscope in your OT, that's enough. If you don't have a separate hysteroscope, you can buy the cystoscope from your urology friend also. That
no, I
also,
have hysteroscope, but I just want to know if there is a triple line seen very good on ultrasound, then any role of hysteroscopy beside other factors?
No. Even that's what data I showed. No, there is a 15%. Even if nothing is suspected, you can get a small lesions like corneal polyps or cervical polyps or flimsy adhesions can be seen.
Right.
So definitely, if you are going for to labelize unexplained infertility, or if you are going to do a laparoscopy, definitely you have to combine with hysteroscopy in those patients.
Right. Thank you.
Thank you, sir. It was really, truly indeed very informative, very stimulating, and interactive session. Thank you so much.
Thank you.
Thank you, sir. Fessi Lewis, you made it sound so simple and lucid, clear. I invite the next speaker, Dr. Anita Rajoria. She's head of department and senior consultant, Department of OB-GYN at Dr. Hegdewar Arogya Sansthan, Government of NCT, Delhi. And she has 32 years of experience with a lot of achievements like the Abdul Kalam Achievers Award. Madam has a heart of gold. Yesterday, when we started the early morning session, she was very prompt to help us out by chairing some sessions and put Jan into the sessions. So, Madam, we would like to listen from you on adolescent nutrition. And this is the burning topic of the day because we have so much of PCO and so much of sedentary lifestyle, and this is going to lead to a totally different scenario of obstetrics and infertility and antenatal periods when these children grow up. So here the mic is for you now.
Good morning, dear friends. Thank you, organizers, for giving me this opportunity. And my dear friends chairing the session. Today, I have been assigned the topic nutrition in adolescence. The relevance, ma'am has already told you about the relevance of the same. Now, what is adolescence? It is a period of development that begins at puberty and ends in early adulthood. It is divided into 3 developmental periods, and we are going to deal with early adolescence, which is 10 to 14 years, and late adolescence, 15 to 19 years. Then the adolescent is evolving into young adult, which is 20 to 24 years. Adolescence is marked by physical and sexual maturation, social and economic independence, development of identity, acquisition of skills which are needed to carry out adult relationships and roles, and the reason, the capacity for abstract thinking. Physiologically, early adolescence is dominated by puberty and sexual development, While late adolescence, it is characterized by pubertal maturation, but less obvious than early adolescence. Young adulthood, they correspond to the adoption of adult roles and responsibilities. In some poor populations, the initiation of puberty may be delayed and its duration is often extended. Whereas in other populations, the well-fed ones like US, the initiation of puberty may be advanced, which appears to be related to body size and body fat mass. Adolescence is characterized by rapid pace of growth that is second only to infancy. Nutrition and adolescent transition are closely intertwined since eating patterns and behaviors are influenced by many factors. We'll be discussing them like peer influences, parental modeling, food availability, food preferences, etc. Epidemiologically, the age group about 10 to 24 years is the quarter of global population, and it is the healthiest population, and this is the group which is best able to raise the economic productivity of the resident country. In 2012, there were around 1.8 billion adolescents in the world, and 90% of whom lived in low and middle income countries. Now, our child survival initiatives have been successful. So we have seen dramatic rise in adolescent population, especially in low middle income group countries, making this is the largest generation of younger population in history ever. It is a period of rapid growth, and failure to achieve optimal nutrition may lead to stunted growth, delayed growth, and impaired organ remodeling. Now, we all know that iron deficiency anemia is so common, and it is the leading cause of years lived with disability among children and adolescents. And it affects an estimated 619 million adolescents in 2013. While undernutrition, which includes wasting and stunting, is on the decline in children less than 5 years of age, there is growing concern about increasing rate of overweight and obese adolescents and children. Now, we all know that overweight children or adolescents, they have multiple immediate and long-term risks, including raised cholesterol, triglycerides, type 2 diabetes, hypertension, etc. Now, as a low middle income country, we are facing double burden of malnutrition. One is the increasing incidence of overweight and obesity among our adolescents, while on the other side of the coin is undernutrition in children and adolescents. So it has developed a growing interest in adolescent nutrition in developing countries to improve the health of women and future generation of children, because we understand that they are going to be the future mothers, and this will impact the health of the next generation also. What are the current trends? We should understand that body size during adolescence can be used as a proxy for nutritional status. Overnutrition manifesting as overweight and obesity, while undernutrition, it manifests as stunting or wasting, and there may be nutritional deficiency, and there may not be any change in the body size. This is known as hidden hunger. So the global burden of disease is there: protein, energy, malnutrition. It is amongst the top 10 causes of death among children and adolescents. Global nutrition trends in adolescents have shown that overweight and obesity affect 1 in 3 adolescents presently worldwide, and most of the overweight children live in low and middle income countries. Prevalence of underweight among adolescent females, it is around less than 5%, but in some low middle income countries like Africa and Asia, around 10% of young adolescent girls are too thin for their age and height. So we have seen that half of the adolescents may be stunting, which is a reflection that there is persistent and cumulative effect of growth retardation from an early age. There are micronutrient deficiency because of their increased nutritional vulnerability, because we know that they are not careful about their nutritional intake. Iron deficiency anemia, I've already talked about. Similarly, iodine deficiency disorders, they are also a major concern. Now, let us understand a bit of physiology of growth and maturation. So, maturation of the body owing to hormonal changes during adolescence leads to dramatic changes in body composition. The maturation of sexual organs is there, but it is also, the growth is also reflected in the lean and fat body mass. The puberty usually takes between the ages defined during adolescence. Sometimes adolescent can start even as early as 8 years, and it can extend up to the 19 years. We should understand that pubertal sex hormones and growth hormone, they generally increase together and are responsible for enhanced skeletal growth as well as sexual maturation. 50% of adult body weight is gained during adolescence. There is associated bone mass, muscle mass increase, blood volume expands, heart, brain, lung, liver, kidney, they all increase in size. During infancy, the growth rate is very high, and adolescence is the second in which the acceleration of growth is there. So nutritional requirements automatically are very high, and if there are deficiencies, the adolescents will suffer. And current evidence suggests that adolescents grow in definite, distinct spurts. Now, why I'm talking about sleep patterns? Adolescent sleep patterns are characterized by natural propensity to stay up late in the evening, and they are sleeping late in the morning. And it has been argued that chronotype of adolescent, it will reverse gradually. We have often seen that adults wake up naturally at earlier times, marking the end of adolescent period. The reversal occurs at a younger age in the girls than in the boys. Talking about sleep in a nutritional presentation is important because robust nutritional support and opportunities of adequate sleep are considered important, especially for workforce who are forced to sleep out of synchrony with their natural clocks, and they may not be having enough of nutrition along with that. The timing and duration of body composition changes are linked directly to the sexual maturation. So, the nutritional requirements will depend more on sexual maturity rather than the actual chronological age of the adolescent. Now, metabolism. We all understand that metabolism is directly related to the total energy requirement and indirectly to growth, and consists of energy cost of growth, basal metabolic rate, and activity energy expenditure. We all need, energy or calories for this. Energy cost of growth is important in adolescent. Similarly, BMR and activity energy expenditure has to be added to it. So if we see this graph, the lower dark black part is the basal metabolic rate, for which the calorie requirement is there. And the upper part, it is reflecting active energy expenditure, which is required for routine activities and carrying out exercise and other physical activities. And then additional requirement is for energy cost of growth. During adolescence, because of growth spurts, they need a lot of amino acids for growth of striated muscles, calcium and vitamin D to accommodate the bone growth. So the energy and nutritional requirements, they must match the needs of adolescent. We should take it as a point that appetite is increased during adolescent. And if the adolescent is sedentary and the lifestyle is not including exercise, they may gain weight if they are using high energy food. So low activity levels among adolescents is a key factor which is responsible for increase in adolescent obesity across the globe. Males have higher caloric requirement because they achieve greater height, weight, and lean body mass than girls. Dietary recommendations suggest that 50% or more of total daily calories, they should come from carbohydrates, and sugars like sucrose and fructose should not make more than 10 to 25% of the calorie intake. Protein requirements per unit height are highest for females in the age 11 to 14 years, while for males it is between 15 to 18 years, which is corresponding to the peak height velocity. Means they gain height during this phase of life. So dietary reference intakes are there. Different societies have given different reference age for calcium, iron, and we should give additional iron for the girl with the onset of menstruation because it imposes additional iron requirement. Similarly, recommendations for zinc, vitamin A, E, C, and folate are there, which is displayed in this card. The energy requirements, you see that as the age is increasing, even females and males both have increased calorie requirement. While carbohydrate remains almost constant, the PUFA and MUFA allowances are also there. Protein intake, you must see that with increasing age, the protein requirement is increasing because they are gaining muscle mass. Now, recent systemic reviews have shown that nutritional interventions for adolescents, that micronutrient supplementation among adolescents can significantly improve or decrease anemia prevalence in the society. Now, we cannot leave adolescents without talking about pregnant and lactating girls. Nutritional requirements for adolescent pregnancy, we should appreciate that 16 million babies are born annually to adolescent girls between 15 to 19 years of age, which accounts for over 10% of total births per year. So adolescent fertility is 3 times higher in low middle income countries owing to various contextual factors like we have traditional early marriage practice, poverty, lack of education, employment. Then there is restricted access to the care, healthcare, weak health systems, abuse, domestic abuse, unplanned or unwanted pregnancy, and there is absence of autonomy or social support for these girls. Now, what happens when the adolescent mother gets pregnant? There is competition of nutrition between the mother and the fetus which is growing inside her uterus. If we find that their nutrition was sufficient, the adolescent girl will keep on growing. But if there is nutritional deficiency, the pregnant mother may have stunting of growth. It was seen that when energy was constrained, the physiology of younger adolescents invests in growth, while older adolescent females, the calories were turned into adipose tissue, which were important for the reproductive function of the mother. So there is permanent stunting of these mothers if nutritional requirement is not enough. Adverse neonatal outcome are there, and poor postpartum outcomes are there. There may be permanent weight retention also in these girls. So there are so many perinatal morbidity and mortality which is associated with this undernutrition of a pregnant adolescent mothers. They give low priority to their nutrition because they are not aware or they do not have access to the good nutrition. Similarly, for lactating mothers, the nutrition requirement is more in this particular physiological stage of life cycle. because requirement for micronutrients is also very high. And we know that if we improve the nutritional status of pregnant and lactating mother, it will statistically improve the perinatal outcomes. These are the dietary allowances for pregnant and lactating adults. I will not discuss for the paucity of time. So, the one carry home message is that teenagers usually have less incidence of preeclampsia until unless they are overweight. If the mothers are overweight or obese, these adolescent girls will have higher incidence of preeclampsia. Now, that is why the obesity concern is an important health implication to be considered for current and future generation. There is global trend for excessive weight gain, and we have seen that mothers who have given birth to babies, they have changes in their heart. They have greater relative wall thickness, reduced left ventricular and diastolic volumes, etc. So the perinatal mortality is also very high. And the child which survives or the survivors, they have permanent health implications like hypertension, early onset renal disease, type 2 diabetes, mental disorders, and other chronic conditions. Now, behavior also affects. I discussed this in earlier part of my presentation. Personal factors, environmental factors, macro system trends like food availability, food production of the country, distribution system. All these affect the nutritional behavior. And moreover, adolescents, they do not eat at home. We all must be facing this problem with our growing children. They want to eat out. So their nutrition is improper and inadequate. There is trend towards eating fast foods. We all know that this has led to obesity. Then another thing is smoking, drinking, and illicit drug use. What this will do? They will not let the adolescent have proper nutrition. So this also contributes. These bad habits, I may call, they also contribute to poor nutrition. Then girls suffer from anorexia nervosa. It is more common in adolescent girls. So these are the various factors you see from the base. If you see that there is typical eating style, eating disturbance, cultural patterns, then they all influence the mother for the psychological factors leading to poor nutrition. Socioeconomic factors also contribute to poor dietary intake, then repeated pregnancies, early pregnancy, livelihood factors, all this contribute to malnutrition, leading to the permanent problems in these adolescents. So we have to take into relevance the social context of the nutrition also. These are the some future areas which need to be investigated because it's a time for catch-up growth, and we must give proper attention to their nutritional requirements. What are the modifiable predictors of adolescent nutritional practice? What is the physiology of pregnancy? Impact of nutritional practices? What is the effect of growth spurt? And how the child is developing final height? All these need a good study. Puberty, onset, development, how it is affected by nutrition, how sleep and activity patterns, they affect adolescent nutrition. So if we provide adequate nutrition in time, will there be healthy reversal of stunting? Or how a poorly fed child, if given proper nutrition, there is augmentation of brain development. So these are some areas which need to be explored further. So thank you so much. Hope I have given you enough food for thought. Thank you so much, organizers, for this opportunity. Thank you.
Thank you, Dr. Anita, for such a wonderful presentation. And it was very interesting to note some of the points which we don't pay attention to, particularly to your slide on adolescent sleeping pattern.
Yeah.
So that was very interesting
So
point.
these things are all interrelated, because if the child is not, sleeping in time, he will sleep throughout the day. He'll get up at 12 noon. So he will skip one meal. So these things are important. And social factors, they are also very important in nutrition of adolescent. And we must pay due attention because these adolescent girls are going to be the future mothers, and this will impact the health of the future generation also. Thank you so much.
Thank you so much.
I'll be happy to take any questions from the floor. Thank you. Thank you so much.
Thank you,
Thank you,
Doc.
organizers, for this opportunity.
Thank you, Dr. Anita, and especially for representing our Delhi here. So we are really proud of you for speaking on such a great topic. Thank you.
We have amongst us Dr. Madhuri, who is the Secretary General of Fogsi. Please give her a hand. Madam is to depart now because of time constraints. So we wanted to take this opportunity to honor her. Dr. Vidu, Dr. Gitanjali, Dr. Venus, Dr. Manu, and myself.
Thank you very much. Mobile से say something. Yes, mobile से
Mobile mic.
ये लो.
Ma'am, we would like you to bless us as we wish you a safe journey.
Thank you. Hello, I'm really honored and I'm humbled to say that I got so much of love from the Ludhiana society and entire Punjab society when I came over here. Excellent hospitality, and I must appreciate Dr. Vidu, Dr. Gini, Dr. Venus, and Dr. Gitanjali and everybody of you, for giving me so much of, love, and hospitality is fantastic. I really enjoyed. I had never traveled to Ludhiana, so I said I take this opportunity to travel to Ludhiana, and then I'm going to Amritsar. So that is also another, advantage to me. And that's, on behalf of everybody, I will definitely pray for everybody. And I must say the conference is organized such a nicely, very well organized. All those, yes, and the scientific sessions are also very good. And everybody, has traveled, and because of your love and affection, everybody has traveled all the way to Ludhiana. And I must appreciate all speakers, moderators, chairperson, and panelists. And of course, without delegate, we cannot have this program. So I'm really thankful as a Secretary General to all of you, and you are most welcome to AICOG, and whenever which we are going to have it indoor. And one more thing I would like to mention, that elections are going on. Whoever has not received the link, we have given number, that is my number. Please call me and we'll do the needful. And AICOG and many things are coming up now, because now the physical activities have started. So see you, and I'll be happy to see all of you again. Thank you very much. Thank you.
Ma'am, we wish you a safe journey.
Thank you.
Thank you, ma'am. Thank you so much.
Blessings.
And I take it as an opportunity to request you for vote for chairperson medical committee. Yes.
Moving to the next session.
हाँ जी हाँ जी क्या अच्छा जी ठीक है बस मैम आपका मैं अनाउंस कर रही हूँ Now we will be proceeding with our next session, AUB Recent Advances by Dr. Shilpa Singh. She is Associate Professor at KGMU Lucknow and more than 10 years of post-PG experience. I invite Dr. Shilpa.
Good morning, all of you. I am Dr. Shilpa. I am presently working as Associate Professor in KGMU. As we all know that AUB is a very vast topic and some recent changes have taken basically in nomenclature and some in treatment. I'll treat the topic in toto with a special stress on the recent advances. So as we all know, AUB is defined as bleeding from the uterine corpus that is abnormal in regularity, volume, frequency, or duration, and occurs in the absence of pregnancy. Its prevalence is 3 to 30% in world, and India, it is around 17.9%. Approximately 1/3 of the patients we see in our OPD are AUB patients. So we will focus on changes which have occurred in terminology, the approach of AUB which should be changed as per the correct scenario, and the changes in the treatment which have occurred. So the revisions were first published in 2007, and then there were updates in 2011 and 18 by FIGO. The FIGO system first defined the abnormal uterine bleeding, then they give an acronym for the common etiologies. The FIGO AUB System 1 defines the parameters of normal menstrual bleeding, and it establishes a mechanism for defining the various symptoms of AUB. Now, the terms menorrhagia, oligomenorrhea, metrorrhagia, and AUB are obsolete. AUB System 2 is for palm coin system, and it provides a structured infrastructure for research, education, and clinical care by categorizing the various possible causes. So AUB is classified as acute and chronic. In acute and chronic, we have intermenstrual and heavy menstrual bleeding. AUB is defined as heavy when there is excessive menstrual bleeding, which affects the patient's quality of life. And intermenstrual bleeding is bleeding which occurs between the clearly defined menses. AUB is acute if it requires immediate intervention to prevent further blood loss, and chronic if it has been present for the last 6 months. To know abnormal, we have to know the normal. So the frequency is considered normal when it varies between 24 to 38 days. The duration is prolonged if it occurs greater than 8 days. The regularity is defined as per age, and the shortest to longest cycle variation should be between 7 to 9 days. The flow volume can be light or heavy. Intermenstrual bleeding can again be classified as cyclical or acyclical. Unscheduled bleeding is for patients who are on steroids, progesterone, estrogen, gonadal steroids. So what has occurred in 2018? Now amenorrhea is considered part of this classification. And regularity, as I have told, it has been now defined as per the age using the 75th percentile. So if the variation between shortest to longest cycle is less than 9 days in 18 to 25 years, less than 7 days in 26 to 41 years, and less than 9 days in 40 to 45 years, it is normal. Duration is normal if less than 8 days, prolonged if greater than 8 days. Volume is defined as heavy and light. Heavy when it interferes with the woman's quality of life, physical, social, emotional, or material. Intermenstrual bleeding is a spontaneous bleeding occurring between the menses, and it can be cyclical. In cyclical also, it could be mid-cycle or premenstrual or postmenstrual or acyclical. Now the AUB system 2, what has happened in 2018? Now in AUB-A, the sonographic diagnostic criteria has been refined, which I'll just discuss. In AUB-L, the type 3 submucous myoma, which was previously considered in others, has come in the submucous category. So what we can see here, that this type 3, it was previously in other classification. Now it is in the submucous category because it causes AUB in many patients. For AUB diagnosis, we have a MUSA criteria in 2015, and now the adenomyosis reporting has to be done under the headings of if whether the uterus is globular, whether it's asymmetrical thickening or presence or absence of myometriosis, hyperechoic islands, fan-shaped shadowing, endometrial, subendometrial echogenic lines, translesional vascularity, irregular junctional zone, or interrupted junctional zone. So whenever we suspect adenomyosis, we have to look for these features for making a diagnosis of adenomyosis. In AUBC, AUBC now excludes any anticoagulants if the anticoagulation is cause of AUB. AUBI now includes all iatrogenic processes, including anticoagulants and those that interferes with ovulation. AUBO, I have already told that the diagnostic threshold have changed as per the age, and now ovulation interfering drugs are excluded from AUBO. In AUBN, N is now not otherwise classified instead of not yet classified. So it includes AVM or isthmocele. What is isthmocele? Isthmocele is very important in today's time because of increase in incidence of cesarean scar. Whenever patient with AUB with lower cesarean section comes to you, you have to consider isthmocele as a cause. It is a myometrial defect resembling a pouch on the anterior wall of the uterine isthmus. And once it is diagnosed, the treatment is simple resection. So AUB, for AUB, this is particularly true. If you listen to your patient, you will reach the diagnosis. Every symptom, every sign leads to the diagnosis. So whenever you evaluate AUB, first assess the hemodynamic stability, diagnose the bleeding pattern, because bleeding pattern will decide which tests to order. Go for detailed sexual history to diagnose pregnancy, STIs, any obs and gynae history surgery for cesarean scar defect or recurrent myoma or recurrent cervical neoplasia, contraceptive history, medical history for bleeding disorder, thyroid disease, hyperprolactinemia, hypothalamic dysfunction, medication history for anticoagulants, hyperprolactinemic medications. Go for a detailed bleeding disorder screening if you are suspecting if the HMB is present since menarche, or if one of the following is present: PPH, surgery-related bleeding, bleeding associated with dental work. If two or more of the following are present: bruising, epistaxis, frequent gum bleeding, or family history of bleeding disorder is there. If any of these are present, then only go for bleeding disorder tests, not in every patient. Similarly, endometrial cancer risk factor screening is very important to decide which patients needs endometrial cancer screening, whether by ultrasound or by biopsy. In physical examination, look for the site of bleeding. Many times, if we don't examine the patient properly, we can miss the cause of bleeding and miss the treatment. The current status of bleeding, whether she requires immediate intervention, the size and contour of uterus, presence of adnexal mass, all of this will lead to the diagnosis. So when we have a primary evaluation, we now know which test to order. So every patient doesn't require a CBC or a serum TSH. It depends on the symptoms and signs. So if symptoms and signs are going for leiomyoma, go for pelvic ultrasound. If they are pointing towards adenomyosis, then go for pelvic ultrasound. If there's a bleeding disorder, then go for von Willebrand factor or ristocetin factor deficiency. If the history is going for endometrial CA, go for sampling. If there's endometrial polyp, go for hysteroscopic, go for ultrasound or saline infusion sonography. If there is endometrial cancer sampling, and this is especially all of these etiologies cause intermenstrual bleeding, and we have to go for tests accordingly. If the patient has irregular bleeding, go for and the other symptoms and signs are all pointing towards PCOS or hyperprolactinemia or thyroid disease, then do the respective tests. Not in every patient needs a serum TSH or prolactin. If the patient has come with secondary amenorrhea and the symptoms and signs are all leading towards ovulatory dysfunction, assess that. If you are suspecting hypothalamic amenorrhea, then only go for FSH, LH, and estradiol. If you are suspecting primary ovarian insufficiency, go for FSH. If your examination is suggestive of cervical stenosis, assess accordingly. If there is history of signs of any infection or DNC, suspect intrauterine adhesions and go for hysteroscopy. So everything has to be directed as per the symptoms and sign. Now the thing is, endometrial screening should be carried for which patient. This is very important because we have to screen them properly, then only we will go for the right patients. So it has to be done in every postmenopausal patient. The primary screening test is TVS. If there is a thickened endometrium, then only go for biopsy. If the patient is age 45 years to menopause, and if bleeding is frequent, heavy, or prolonged, then go for assessment. If there is intermenstrual bleeding and it is ovulatory, go for assessment. In patients younger than 45 years, who should we screen? Any patient with BMI greater than 30 or equal to 30 should be screened. If BMI is less than 30 and one of the following is present, that is chronic ovulatory dysfunction, unopposed estrogen exposure, failed medical management, or high risk of endometrial cancer, or premenopausal symptoms with 6 or more months amenorrhea, or when we are monitoring a patient with known endometrial hyperplasia, go for screening, or the cervical cytology results are coming atypical glandular cells, then we have to go for screening. In this, I like to add that endometrial aspiration is the preferred method, and as per NICE guidelines 2016, hysteroscopic biopsy should be undertaken if discrete focal lesion or hyperplasia is present. Otherwise, it is not required. It is definitely a very sensitive test, but should be selected in selective patients only. About pregnancy test, I'll like to say that it should be done in every case of AUB, even those with recent bleeding, with no sexual activity, and those who say they are on contraception, because if it is missed, it will be a great problem. So UPT should be done, and even if negative and you are suspecting early pregnancy, go for serum HCG, and if serum or urine test is positive, evaluate for pregnancy-related cause of bleeding. It will change the management entirely, so UPT is a must. Coming to the treatment, first we have to focus on the choosing a treatment, then primary etiologies which can be easily treated, and then AUB, E, and O, which first require medical management, and then we can go for a secondary approach. So AUB of benign etiology, treatment depends on following factors: the etiology, how severe is the bleeding, what are the associated symptoms and issues, what are the contraceptive needs, what are the medical comorbidities, where there is underlying risk of venous thromboembolism or not, patient preference regarding as well as access to medical versus surgical and short-term versus long-term therapy. All these have to be considered. It is very important that treatment is not initiated until etiology of AUB has been evaluated and pre-malignant or malignant disease excluded as required. Empirical treatment without evaluation may miss a primary etiology that may be corrected or mask symptoms of neoplastic disease. For acute AUB, the treatment is clear. We can go for intravenous estrogen or multi-dose COCs or multi-dose oral progesterone or tranexamic acid depending on the patient profile. So when I say primary etiology management, it is important because many disorders can be corrected and the bleeding will be controlled and the further treatment will be more effective. So these disorders are submucous fibroids or endometrial polyps, arteriovenous malformations, cesarean scar defects, chronic endometritis, endocrine abnormalities like hypothyroidism, hyperprolactinemia, bleeding diastasis. So if you are finding any of these, first remove them. And if all the tests are coming negative and we have a diagnosis of AUB-O or E, then we have to first go for medical management in which estrogen, progesterone, contraceptives come. The FDA recently FDA approved OC with estradiol validate 2 to 3 gram and Dynogest 2 to 3 gram. It has 26 hormonally active pills in 28 pill pack. The advantage is that it has got less withdrawal bleeding. So now the emphasis is on decreasing the pill-free days so that there is less bleeding. Non-contraceptive estrogen progesterone formulation are there in those patients who cannot tolerate estrogen, like AUB-O with obesity or hypertension, HMB and uterine leiomyoma as well as obesity or hypertension, AUB or HMB who smoke cigarettes. LNG should be, if in HMB, results in scanty menses, we have to remember that expulsion rates are higher and it requires more frequent removal because of less efficacy over time. Depot medroxy progesterone acetate should be given if there is contraindication to estrogen. High dose oral progesterone is again preferred in patients with contraindications to estrogen. Remember, norethindrone acetate is more efficacious than medroxyprogesterone acetate. And if you have a patient with anovulatory HMB, prefer 10 to 14 cyclic day regimen. And if you have a patient with ovulatory HMB, prefer 21-day cyclic regimen. Evidence supports all this. Tranexamic acid has been approved for HMB in 2009. It should be avoided if there is high risk of thrombosis or renal disorder. NSAIDs causes 30% reduction in bleeding, so can be added. Coming to surgical management, this is the STEP W classification, which defines the feasibility of hysteroscopic myomectomy on basis of size, topography, extension of the base, penetration, and the lateral wall involvement. If the score is less than 4, it is favorable for hysteroscopic myomectomy. For patients with completed family, we have the option of endometrial ablation, uterine artery embolization. Safety of pregnancy after uterine artery embolization is not yet established, and it is usually reserved for patients who are not contemplating future childbearing. Hysterectomy, definitely it has got a high rate of patient satisfaction because of its curative nature and definitive. So what are the other options? We can, if we compare LNG, IUS and endometrial ablation, it depends whether the patient wishes to be fertile or contraceptive purpose, for which thing she is requiring the treatment. LNG versus hysterectomy. LNG is preferred because of absence of surgical morbidity and reversibility for patients if they want to conceive. For adenomyosis, we can use high-intensity focused ultrasound and adenomyoma. For fibroids, MRI-guided focused ultrasound, thermal ablation, or laparoscopic radiofrequency myolysis are the options. Okay, thanks.
Any questions?
Thanks for patient hearing.
Thank you, Dr. Shilpa. Now we will be starting with our panel discussion, identification and timely intervention in complications of laparoscopic surgery. I invite Dr. Zini Gin for the as moderator for the session. She is consultant obs and gynae in Suman Hospital and SPS Hospital, Ludhiana. Her special areas of interest are endoscopy, urogynecology, and high-risk pregnancy. The panelists for the session are Dr. Suman Puri, Dr. Ajay Agarwal. He is Managing Director and Consultant Laparoscopic Surgeon at Amaria Lab Center, Sector 19, Chandigarh, and has been awarded Endoscopic Surgeon of the Year 2019 and 2022. Next panelist, Dr. Gursimran Khurana. I invite Dr. Suman Puri as panelist. She is Professor and Head Unit 2 DMC Ops and Gynae Department. She is MBBS MD FICOG with more than 25 years of experience. She has pursued reproductive endocrinology, infertility, and advanced laparoscopy at Mount Elizabeth Hospital, Singapore, and started PGS PGD program in IVF in DMC, and has many publications at national and international level. And also she has been the organizer for workshops on laparoscopy and organizing secretary of MRCOG program at DMC. He is a very skilled gynae laparoscopic surgeon in our Ludhiana city and has more than 20 years of experience. Dr. Gursimran Khurana, is she there? And I also invite Dr. Manmeet Kaur as panelist. She is senior consultant at SPS Hospital.
Gursimran कहाँ रहेगी? Right. Dr. Nidhi कहाँ गए? Dr. Nidhi भी कहाँ है? Dr. Nidhi, who is an eminent laparoscopic surgeon from Jalandhar. I think you don't have the updated list. Okay. I would first of all like to apologize on behalf of Dr. Bhaskar Paul. Unfortunately, on Friday only, he lost his father. Otherwise, he would have definitely been with us to host this and moderate this panel. Welcome to all the panelists. And we'll try, I wish there were more students here and, MD students here, because this would have been a good learning experience from all the experts, because I will be touching on some very basic things on what can go wrong and how you will manage it. And we'll start with that. Okay. So minimal access surgery has its advantages, certainly. However, it carries a high risk of complications. The key is meticulous dissection and prompt identification and management of these problems. So there are two reasons why complications happen in endoscopic surgery. One, they arise as a result of physiological aspect of laparoscopy. And secondly, because this is because you are insufflating the abdomen with carbon dioxide, you're using electrocautery, you have to have a certain position for the patient. So these are the reasons why you can have complications. And second, of course, is the surgical expertise. Now, laparoscopy does have a learning curve. And of course, everybody gets trained over time. We've all had complications. I think if a surgeon says that they've never had complications, either they're not doing enough surgery or they're telling a lie. There is no third thing about it. But if a complication happens, you should know how to deal with it. Secondly, the patient himself or herself might have some inherent problems, like they might have had previous several abdominal surgeries and they might have had some medical conditions, or the reason for which surgery is being done, like, advanced cancers, endometriosis, they may increase the risk of complications. So we'll start with the very first aspect when we start the surgery is as to how you position the patient. So I'd like to pose this question to Dr. Gursimran. So what position do you use when you are starting a laparoscopic surgery?
We prefer to put the patient in the Trendelenburg position.
And when you say the Trendelenburg position, how much angle, tilt, head tilt, which way would you use?
Head low, and the patient should not be in extended lithotomy.
Just a comment. Actually, we like to do this after we put in the primary trocar. You know, then we tell the anesthetist that we like a head low because all the vessels, the vena cava and all are very close.
Yeah.
And if we give a head low very early, probably the chances of injury would increase.
Yeah. So we start off with a supine position and a modified lithotomy position. So, Trendelenburg position, you are absolutely right, Dr. Suman. We should always do it after putting in the primary TOCA. But because there are a lot of complications related to Trendelenburg position as well, so that should always be. So, Dr. Manmeet, can you tell me what's wrong with this picture for a laparoscopic surgery?
The feet are too high.
Yeah.
There should be a low lithotomy.
Yeah. So I think what this shows is that you have to have a Lloyd-Davies or a modified lithotomy position where the legs are not pushing up against the abdomen and they are not pushing actually the intestine in your waist to injure them. So the problems that happen, sorry, Dr. Modi.
The ankle, the knee and the shoulder on the opposite side should be in the straight line.
The other
Parallel.
complication
Then
which
it's
will
the right
probably happen is because you're not supporting the knee and the thighs, is that you will probably be at risk of having more neuronal injuries, backache. So these are the complications which happen when patient is put in Trendelenburg position. They can have airway or facial edema. If the patient is on a big tilt and you're not supporting or you're supporting the shoulders with a strap, you can have brachial plexus injuries. There are corneal abrasions. Patient can slide off the table. You can have lower extremity nerve injuries, visual loss or defect. In fact, posterior reverse encephalopathy syndrome is a very well identified syndrome for people who have been in Trendelenburg position for a very long time. Your anesthetist might start complaining because he's not getting enough compliance for ventilation of the patient. Subcutaneous emphysema, wrist edema. So overall, there is a lot of complications which can have. So don't think that you can keep having it, you can keep pushing. So anything,
Vaginal
obese woman, there is a lot of fat in the abdomen. You're not getting access to the pelvis. So how, Dr. Amit, would you try to keep the bowel away?
I think bowel preparation is very important on the
Yeah.
preceding night. I
Yeah.
usually use Peglac or Dufalac.
Yeah.
That does a good
Can we
job.
have a mic there, a handheld mic? Yeah.
I think pre-operative preparation of the patient is most important. The gut should be empty.
Especially when you are going in a very scarred or a endometriotic.
I think for a scarred abdomen, you should always use the Cleveland point or a modified Palmer's point.
Yeah. We'll come to
for
the entry. Yeah.
But for the gut preparation, I think a good evacuation is important and a good pneumoperitoneum.
Yeah.
And,
And
I
a deep
would-
head flow sometimes
Yeah.
also helps.
We can also use a nasogastric tube.
Yes. So, gut preparation is of utmost importance. So don't be shy to give your patient a bowel prep at the night before. So let's look at a few abdomens here, and I'll start with Dr. Nidhi. In the first picture, what will your point of entry be? Okay, first closed or open?
The method of primary trocar
Yeah.
insertion, I usually prefer the open method.
Open method.
Yeah.
You are in Hazard.
Yeah,
Dr.
I'm very
Manmeet.
comfortable with that.
Dr. Manmeet.
Yes, open can be a good option. of course,
Dr.
in this
Suman.
case, though.
We can use the visual trocar also in this case.
Okay, you can use a Visiport. Dr. Ajay. Mike.
First one, no?
First one. Okay.
Works well.
Okay. And Dr. Amit?
Ma'am, the same, Palmer's point.
Palmer's point.
Or the modified Palmer's point.
Gursimran?
Since I feel that the vertical incision is about 2 to 3 centimeters below the umbilicus, we can also go for the superior crease.
You know what, whenever patient has had a previous abdominal surgery, the systematic reviews have shown that 68% of bowel injuries had had prior abdominal surgery. And there is a higher rate of injuries in a large cohort study as well. And even if it's a virgin abdomen, don't think you can't have adhesions. 10% of patients, even with a virgin abdomen, will have adhesions. Now, what is important is that, you know, whenever you're putting the primary toga, you have to have all these things in mind. Open technique versus closed technique. In literature, there is no evidence that the risk of bowel injuries is less whether you're going for an open technique or a various technique. The only difference is with vascular injury. Vascular injuries are lower in an open technique as compared to the various techniques. So as Dr. Amit and Dr. Ajay were saying, we have different points of insertion of the various needle. You can go intra-umbilical, supra-umbilical, Li Huang point, ninth intercostal space, Palmer's point, the Jane point, and the which is 1.5 centimeters to the interior of anterior superior iliac spine and 2 centimeters above in the mid-clavicular line. So the two randomized control trials have compared open and closed entry techniques, and a meta-analysis does not indicate a significant safety advantage of either technique. In a meta-analysis of 350,000 closed laparoscopic procedures, the risk of bowel damage was 0.4 per thousand and of major vessel injuries was 0.2 per thousand. So you have to counsel and consent the patient accordingly. And in another study of 10,800 plus patients, they found that 6 cases of bowel damage, 4 of which were recognized immediately, but in 2 of them, the diagnosis was later and reparative surgery was delayed. The rate of adhesion formation. So if a patient has had a midline laparotomy, remember that there is up to a 50% risk of scars and 23% in the case of low transverse, which is a common incision you use for cesarean sections. So you, as you said, Palmer's point is used, which is in the mid-clavicular line, 3 centimeters below the costal margin. So consideration with the habitus of the patient. Dr. Nidhi, thin versus obese patient. What would your choice, I mean, how would you, if you're using a various, so how would it be different in a thin versus an obese patient?
I don't use varies. I have always done with open methods, so I'm very
Okay.
comfortable with
For
that.
somebody then who
I
uses
can
varies.
take this, yeah. So when we use varies for a BMI which is more than 30, we like to go vertical first rather than at an angle, because that is how we'll be able to penetrate through the subcutaneous fat. But if it's a thin patient, we can go at an angle of 45, and the varies has a very good spring guard mechanism with the stillet
So
and the
in
outer edge.
a thin patient, you will have no option but to go at 45 angle, otherwise you're going for the straight for the major vessels.
Yeah.
Now, if you look at the distance between the anterior abdominal wall and the posterior spine or the vessels on the spine, the distance progressively increases in an obese patient. You don't want to be in the subcutaneous plane or the preperitoneal area so that you don't cause extraperitoneal insufflation, because that has its own problems. Now, the first picture, Dr. Amit, can you advise us what's wrong with this picture?
The upper left picture, I think you're not inside the abdomen, or you're in the gut, I believe.
We are in the pre-peritoneal space, I think.
So you are actually, you're lifting the abdomen at the wrong place and you're in the
We
wrong
haven't
place.
entered the abdomen. We are in the pre.
Which
we are
picture,
just in
First one, the very
space.
first one.
Mechanism of injury.
Yeah.
Animated one.
So already the patient is in Trendelenburg, that's wrong. Okay, you're lifting the abdomen at the wrong place and your angle is wrong because it's a thin patient. So you have to be careful. So Dr. Ajay, you've gone inside, you put the varies, you've insufflated, you put your primary port and camera, and this you find in the retroperitoneum. What would you do?
It's It's a major vessel.
Major vessel injury.
Yeah, there's a huge hematoma.
In second picture you are talking about?
The second picture where
I can see appendix, I can see the sigmoid colon, and I can see a collection of blood over there. And because I've used Very's needle over here, so I would like to wait for some time to see whether this hematoma is increasing or not. If it is limited over there, because most likely it is not arterial, most likely, I just assume, it should be a venous injury. I will observe for some time. Just in case if it is increasing, then I would like to open the patient.
Perfect. I think I completely agree with that. Wait, see if it is increasing or not, and if it is, get your vascular surgeon or a surgical colleague on board and open up the patient. The third injury, Dr. Amit, so you have put in a Very's, you looked and there was this bowel injury.
Yes, ma'am. There's nothing to be done, ma'am. You just have to observe and this will heal on its own.
Okay, great. So a lot of times we can just wait and watch. So, you make more mistakes when you panic and you're worried about these injuries. And if you are not experienced enough, get somebody senior in and don't be hesitate to ask for help. Operate, you're looking at the monitor, first, second, and third points.
I'm really happy when the gas pressures are the actual pressure is less than 10. So that tells me that I am not inside any luminal structure or omentum. I'm not creating an emphysema. And yes, when I'm assured that it is inside, then I might as well can increase the pressure.
So that's a very give, even though you've done a Palmer's test, which I think is mandatory, because in a court of law, certainly in England, because there was a case where they had not mentioned in the notes that they've done a Palmer's test. And the judge just said, oh, what is a Palmer's test? He says, it's a safety test when you're doing laparoscopy. He says, you've not done a safety check, and immediately the case was called. So, if you are doing a close technique, always mention that you've done a Palmer's test. So then you're looking at low pressures, a good flow rate, and then you are never looking at the final volume. A paras abdomen may take up to 4 liters, and a nulliparous abdomen may be, well distended with 2 abdomens. What you should be looking at is the initial gas pressure before the insertion of primary trocar. The Royal College of Obs and Gynae clear guidance on safe entry technique is that you have to have initial pressures of 20 to 25 when you're putting the primary trocar, because this puts a maximum distance between the bowel, the posterior wall, and the anterior abdominal wall. And this should be reduced to 12 to 15 millimeters once the trocars have been put in place. And why do you need to reduce the pressures? Dr. Nadi, why should you have lower intraoperative pressures?
Because it will tend to, put pressure on the major vessels, and definitely the diaphragm will be pushed up. The anesthetist will start shouting.
That's one. Secondly, there have been a lot of studies where they have done peritoneal biopsies, and they have looked at that if you've had major pressures, higher pressures in the abdomen for a longer period of time, it gives rise to a lot of inflammation inside the abdomen, and post-operative also patient has pain. Certainly, there is a lot of effect on the cardiac output, the heart rate, the systemic vascular resistance with the increased abdominal pressure. The anesthetist will not be happy. And in a healthy patient, which we usually are dealing with, most patients will take it. But if the patient has an undiagnosed poor cardiac reserve, or she has a cardiac undiagnosed cardiac problem, they can really cause a lot of problem, which is exaggerated by the Trendelenburg work position. So remember that. Yes, you can have increased hypercapnia. You can have effect of carbon dioxide on the heart, or you should remember all of these things. So you have put in your primary port. Your you're teaching someone, your junior went and felt that, okay, I'm in the right, but you have got pre-peritoneal insufflation. You put the camera and that's where you find the gas. Dr. Suman, how would you tackle this if this happens?
I think I'll stop the gas at the time and
Right.
probably do a repositioning again.
Yeah. Or Dr. Ajay, you want to take on that?
In case of preperitoneal insufflation, I will take off the trocar. I will go back in at most likely at the same site, because I can do that. But just in case, if I'm not sure, and the distance between the peritoneum and this entry point is too much, then I will go at the higher level.
And then I will probably do what Dr. Nidhi does for all her patients. I'll probably go for an open technique at this stage.
Because we need to deflate it as well, because once we go inside, the visualization becomes
be
bad.
not there. Absolutely right, Dr. Nidhi, because what will happen is, again, wait for sometimes. If you're now in the abdominal cavity and as you're insufflating the abdominal cavity, this gas will get absorbed. But do tell your anesthetist that look out for surgical emphysema, look out for chest emphysema, pneumothorax, anything like that. Because, you know, there are sometimes undiagnosed tears in the diaphragm and people have had mediastinal or pneumothorax in the chest if the gas has gone from the abdomen to the chest. So post-operatively, watch for this. Now you're putting in the primary toker and this is what you find. You know, this was a scarred abdomen. She's had several previous surgeries and you were suspecting it and, you know, you went in and this is it. The abdomen is looking like this. You start dissecting and what you find is that you are here. You know, you're in the bowel.
You're on the ball.
What do you do? Dr. Amit?
I think, ma'am, first you need to be sure you have penetrated the bowel. You'll put in a secondary trocar. You usually get to see this kind of a complication whenever we go into the abdomen, we look all around. There's a 360 maneuverability of the scope, and then you see if there is some gut attached to the abdominal wall. Normally, when we put in a scope, we usually rotate the scope all around. We check for bowel adhesions in the interior abdominal wall, and if your abdominal wall is clear, then you proceed with the surgery. But usually, this kind of a complication will be picked up immediately once you rotate your scope. As soon as you enter, you rotate all around. You look for the upper abdomen, lower abdomen, on the sides and make sure you haven't injured anything. That's a routine practice for all of us, I believe.
Yeah,
As soon as
absolutely right.
That is how you must have put in a secondary trocar to check.
Yes.
To that whether I have perforated the gut or not.
No, not all of them are my videos, thankfully.
But then if you have, then you would keep the scope there, open the abdomen, look for the gut perforation. Don't remove the trocar.
Yes, that is what I wanted to come
where you perforated the gut.
If you are finding such additions, put in a secondary under vision and then look where your primary trocar is. It's very important. You can put in a 5 mm scope, you can put a 10 mm scope, it doesn't matter. But again, as Dr. Amit has said, do not remove your scope because you might lose that area of injury. Because here, if it is in the small bowel, you can even suture. If it is partial thickness, if it is a full thickness, you will have to do a dissection and anastomosis. So it's very important that you do not remove the primary trocar. And if you find such a scarred abdomen, put in a secondary port and then look inside the abdomen to see where your primary port has landed. So respecting the vascular structure, vascular structures in the abdominal wall for trocar insertion. So you put in your secondary trocar. You remember you have loads of vessels in the abdomen. How can you avoid this, Dr. Ajay?
I think you have injured the inferior epigastric artery over here.
Yeah.
At the time of insertion of secondary trocar. It has happened with me once also. Yeah. Especially it happens in obese patient where you are not able to identify the inferior epigastric artery, very obese patient. So if you want to try to avoid it, you should go ideally 1 inch medial and above or lateral to the ASIS, never too medial to the ASIS. First thing. Second thing, just in case if you have found this bleeding, the first thing is there are 2 options. One is you can try to catch it and coagulate it, but it never works. So what worked for me and what worked for other doctors is you immediately use the port closure needle, pass it inside, and then suture is passed from opposite side and just tie it. And the bleeder will be taken care of. That works wonderfully and immediately.
I think I would be very happy with the suture port closure needle as is being shown in this picture. The thing is that when you do diathermy, sometimes it will keep creating a hematoma still in the muscle. So it's important to get a through and through stitch, and the port closure needle is very easy to use and manage this sort of a complication.
Also vessel seal it. You can use a good vessel sealer and you can probably coagulate. I use the 10 mm Atlas for these kinds of cases and invariably always succeeded.
That's the other thing, that what kind of vessel sealer. So 7 or 10 mm vessel sealers are great for big vessels, and I think if you get it in there, yeah.
See, once hematoma formation has already started occurring, it is very difficult to identify the pinpoint bleeder. So the best thing works is the suture with the help of the port closure needle, and that you have to go towards the pelvis. The suture has to be taken towards the pelvis because blood is coming from below.
So both the techniques are right. It depends on surgeon to surgeon what you are. But at the end of the day, just be aware that both of these options are available. So bowel injuries. Now we move on. You started your dissection. The incidence of bowel injuries is 0.13 to 1.8%, depending upon, of course, the surgical expertise, and maximum, of course, in the GI surgeries. And most injuries, remember, are with minimal, with no impact on clinical outcome. However, most of them will not be recognized immediately. At the time of laparoscopy, you will only be able to identify less than 50%. And within the first 48 hours, you will identify 10 to 35%. And delayed identification is 19 to 15 to 45%. So, here was a patient, you wanted to do a TLH and she had a bad hernia and you had no access to the pelvis. You started dissecting the hernia off. And once you have started dissecting the hernia off, midway during the dissection, you realize that there is a hole in the bowel. Dr. Nidhi, how would you address this?
We will suture it then and then.
Single
That's
layer,
it.
2 layer, on your own, with help?
I think I've never needed to do it, but I've watched many videos over it. I think they do single layer suturing, not the traditional method as the surgeons do.
Okay, Dr.
Yeah.
Manmeet, your take on it?
I will not do it on my own. Definitely, I'll ask a GI surgeon. And yes, I think they prefer two-layer closures. They definitely seal up their muscle and then the serosa.
Dr. Suman?
Yes, we will call for help and take their advice, because it's even better medico-legally that a GI surgeon has been called in. So they have multiple options. If it's small, you can do suturing, two-layered. Sometimes if it's a big rent, they go in for colostomy also. So depends on what type of injury it is. Though suturing helps in small injuries.
Okay. Dr. Ajay?
The first thing I do is apply a silk suture to identify the site of injury, and then I complete my dissection and my surgery. Meanwhile, I send a call to the general surgeon just in case if he is approachable or not. If he's not approachable, then I do the endosuturing on my own after documenting that we tried to approach some surgeons and could not be approached, hence sutured by the gynec laparoscopic surgeon himself. If I do suturing, it will be endosuturing with the help of Vicryl. Small bowel has to be sutured in 2 layers with the help of 2-0 Vicryl. Okay, and mucosa should not be exposed outside. The second layer will be taking care of the serogel layer. Okay, but if I am suturing the large bowel like sigmoid colon, that you can suture in single layer, or just in case if you are like having lots of fear about the leakage, then you can just do gentle approximation of the serosal layer on the top of the first layer. All right, and that is it about the bowel injury, I think.
No, I completely agree with it that first you put a stay suture there, leave a place so that you can identify where the injury was. Yes, in this day of medical legal era, even if you are very capable of suturing as a gynecologist, the bowel injuries yourself, ask the surgeon to sit outside and put a note in that they've seen it. Don't ever leave it, because, in the court of law, you will only be asked one question, that did you involve the surgeons, and that is it.
Yeah, one more thing. If my surgeon comes for repair of the bowel, then I always go for mini laparotomies because I don't trust their endosuturing at all.
Yeah,
I've seen it,
if in
and
doubt,
I burned my
open.
finger.
Yeah, if in doubt. So, great. I think we missed one on colon injuries. Anyway, so we come to thermal injuries. Now, Dr. Gursimran, can you tell us what is happening in the first slide, in the first picture?
The monopolar is coming in direct contact with the intestine.
Yeah. I mean, it's insulated, but why do you think this is happening? Dr. Amit?
Activated coupling.
I think it's either the insulation is gone.
Yeah.
It's probably
It's an insulation related
failure,
injury.
I believe. Yeah.
In the second one, you are seeing this. Your camera is there and you see this little spark. Okay. So what kind of injuries are these? So, their thermal injuries can happen in a number of ways. So what we saw in the first picture was insulation failure. So your tube, your monopolar or even your bipolar, it is in a sheath and then it is in a protective sheath. But sometimes there are cracks which mostly happen when you're autoclaving and you are actually cleaning your instruments. There is something called as porosity detector. You can ask your technicians or biomedical team to look at it. But if that is not possible, then make sure that you're not touching anything. As for long as possible, you should not touch anything. The second picture we saw was antenna coupling. Antenna coupling is like you have your camera wire going, you have your bipolar wire going, you have your monopolar wire going, and you have tied them all together to stop that spaghetti effect on your table. So the current, because of the electromagnetic waves, there is a transmission of current between the two wires. And now your camera lead also starts transmitting electrical energy. And so you start cauterizing things through when you're pressing on your cautery button, you start accidentally cauterizing your tissues with which the camera is touching. And there are other forms of thermal injuries, which is direct application, inadvertent activation, residual heat. Dr. Manmeet, which instrument, mono, bi, or harmonic, which instrument has maximum residual heat?
Unipolar.
Sorry?
Unipolar.
Monopolar.
Monopolar.
The maximum residual heat is actually in your harmonic. It's on ultrasound-based devices because they tend to be hot. So, I've actually tried to show it to my team in theater, my assistants. Whenever I have just cut with the harmonic and I touch it to the uterus, immediately that area goes white. So be careful if you're doing your pelvic dissection and you have bowel, don't push your bowel away with the monopolar. You should do it with a cold instrument and your harmonic should only be used to cut. So harmonic retains the heat for the longest duration of time. So whenever you're using electrocautery, remember use lowest feasible cut mode or setting, which is cut better than blend, better than quag. Use short activating time, inspect your instruments regularly, do not bundle or jumble the electrosurgical wires. Recognize that residual heat is highest in ultrasound-based devices and do not activate the electrode in close proximity or in direct contact with metal instruments. Let's say you have put a clip on a vascular instrument, you don't use electrocautery because the heat gets transmitted. So small bowel thermal injury. Dr. Amit, would you like to comment on this? What would you do?
I think this is one of the most difficult case scenarios. You don't know the extent of damage. It will only be exhibited after a couple of days. So either you just leave it if you think it's a superficial burn, and if you think it's a deep burn, open up.
And
Do
Dr.
a
Ajay,
resection anastomosis.
you would still like to close this, or you would
I would like
leave?
to take 2 bites on top of that. I would like to approximate the serosa on top of it and have a nice sleep and not to bother what will happen after 7 days.
So the question in this kind of scenario arises, do you need to repair all serosal injuries? Now, in an in vivo model, the serosal injury model, they found that no perforation at physiological intraluminal. But if it is more than, it was 100% circumference and more than 4 centimeters, there is no doubt that you have to suture it. So you are doing a good dissection. There is lots of adhesion. This patient has bad endometriosis, and this is what starts happening. Dr. Nidhi, what would you do?
We'll do a bipolar coagulation and look out for the bleeder and then exactly pinpoint rather than randomly going and rushing around, catching whatever comes in the way. Instead of that,
okay, Dr.
it's
Manmeet?
better to catch it.
The person who's showing the camera is really your saver at this moment. If the camera it's not supposed to be spoiled, and then yes, hold it.
That is the biggest problem that you can see, because once you have a big spurter, it will start spurting on your camera, and then you will lose your field very quickly. So you're going with bipolar. And Dr. Suman?
Yeah, we have 3 options, bipolar, or I would use a clip, or I would even use a suture. But I have to have a field which is very clear. So I would probably do a quick suction and see actually where the vessel is bleeding.
Okay, Dr. Ajay?
Yeah, that is
What has
rightly
happened in
mentioned.
this picture? Now, earlier you were showing something different. If I just show you, there's slight difference in the previous picture and this one, if you identify that. Let's see what the difference. So here you have this, okay? Then you have this, and then you have this. What is the difference in these three
The
pictures?
manipulator has been used to bring up the uterus a little.
You get an extra port.
Extra port is there and suction is being used now.
Suction
Yeah.
you to
See,
clear
the most important part, whenever you are seeing any kind of bleeder, the first thing you try to catch the bleeder and bring the suction from the other port. And just in case if you need extra port, that you can add later on. But the first thing is to catch the bleeder immediately, take a pause, clean the field with the suction. If at all it is filling up profusely, then suction and a grasper in one hand, suction and catch the bleeder. Once your bleeder is in your hand, then you take a pause, you think what is going to be your next mode of action for hemostasis, whether it will be suture, clip, or bipolar or harmonic, whatever it is. That is the last thing.
So, you get an extra port in, you try to do it with bipolar, doesn't happen. You put a clip on, which is the next thing that has been done, doesn't happen. And then finally, if it's not settling with the hair, you can see the clip beautifully, but still it's not able to control the hemorrhage. And then you finally have to take a stitch. And let your anesthetist know. Because, he has to be on the top end looking at the hemodynamics of the patient. And he has to make sure that the
Sometimes
patient
if
is...
it's a massive hemorrhage, you might need to open immediately rather than waiting. We cannot, put in the...
If in doubt,
holder
open.
and it'll
Okay,
take a
so
lot of
there
time
is
to take
no
a stitch.
thank yous and no, there is no surgeon who's ever gone for a laparoscopy and has not opened up an abdomen. It's the safest thing to do. Pressure will stop bleeding from aorta. Okay, in the moment, but be aware if it's a very big vessel like an IVC or an aorta, the moment you slash the peritoneum, you've lost that tamponade. So the moment you're going to open your peritoneum, tell your anesthetist her blood pressure will drop. And you have to have your vascular instruments, your bulldog clamps, your vascular surgical team, and you just go and press on the abdomen. So before you open your peritoneum, you have to warn the anesthetist, because this is what you see in ruptured aortic aneurysms. So you warn the anesthetist that I'm going to open the pneumoperitoneum now. Her peritoneum now, her blood pressure will just plummet, and it goes down to 30 like that, and you will lose that patient immediately. So beware whenever you're opening, how, especially when it's coming to big vessels, your common ilex, your IVC or your aorta, be careful of that.
Air embolism is a dreadful condition. Air embolism at that time can be a dreadful
Yeah, I've had
condition.
that. I was once doing a pelvic lymphadenectomy, and just with my enthusiasm, I was just at the last very node, and I had a small tear in the, in the common iliac vein. And I got it. I immediately put the bulldog clamp, identified and sutured that. But my anesthetist started telling me that her CO2 has become very low. Why has the CO2? And then he told me there is no blood pressure. I said, no, blood pressure is there. I can see the pelvic arteries pulsating. So she was immediately on Nora at 25. We got the patient better, and I was very, very grateful to God that when I woke up the patient, she was completely mentally fine. Immediately her blood gases went off. She had severe hypocapnia. She had her blood pressure to a down in the boots, but thankfully she made
And
it.
I still remember your glorified face next day when you saved the patient like that. I still remember that.
I just only glorify God in these situations, because believe me, that's the only one body that you need to glorify. So Gursimran, last question for you. We're almost at the end of the discussion. So you're doing this previous cesarean section, you want to do a TLH, and halfway down you find this. You start seeing the beautiful catheter.
I know.
Inside the, and you say, oh God, I've opened the bladder. There you can see the catheter. What would you do now?
So
We would suture it.
We have to suture the bladder back.
No, will you carry on with your dissection? Will you stop your dissection, open up the patient? What is your take on it?
We don't need to open up the patient. mostly it is considered that sterile urine does not cause any chemical peritonitis. So we can carry on with the hysterectomy, and at the end we can repair back the bladder.
Dr. Amit?
Yes, ma'am. I agree with her. You can use 2-0 and repair it in a single layer and keep drainage for 14 days.
Somehow,
No, these-
after you made the hole, you find the plane very easily and you're able
Yes.
to replace
Once you know how to damage it, you are comfortable
I
with the
don't know why
surgery.
it happens, whether you're doing a cesarean or you're doing a hysterectomy. The moment you open the bladder, the next thing is you find the plane where you had to dissect
Yes.
and you
One
kick
more
yourself.
Actually, the moment you learn how to take care of the complication, then complications stop occurring.
I
That's a
still
learning One more curve.
point
I
I would
still
want to-
remember the first time I was doing a hysterectomy, and my anesthetist, he started shouting, "Oh, open up, and then repair the bladder." I still regret. I could have repaired laparoscopically. So
So
now
yeah,
I'm
you need
wiser.
to have a very good team. Your scrub team, senior staff, your anesthetist at the top end, who's has the confidence in you that you will be
One
able to
more
manage.
point I would like to add, that we don't like to remove the catheter after 14 days. We always like to do a check cystoscopy and then remove the bladder.
But they
we can check
recommend
with
these
methylene
days
blue,
that
then only.
even 10 to 12 days is enough to keep the catheter. You
Now
don't have to
it-
keep it for 14 days.
We've gone very far. We'll just step back a little bit. You've now dissected off the bladder. You found the right plane, and you realize that the injury is in the dome of the bladder. Okay, Dr. Ajay, what will you do?
See, in this particular case, what your question is about what?
If the injury is in the dome of the bladder, you've done the reflection, you've left it, कि ठीक है, I'll finish my hysterectomy, I'll do the cervical, dissection, and once I've done it, then in the end I'll come and suture it. You're not worried. No, now you found that the injury was at the dome of the bladder. Then what would you do?
I will suture it.
You'll suture.
I will suture it
One
with
layer,
the
two
Vical
layers,
2-layer,
suture.
always 2-layer.
2 layers, 3
Watertight.
Yeah.
Watertight 2-layer with the help of Vical.
So you will check a watertight seal. You do it in 2 layers.
So one more thing I would like to highlight here. I don't catheterize my patient. It is very, very important if you are catheterizing your patient before your TLH. Then at times we go in and patient is already catheterized by the norms, standard norms. Then please ask your assistant or your staff to clamp it, so that the partially filled bladder, it will help you in identifying the correct plane all the time. The chances of bladder injury will be almost zero with partially filled bladder.
Absolutely.
But if your bladder is like totally,
I
empty,
myself, as a routine, never catheterize my patients. I only do intermittent catheterization at the start of the surgery before I put my varies, and if need be, if it is obstructing my dissection around the cervix when I'm doing the vault, then I catheterize. Otherwise, I
yes,
leave it alone.
when you are already sure that yes, your bladder dissection has been done, then
So,
only you can
full-time
empty the
Foley's
bladder.
is
Otherwise,
not
no.
required during
No, not at all.
TLH. That is very,
The
very
chances
clear.
of injury will be more.
So, Dr. Amit, if you felt that the injury was lower down at the level of trigone, what would you do then?
Ma'am, you need to dissect it completely dissect the bladder and put a DJ stent.
Yeah.
A stent is a must for
Yeah.
2 to 4 weeks.
Absolutely.
And then you repair it. And intermittently, you can put in a bit of a momentum.
Urologist
between
there
the
or
repair.
not there?
I prefer not to call them because invariably they are not available.
Okay.
No, definitely.
But again, I'll come back medico-legally, even if
Yeah,
they come
if you
out and
have
put a
to
note that I
answer
have
in the
seen
court
it,
of law.
you have some friends who can do that for you. So you must be perfectly, you stent it. If it's open bladder, you can just stent it from there only. You don't have to do anything else. You don't have to do a cystoscopy. Dome injuries, thankfully, God is very kind. Dome injuries heal very well. But it is the trigonal or lower injuries which are a problem. If you're worried, in the end, put an omentum, pull down the omentum and put it between the vault and the bladder so that you leave no area for communication between the two. And secondly, catheter, people are saying, yesterday also we were having these discussions, doctor, in my urogyne workshop, the urologist says 7 days, sometimes 14 days. And if it's a very bad injury or multiple tears, then even 21 days. But in those cases, do an MCU and then take out, or just do a cystogram. Make sure that the bladder wall is intact, and then you take it out.
What is MCU?
Matuating cystourethra.
I do cystogram if I
Yeah,
operated a case
cystogram
of bladder endometriosis. Then I do cystogram after 2 weeks before I take out the Foley's.
One question is, if you're doing a TLH for somebody who's had previous 2-3 section, you had bladder adherence, and you were deflecting the bladder away. How long would you leave the post-operative, leave the catheter for?
I don't catheterize my
Happy
patient.
with my
You don't
dissection,
catheterize.
I
I'll
don't.
remove the next day.
Next thing.
If I'm
Dance.
happy.
Because there was one discussion one day I was having with one of my surgical colleagues, although I have found no evidence for it. He said that these patients tend to have a thimble bladder. So it's good to leave the catheter for 3-4 days in those patients, but I have
what's
found
the
no
point of
evidence.
I don't
laparoscopic
even
surgery?
catheterize my patient. Previously,
And,
cesarean, badly adherent bladder, anything. I don't catheterize my patient.
And we are
at all.
all in the concept of eras, early recovery after
Like,
surgery.
ma'am,
And
rightly mentioned eras.
unnecessary tubes.
I don't give bowel preparation also before my surgery. Until unless I'm doing cancer surgery, that is a different story. That is also ovarian cancer, not for endometrial cancer.
Usually, intraoperative procedure itself guides us what will happen post-operatively until and unless there is something cardiovascular.
When we are talking
or
about eras,
drug
no,
disease.
early recovery after surgery, it is very important. Don't give any bowel preparation and don't catheterize the patient. Early ambulation is the key. Early,
And discharge the patient.
allow, only allow.
Most patients will go home on day 1 or day 2, but I do give bowel preparation if I'm suspecting grade 4 endometriosis. I do. I mean, I think because if there is, it keeps your bowel empty. Obese patient, it keeps the bowel away, and if it does open up, there is less risk of contamination.
Yeah, I agree.
So,
All pelvic surgeries and endometriosis,
Yeah.
bowel preparation
But you don't need
is
to do it for
needed, not
routine
in a simple,
hysterectomies.
clean case.
So
of
we have a
hysterectomy,
consensus, and then
laparoscopic
not in
hysterectomy.
routine hysterectomies, only for complicated surgeries. But Dr. Ajay, maybe, he's very experienced. So, as I said, every surgeon develops their technique depending on their experience and develop on, how their outcomes have been. And perfectly good point to take at home from that. Last discussion on fibroids. Primary trocar, you have a large fibroid. Dr. Amit, what is the precaution that you would take when you're putting in the primary trocar?
It should be as high as possible. Probably
Li
2
Hong
inches
is
above
the
the umbilicus.
preferred, my preferred thing.
Sorry?
Li Hong is my
Liu Hong.
preferred
Hong,
one.
yes.
Yeah.
Liu Hong.
Liu Hong, a little bit on the left because otherwise you'll be in the falciform ligament. So at least 8 centimeters above the height of the uterus. That is what the dictum is, that at least 8 centimeters. And I know Dr. Amit uses very little vasopressin. Your dilution is very high. You only use about 2 units, I think.
I use really less.
You really.
ml and 100 ml of saline.
So the guidance even by the most endoscopists is 200 units in 20 units in 200 ml saline, and most of the time subserosal fibroids will blanch very quickly. It's only the deep intramural and wait till blanching happens. The second is incision. How big your incision should be?
It should usually be almost 3/4 of the fibroid size, because I was giving smaller incisions and then struggling a lot.
We've all
Then,
done that.
yesterday
When we
only I
start
was
out, we
doing
always
my
end up
fibroid and
start
I
out
do-
with small incisions when we are starting out myomectomies, and gradually we get confident and we just
Yeah, we give
cut
bigger
it.
incisions.
Yeah. Devices, monopolar, bipolar, or harmonic, or ligashaw.
Monopolar for cutting the capsule, and once this thing, then we endosuture.
Yeah, I think this is
prefer
where
I don't use harmonic for this.
I would prefer a harmonic. In fact, you can put a little cauterization with a bipolar and then go on and use the harmonic. which
in
is,
these cases,
Energy sources
the
usually
fibroid doesn't
disfigure the capsule, so you can't get into the right plane. In fact, the best thing you can use is a simple scissor, cut the capsule, because the scissor will not go into the fibroid. So that way your planes are intact if you use a scissor, and if you use energy sources vis-a-vis, you might cut into the fibroid, and then the plane of the fibroid and the myometrium is not there anymore. Then you
And then
dissect
we can use a
all the way
percussion
more.
probe.
Normally use a monopolar.
So one thing again, what Dr. Amit, I know he uses ligashaw. Having 7 to 10 mm vessel sealer will be helpful in very big fibroids because they have very large veins. So I think they,
No, but you
at
injected
this time.
vasopressin, no?
Sorry?
You already injected vasopressin first.
Yeah, but still, I find that sometimes if you have very large fibroids, it helps to have larger vessel
so
sealers.
you
But
mean
each to
use
his
an
own.
NC
Each to his own.
basically. You're suggesting an NC for a 7 mm vessel.
I never need to use a vessel sealer for my fibroid. I usually inject vasopressin, give a
They're quite
monopolar
kind.
incision,
Most
and
of the
then-
fibroids are quite kind.
See, for better healing of the myoma scar, try not to use any kind of energy source. Okay,
Exactly.
first thing is this.
Exactly.
So second thing, if definitely I'm dealing with multiple fibroids or very large fibroid, then what I do, I use harmonic like you are showing in this video for the dissection of the upper myometrium. And when I'm at the base, like now, I will use my scissor so that my planes are not spoiled. See, when you are using cold scissor, no, your planes are beautiful.
Very
Beautiful. You know each and everything. Like if even if I'm doing a denomyomectomy where it is very difficult, there is no capsule, nothing. Only Caesar can tell you where you exactly are.
You can open the cavity, otherwise if you get over
Yes,
enthusiastic.
if you are using Caesar, you won't open the cavity because all the time you are palpating it, then you are giving cut. Palpate and cut.
I completely agree with that, and only use the vessel sealers where you actually see the vessels. Otherwise, you just reflect the fibroid. Last bit, if you have a broad ligament or a cervical fibroid, what extra precautions would you like to take in these situations, if any?
See, for broad ligament fibroid, suppose you are dealing with right side broad ligament fibroid, okay? So that depends on the location of the fibroid exactly. Suppose my this is so big that even round ligament is getting stressed on top of it, then I will cut the round ligament. I will take the entire peritoneum on the right side. I will take the uterine artery at origin and dissect the bladder down, and then I will take out the fibroid.
So you will ligate the uterine artery, you will clip
I
temporarily.
will take care of the ureter also.
Yeah.
Ureter will be right in front of me all the time.
So I've seen Dr. Prakash Trivedi, temporarily he clips the uterine arteries. After he's done the surgery,
Both options
he
are
takes
fine.
it off.
You
yeah?
can do it permanent or
So,
temporary.
yeah.
That both options are fine.
Because anyway, you'll get collaterals. Yeah.
Yes.
So ureter, I think is what I wanted to.
It is very,
highlight.
very important.
Yeah.
For broad ligament fibroid and cervical fibroid, there are only 2-3 things you have to take care of. One is the bleeder, that is your uterine artery. Second thing is the ureter, because once you have injured it, you are in soup. Third thing, if you are dealing with anterior cervical fibroid, then bladder. If you are dealing with posterior cervical fibroid, then bowel.
Great tips. And last of all, morcellation. Let's just have a consensus. Dr. Nidhi, in bag, outside bag, or no morcellation? No, you have to take out the fibroid. In bag, outside
Usually,
bag.
what the consensus says is if it is not a suspicious fibroid, younger age female, then without bag only you can do.
Dr. Manmeet?
Yeah. Yes, I agree to the same. I think, yes, without bag morcellation and it's pretty
Dr.
fine.
Suman?
Yeah, same. You have to be sure of the nature of the fibroid.
But you can't
And when
be.
you-
It's a
Yes,
histological
true.
diagnosis.
But when you look at it, you
Oh.
can make out in
So
chalk
it's not a
that
soft
it's a
fibroid, it's a
benign-
beautiful firm fibroid.
Yeah,
It's telling
so-
you I'm benign.
Of course, degenerated
At least-
fibroids does create a problem.
Yeah, almost done. Last slide. Dr. Ajay?
See, if you go by the FDA, then obviously you cannot use any kind of morcellation.
Yeah, the-
First thing is very clear.
Yeah.
Second thing, if at all you are using morcellation, then it has to be endo bag all the time. But in practice, because obviously we try to save lots of money all the time, and one endo bag if you are using, it will increase your 10 minutes time. First thing, second thing, the cost will also add. So that's why in all hard normal looking fibroid, I do normal straightforward morcellation with my morcellator. But if I have-
Carl is taken off
I
its
have
morcellators.
Carl Stores is banned now, but luckily I have Carl Stores.
We'll pray that its blade lasts us a
Yeah,
longer time.
yeah. And that's why I bought one more blade. Once they banned it, immediately I bought
No,
one
there
more.
are alternates.
So second thing is, just in case if I have iota of doubt that this fibroid is degenerated, I see all the MRI on my own. Okay, all the MRI, all the
Absolutely.
ultrasound. So if I
Fibroid
have any
mapping.
iota of doubt about the, it is even if it is degenerated, I will always put the fibroid in the bag and I will do endo bag morcellation. Always.
Just to comment, our morcellator was not working for a very long time, so we took out most of the fibroids vaginally also by cutting, even the big fibroids
Open
by
PODs,
colpotomy
yes, that's
or
the best.
by chunks
Open
through the
POD,
vaginal
avoid
route.
morcellation.
I think
You
mini
know, lot
lab
of
can
time-
also be one of option when the morcellator is not available.
Absolutely. Till 5 centimeters
See,
fibroids, 6 centimeters, dissect them and remove them vaginally.
We can do that very easily.
Yeah, I was having this discussion, and then I said, the moment you've put a myoma screw, you've caused a spill. So why are you worried that if you're morcellating
The moment
in
you
bag or
cut
out?
on the top of the fibroid, there is spill.
Exactly.
If it is leiomyosarcoma, there is spill.
It's spill. Okay. So the point of morcellation is actually making sure that you don't leave a bit.
Yes.
That is the point in the bag.
It is not microscopic. It is basically for macroscopic spillage.
Yes.
The endo bag morcellation is for to avoid
Macroscopic.
macroscopic spillage.
And I
not the
like what
microscopic.
Dr. Amit also, in interest of saving money, I think Dr. Amit has gotten very used to using large gloves to retrieve
Yes,
his
ma'am.
fibroids.
Yes.
So I think that's a technique you can teach us on one of the
Ma'am,
workshops.
actually, I tell you, since my dad is a dentist, he used those drills to sharpen and clean teeth, no? So I have learned the technique of sharpening my blade on my own. So one morcellator blade I'm using 100 times. This
So
is,
you have to
if the
teach us
company
that.
people ever
So
heard it,
now we're
they'll
getting
stop.
the tricks of the trade. You have to teach us.
No, you can actually learn to sharpen your own blades. I have a Diva Care Johnson & Johnson Gynae Care morcellator.
We'll pay you. We'll send you our morcellator blades. Me and Ajay,
Anytime.
whenever our blades
for,
are worn
for
down.
you, I'll do it for free, no issues.
Thank you.
You can
fact,
actually
what
sharpen
I-
them.
what I
it's not an
feel-
issue. One blade you can use for 100 surgeries.
I
I'm using it.
was also looking for a person.
You can just clean your blades with hydrogen peroxide so they don't get jammed, and you continuously you can
hydrogen
resharpen them
peroxide.
and put some oil after usage, clean them before surgery, and sharpen the blade every time you need a new blade.
And so many times it's like less time consuming to take it out vaginally. It's faster. What I have seen, if you just cut and bisect the uterus rather than doing the
See, my standard
morcellation,
norms is like if fibroid is approximately 1 to 2 centimeter,
you don't have
I take those fibroids through the primary port itself. I don't take up the port. I use I5mm scope and I use a claw forceps that is for the gallbladder. I catch the fibroid and I do sort of like mechanical modulation for 1 to 2 centimeter fibroid. All the fibroids like 3 centimeter, 4 centimeter, or up to 5 centimeter, which is fitting in the POD. All those fibroids are to be open the POD and to be taken out from below. All right. And all the fibroids which are bigger than that, if I'm doing it in freelancing, I'm not having morcellator, then I will cut the fibroid in pieces like zigzag shape, and then I will take out from the POD. But in case if I'm dealing with endometriosis and POD is frozen, even if I have done complete dissection, I won't open the POD, because if endometriosis comes back, it will be very bad. Then I will do mini laparotomy.
So take home points. I think one thing which I missed, fibroid mapping. MRIs, as you said, very important. Your fibroid mapping is very important before you embark on any surgery of fibroid. Secondly, you have to protect yourself medico-legally. So in-bag morcellation, but yeah, it's not for microscopic spill. It's only for the macroscopic spill. Thirdly, if you're taking multiple fibroids, then have an alternative method of taking out the fibroids, maybe in the POD or even doing a mini lap. All right. So I'd like to thank you all for your lovely contributions. It was really interesting. I really enjoyed it, and I'm coming to you, Amit, to sharpen my morcellator blade next time.
Thank you so much. We learned
Thank you so much.
Which instrument, ma'am?
it happens, yeah.
We searched for half an hour, but couldn't find. So she said, my laparoscopic surgeon said it doesn't matter. Sometimes we leave the clips and firstly she was worried. Then she said, if we are not getting it, it's not causing any problem.
Clips and
Ma'am, we even put titanium this thing in our spine also, then doesn't matter. I
Clips
think it's
versus a
right.
tip of a sharp needle versus a tip of a myoma screw is very different. Clips are very safe,
No,
but
I
it
think
depends on
she's
what
saying
you've
the
lost.
harmonic, part of the harmonic.
No,
yeah.
most
Tip
of
of
the
the
general
harmonic,
practitioners won't
tip
have
of the
CR.
harmonic. Even Teflon coating is lost at times, it is fine. You try to remove it. If at all you are not able to, then it is
You
fine.
do try to remove it. Do a lot of saline wash.
The
and
problem
try to
is
remove it.
sometimes that port closure needle, it breaks off. The flimsy part breaks off.
That
That's
is
the
something
big
you have
issue.
to, so you have to make sure that it is completely closed when you're putting it in.
Yes.
Under the table, who have a facility for fixing. So you can find it out.
Siam. It has to be used, no?
Siam will not come into my mind.
Right.
Because I have bought a Siam for my hospital.
Not for myself. So it is a C-arm you should have. So at least you can find it out. Like she has find it out in the jar afterwards. Lost so much of time.
Ma'am, once what happened, I was closing the umbilical cord.
One sec. So if you have got that, you can immediately take that X-ray and you can find it out, and your time will be saved. If any other complication later on occurs, so you will be saved from all your, I don't want to name the things.
If you are leaving anything in the abdomen, you are always,
You are always at
in
risk.
that medical
So
legal
it is
line.
much
Always, no
better-
doubt.
It is much better to spend on your Siam.
time extra.
Yes.
And
I am not a Siam person who is propagating for this thing, but I know because for this only we have bought this table for our institute. Okay. And because if you want to do placenta accreta and all, so you want to call your interventional radiologist for embolization, so he can do it only immediately this thing. So you have got a competent person, but you do not have the skilled person is there, but you do not have the instruments. So, and you patient bleeds and all this happens, maternal mortality occurs, so many things happens. Although in the government hospital, not a much problem, but still, it's a patient, it's a person, it's a human life. So I thought I have to invest over it.
Right.
So it is better to have a Siam table.
Right. Agree.
Okay.
Yes, we do have a
Or you can have a compatible table also.
We do have Siams in
Yes,
the
Siams.
hospital, in the
Yeah.
theaters.
Siam. Thank you.
Dr. Rao wants to
Because
add
after
more
6
lines
months,
to this.
so everything is out of my mind.
Thank you, Dr.
Came 2
Zinni.
days
You're
before.
always brilliant. You're always brilliant and nice. You know, the panelists are scared when Zinni is there.
Good morning. My name is Dr. Lalit, and I'm an anesthetist. It was a wonderful experience with all these accomplished surgeons and listening to the panel discussion on laparoscopic surgery. I'm here to just, present my anesthesia perspective for the laparoscopic surgeries. First of all, spinal versus general anesthesia. Most of the surgeons must be doing laparoscopic surgery under spinal anesthesia. From the anesthesia point of view, we would strongly recommend using general anesthesia for laparoscopy. The thing being, the patient is never ever comfortable under spinal anesthesia. I might give a spinal, and then when the insufflation is done, we have to give ketamine and then propofol, a lot of cocktail, but the patient is never ever comfortable during the surgery or after the surgery. So general anesthesia is better for laparoscopic surgery. Secondly, over the last 15 years, I've seen whether the patient is young or thin or has no history of dyspepsia. Whenever I put in a Ryle's tube, the patient always has a lot of aspirate. So in laparoscopic surgery, you must insist to get a Ryle's tube before you insufflate the abdomen. It will save you a lot of gastric. It will help you with a lot of gastric decompression. Thirdly, whenever under GA, while the positioning is being done, let your anesthetist take the call for positioning. I've seen cervical spine injuries when the OT assistants, they take up the patient and, they move the patient without the anesthetist call, and the patient is under GA. It always has a risk of cervical spine injury. And finally, during positioning, never ever let the shoulder go beyond 90 degree. The incidence of brachial plexus injuries, it goes a lot more up when the shoulder goes beyond 90 degree. And as ma'am pointed out, initial insufflating pressures should be around 20 to minimize the risk of visceral injury. But as soon as you are inside, keep your pressures below 15 for 2 reasons. First, cardiac output goes down because of decreased venous return. And second, the more CO2 that gets absorbed, the more hypercarbia that causes, and the more hemodynamic changes, that is high blood pressure will be there, and we have to use, venodilators to bring it down. Thank you very much.
An anesthetist is a surgeon's best friend, and we should remain like that, because there's so many things which can go wrong from your point of view, and when I'm in trouble, you are the one who's going to calm me down. So thank you for your input.
And yeah, ma'am reminded me, good communication is the key. Thank you.
Yes, sir. Thank you so much, sir, for adding tips to this exhaustive session. I would like to continue this session forward. It is imaging in obstetrics and gynecology, and I would like to request our respected Dr. Yashodhara Pradeep ma'am on the dais for being the chairperson for the session. She is Professor, King George Medical College. She has received Best Teacher Award, Best Paper Award. Presently, she is Chief Editor of Journal of Midlife Health. I would like to call Dr. Rajiv Garg on the stage for being the chairperson for this session. He is MD Radiology, Senior Consultant Radiologist at Redneck Diagnostic, Ludhiana. His areas of special interest are fetal USG, fetal echo, 3D, 4D USG. He's a regular speaker at various regional and national forums. He's a trainer, SFM Ludhiana chapter. Now I would request Dr. Yashodhara Madam to please introduce our speaker, Dr. Maneet Kaur.
Good morning, everyone. After the vibrant panel on complication of the laparoscopic surgery, we are going to start a scientific session. And the first speaker of the day is Dr. Maneet Kaur. She is MD Radio Diagnosis, and she's a director of Genesis Imaging Center, Ludhiana. She has got a 10 years post-graduation experience and 6 years in OBGYN fetal medicine. So Dr. Manmeet is going to enlighten us on evaluating a compromised fetus. Does the Doppler say it all? Dr. Maneet, the stage is for yours.
At the outset, I would like to thank the Yuva Fogsi for giving me this opportunity to take up this topic. This is a huge topic. I don't think I'll be able to do justice to this topic in the 12 minutes that have been given to me. But I'll try to put forward some salient points which we must follow.
Dr. Maneet, I request, please be in time.
Okay, ma'am.
Please be in time. Okay. Because I was also a speaker and I left everything. I just came to the take-home message and finished.
Okay.
So
okay,
because we are having all the time constraints.
Sure, ma'am.
Yeah. Thank you so much.
How to identify a compromised fetus? A compromised fetus is the one which, because of a pathological process, is unable to achieve its growth potential or is unable to meet the oxygenation and nutritional demands. We know the causes can be many. It can be uteroplacental, which is the most common. There can be maternal causes like diabetes, pre-gestational diabetes, hypertension, autoimmune causes. And there can be fetal causes in which there may be a congenital anomaly in the fetus. The fetus may be chromosomally abnormal or fetal infections. Doppler says a lot in evaluating a compromised fetus. It's up to us to understand what the Doppler is trying to say. It may not say it all. There are other players which we use to identify the compromised fetus, which may be the size and the growth of the fetus, the amniotic fluid, the biophysical profile, and the cardiotocography. So it's for us to decide which we have to use for diagnostics, for prognostication, and for surveillance of a compromised fetus. The most important thing that we use to identify a compromised fetus is the fetal size. Smallness is used as a surrogate marker for growth restriction. Because of impaired oxygen, there is fetal adaptation, redistribution of fetal blood to the vital organs, leading to reduced blood flow to the liver and body stores, hence the smallness. By looking at the fetal size, we see the smallness and we identify a compromised fetus. However, fetal smallness can be of 4 types. It can be a wrong small, normal small, starved small, or abnormal small. I'll take examples and explain how. This is a hypothetical patient, comes at 35 weeks, 5 days for the first time. And she's carrying a scan which has been done 2 days back, which shows that the growth velocity, the size of the fetus was 33 weeks, 6 days as per AUA. So they have given EDD according to that. So there is almost a 2 weeks lag. Is this a small or compromised fetus? We do not have enough data to say at this point of time. So we'll ask history and get the dating scan. Here is the growth scan. When we take the LMP and assign gestational age according to that, we see that all the growth parameters are low. But when we go back and look at the dating scan, we see that the 2 weeks lag was present from the start only. So now again we correct the date and we see that the fetus is appropriate for gestational age. So we know that this was a wrong small fetus. So whenever we see a small fetus, we have to ensure that the gestational age is correct. Then only we can say that this fetus is less than 10 percentile of the gestational age, and this is a small fetus. And we do not need to use the AUA, which is given by the machine. Once the gestational age has been assigned, we should never change it in subsequent scans. Why is it so important to assign gestational age? We never change our date of birth. Same way, we cannot change the date of birth of the fetus. We assess the growth of the fetus based on percentiles for gestational age. Doppler assessment is also based on gestational age. There are no absolute cutoffs like SD more than 4 or less than 3. We have to use percentiles according to the gestational age. Management protocols are also gestational age dependent. And whenever we use growth charts to see the growth, we need accurate gestational age. Now I take the second type of smallness, which is an abnormal small. We have a fetus conceived by IUI. She had an NT-scan which was normal. Quad test was intermediate risk, 1 in 246. Anomaly scan done at 17 weeks was fine, except for 5 days lag. She did another scan after 2 weeks, again 8 days lag, and the lag was increasing. NIPT was low risk. Here we see that the growth is around 2 to 3 weeks lag is there. So scan was done, the Dopplers are fine, Leica is fine, except for growth restriction and cleft, one-sided unilateral cleft lip and palate, everything was fine. Because we know that these fetuses can have chromosomal abnormalities or other things, we did an amniocentesis and it revealed a 4P deletion. However, not all second trimester detected small fetuses may be abnormal small. Uteroplacental insufficiency can also present at this time. Like in this case, we have a fetus at 17 weeks, 5 days. Growth is less. Umbilical is normal, but we see high impedance flow in the uterine arteries. After 2 weeks, 3 weeks interval, we see all the features of uteroplacental insufficiency. The normals, how do we know whether this fetus is normal small or abnormal small? We look at the growth graphs. This is an appropriately growing fetus. The growth is falling along, going along the curve. Here, there is a normal small fetus. The growth is going almost at the 5th centile, but it is growing. There is no lag in the growth. Even the weight is falling just above the 5th centile, but it is growing normally. So to differentiate a compromised fetus versus a normal small fetus, we can use growth graphs so that we know about the growth trajectory of the fetus. However, if the smallness is due to growth restriction, we see that there is falling percentiles as we monitor the growth. It's important to differentiate these fetuses from normal small because falling growth is a sign of fetal compromise. If we have an AGA fetus, how to identify whether it's compromised? We can have such case scenarios when there is diabetes or coexistent PIH or other causes of compromise, then multiple pathologies are going on. Like diabetes can lead to increased growth, placental vascular changes can lead to reduced growth. The end result may be an AGA fetus, and we may evade detection if we just see the growth. So we use other players like Doppler, amniotic fluid, CTG, biophysical profile, and daily fetal movement count. Now I'll discuss about the role of Doppler. These are the main vessels which we sample during the Doppler. The most commonly used are the uterine arteries, which we use to diagnose placental insufficiency. Umbilical artery, middle cerebral artery, aortic isthmus, and the ductus venosus are the most commonly studied vessels. We have to understand the normal patterns in each vessel, the pathophysiology behind Doppler changes in each vessel, and the implications in cases of abnormal spectral waveform. We always should use the pulsatility index. We have to get SD and resistive index out of the picture, and the pulsatility index also has to be taken in account with the gestational age. I think I'll skip the technique of sampling the uterine arteries. This is the normal waveform of the uterine arteries. We get a high impedance flow up to 12 weeks, and there may be a diastolic notch or not important. And as the gestational age increases, there is decrease in PI and the increase in diastolic flow. Umbilical artery is a very important vessel because it gives us diagnostic information in early onset growth restriction as well as prognostic information. If there is less than 30% involvement of the placental bed, we see a positive end diastolic flow in the umbilical artery. If the involvement is 30 to 50% or more, then we have absent end diastolic frequency, and with greater than 50% involvement, after 70%, we say that there are reversed end diastolic frequencies. These are the normal patterns of umbilical artery waveform. We see that there is gradually increasing diastolic flow with decreasing resistance. Again, one important point is that we should always see the linear pattern of temporal pattern of changes in the Doppler, like we see for growth. MCA Doppler waveform is high resistant throughout the gestation. Impedance is always higher than umbilical artery in normal pregnancies. And this informs us about the existence of brain vasodilatation, which is a surrogate marker of hypoxia. Whenever there is hypoxia, there is cerebral redistribution with decreased PI and decreased cerebral placental ratio. And when the metabolic deterioration is very severe, the MCA Doppler indices normalize. In mild placental disease, umbilical may be normal, but we may see changes in the CPR, leading, and these are indicators of stillbirth and poor neurological outcome. Here we see that the Dopplers are normal, 89% umbilical, and MCA is at 12 percentile. Weight is a little bit less. What should we do next? Is this, should we let it go like that, or is it a matter of concern? Then we see another parameter, which is the cerebroplacental ratio. This is a diagnostic index for late onset growth restriction. It has two parameters. We take MCA PI divided by the umbilical PI. It has a markedly increased sensitivity to detect fetal hypoxia. In late SGA fetuses, the abnormal CPR is present before delivery in 20 to 25% of cases and is associated with a higher risk of adverse outcome at induction. Now, if we have the same fetus, but the weight is at 18 percentile, do we still need to do Dopplers? Yes, the Dopplers are still important because the cerebroplacental ratio as on its own is a marker of impaired fetal growth velocity and adverse outcome. This is the small for gestational age fetus that I showed earlier. The growth is going along the chart. The Dopplers are fine, but when we reach 36 weeks, 6 days, we see that the umbilical artery flow has decreased. There is cerebral redistribution. Even the ductus was showing 0.73 PI. Okay, ma'am. So here we see that the AG or SGA fetus is turning into a compromised fetus. We need to do constant surveillance. Ductus venosus, they become abnormal only in advanced stages of fetal compromise, and absent or reversed velocities are associated with perinatal mortality. But the ductus changes precede short-term variability on CTG, and they are abnormal before biophysical profile in 90% of the cases. So ductus changes are very important in early onset growth restriction. I'll just tell a little bit about early and late onset growth restriction, why it's important to differentiate. Because early onset, we have severe placental disease, cardiovascular changes are more, we have to look for cardiovascular compromise of the fetus. We see the ductus waveform. The tolerance, brain tolerance to hypoxia is there, so we do not need to worry about the CPR changes and the cerebral redistribution. However, late onset is difficult to diagnose because the growth restriction is not marked. The hypoxia is important because the brain is mature and it is very sensitive to hypoxia. Ductus changes are usually not seen. Cardiovascular adaptation is not seen. And it is the late onset fetuses which are prone to lead to stillbirths and perinatal compromise. I'll skip the stage-based management protocol then. Uh, just one slide for this. This is the state-based protocol proposed by Graticos from the Fetal Medicine Barcelona group. It's very helpful for both early and late onset growth restriction. If we have severe smallness that is estimated with third percentile or cerebroplacental changes, umbilical changes, uterine artery changes, we do a weekly monitoring with Dopplers, and delivery is indicated at 37 weeks. In cases of severe placental insufficiency when we have an absent end diastolic flow in the umbilical, we need to do more frequent Dopplers to pick up the worsening of the scenario, to pick up the point when the fetus is going towards acidosis, so that we can take the decision of delivery. When we have stage 3 and 4, we see that the indication of delivery comes earlier and earlier, and this is one chart which is very helpful in both early and late onset growth restriction. Yeah, ma'am, I'm moving towards the end only, ma'am.
Thank you so much.
The other parameters, amniotic fluid is not very helpful in predicting when we should deliver, and a single vertical pocket has to be.
No, I don't think so.
Single vertical pocket is the method which we should use because it leads to lesser chances of intervention, unnecessary interventions. Cardiotocography and biophysical profile scores may not be very important in early onset growth restriction, but they have a role in late onset because they tell us about the brainstem function, the neurological status of the child. And it's important, these two things are important in late onset because the ductus is normal, most of the Doppler parameters may be normal. To sum up, fetal compromise is seen in SGA as well as AGA babies. We use smallness as a surrogate marker. Gestational age and dating are of utmost importance. Doppler is indispensable for diagnosis and management, and it's time to shift to PI and percentiles. Early onset fetal growth restriction follows a chronological sequence of events. We go from changes in the high resistance in the umbilical to absent end diastolic flow, ductus changes, and cerebroplacental changes, and then there is sudden events which occur, perinatal events. So if we follow a state-based protocol for surveillance, we'll know when to deliver. Ductus venosus and umbilical artery are very useful for timing of delivery. In late onset, the screening has low sensitivity. Umbilical and uterine artery may be normal. The only thing that we see in the Doppler may be cerebroplacental ratio. But it's important to detect that because it's late onset is important cause of neurological morbidity and stillbirth. Growth graphs are necessary to assess longitudinal changes in growth. Biophysical profile, daily fetal movement count, cardiotocography, important in late onset growth restriction. And we also should always look for other causes of fetal compromise, which may be difficult to assess by Doppler. Thank you.
Thank you so much, Dr. Mani. Your talk was excellent. But because I have 5 minutes over, still it is 5 minutes over the time which so I just want to conclude to say that dating scan is the most important scan because everything depends upon it, how you are going to follow up. One thing. Then if your CPR is very important, but if it is low, it is more than 1 because normal is 1 or less than 1. If it is more than 1, you should see the cause also. It is not that you jump for the C-section. You should see the cause. Sometimes you have to go retrospect and you see that you have missed the hypertension and the preeclampsia. And as soon as you treat and you repeat your Dopplers in a week's time, you see that it has improved. So it is very important to, one of the person was speaking on the reducing the C-section. So we all have to be responsible, act as a responsible person. Thank you so much, Dr. Mani. It was really wonderful.
Thank you. Thank you. Thank you, Dr. Mani, for this wonderful
Thank
session.
you, Dr. Mani.
Now I
I would like
Dr.
to
Lad.
invite our distinguished speaker, Dr. Ladvan's Kaur, for her talk on imaging in the ectopic pregnancy. She did her MD in radio diagnosis from the PGH Chandigarh, and she's a senior consultant radiologist and director of the Prime Imaging and Prenatal Diagnostic Center, Chandigarh. She's the pioneer in the first trimester ultrasound and 3D 4D ultrasounds, and she has more than 60 publications and more than 200 national international talks to her credit, and her book is forthcoming, which is about the atlas of the first trimester ultrasound. And she has also been awarded the Woman of Substance by the Government of Punjab. So I would like to invite Dr. Ladbans for her talk.
You want to speak? Carry on.
Good morning, everyone. It's a pleasure for me to be here today from Chandigarh. Ludhiana is very special to me because I was born here. So with that, thank you organizers for having me today. And here I am speaking on imaging of ectopic pregnancy. I think it's a very common topic, but needs a lot of attention because it raises everybody's blood pressure. So ectopic is crucial to diagnose because we do understand that early diagnosis can reduce the fatal outcomes by 75%. And as far as the location is concerned, we all know either it could be tubal in 95% or non-tubal in 1 to 2%. Ectopic pregnancy, the various presenting features are well known to you, and they can mimic various gynecological problems other than amenorrhea, bleeding, and positive pregnancy test and a positive beta HCG. We do also understand that there is a certain discriminatory zone of beta HCG, which is very crucial when you think of ectopic, that is about 1,000 to 1,500, but you are supposed to know that there is a limitation where many ectopics are seen with a lower beta HCG, and a single value of beta HCG is not useful. You need to take a serial cutoff, and it's all well known to you as gynecologists. So remember, waiting till the discriminatory zone of serum beta HCG could miss an early ectopic presentation or an intrauterine pregnancy. So transvaginal ultrasound, needless to say, it's the modality of choice because of a high sensitivity and specificity. But remember, you need to add on a transabdominal approach to have a global overview. I do also understand that when the patient is sick, you need to go in and do a transvaginal immediately. But if you do not get your answers on a transvaginal scan, please do not hesitate to go abdomen, fill up the bladder, and that depends upon the hemodynamic condition of the mother. And of course, despite many publications in MRI in ectopic pregnancy, trust your transvaginal ultrasound. So features of imaging are, of ectopic could be tubal or non-tubal. Coming to the tubal are the uterine findings, which could present either in the thickened endometrium, you could see a small fluid in the endometrial cavity, or you could see a decidulized endometrium, which is thickened and shows you small, tiny cystic areas, which are devoid of the chorionic reaction, and that is how you differentiate them from a true gestational sac. That was a recently done ruptured ectopic pregnancy where I saw a large clot in the endometrial cavity with fluid around it. So you can have a varied presentation of echogenic to decidulized to fluid to a large clot. So just to emphasize the difference between a true gestational sac and a pseudo-gestational sac for the beginners, a true will have a sub-endometrial or an exenteric location, would show you a good chorionic reaction, good flow, and as compared to the pseudo-gestational sac will be just a fluid collection, right? In the center of the cavity will be devoid of endometrial reaction and will not show a color flow around it. Do use power Doppler. Better than it picks up slow flow. So that's a clue to your color Doppler. And as far as tubal pregnancy is concerned, you may have varied presentation starting from a mass to a ring to a large mass. And if you're very lucky, you would find an extrauterine gestational sac. To begin first with the blob sign, we call it, the presentation is seen most commonly in 60% of ectopics as an echogenic mass. Remember, whenever you have pregnancy outside the uterus, it will be echogenic. So that helps you differentiating from other structures. One, and of course, color does help you at times. But I use very frequently VCIA when I need a contrast in order to differentiate the grayscale features of a mass other than the ovary. Then a Bagel sign, which we call it as an echogenic tubal ring. The echogenicity is predominantly because of the perichorionic tissue, the trophoblastic tissue. That's why it's echogenic. And generally it is seen outside the ovary, and you will also see a perichorionic flow. We may also see small little bagels like these, and if you see these small little bagels, that can be enhanced by using 2D chroma. That was a hydrosalpinx, which shows you a tiny little bagel, and you do have fluid around, and the Doppler adds to detection. So remember 2 big Bs, bagel and blob sign. And then, of course, life becomes very simple when you have an echogenic and an extrauterine gestational sac itself sitting outside the cavity that is seen and determined by the presence of a yolk sac or a fetal node with or without cardiac activity. But you may be never ever fortunate enough to see, because it happens only in 20% of ectopic pregnancies, and it does have 100% specificity and a good sensitivity. So there is always a common problem of differentiating corpus luteum and ectopic. The only thing I feel is that your 2D characterization is going to help you a lot. Where you find the location, and second, the echogenicity of the corpus luteum is generally hypoechoic as compared to the pregnancy, which is then the form of a blob or a tubal ring. And as you see in this, you see that it's intra-ovarian, and that's the echogenic mass, which is seen outside and does show you the color flow. Remember, Doppler has a limited value in differentiating a corpus luteum and an echogenic or an ectopic. The reason being, both are going to show you color flow, both are going to show you a fire of ring. Maybe fire of rings I feel, are seen more frequently with the corpus luteum other than looking at ectopics. So other problem rises when you have a big mass, but clinical findings do help us. Here you really have to go about looking at how I go and see the ectopics is by first characterization on grayscale. Don't be in a hurry to use Doppler every time. Try to look at the ovary. Try to see where is the mass. Try to look inside the mass. There are hints. Believe me, you have something called as 2D spontaneous contrast. Try to go and search for it. If you find something looking like a swelling motion within a huge mass, yes, you are looking at an trophoblastic tissue. It would show you flow. Why? Because it's the maternal blood which flows into the chorionic tissue. As I just show you in the next slide, and if you're very fortunate enough to show you a tiny little sac in a huge mass in the second picture, showing you a fetal cardiac activity. So I'm just showing you the approach you need to have once you come across with a large mass in the adnexa. So once you see this, you will go further, zoom your image, use 2D, go slow. Go slow in visualizing. That's the spontaneous contrast seen in the chorionic tissue. That tells you there is trophoblastic tissue sitting inside within the mass and helps you formulate a diagnosis, right? And then, of course, Doppler does have a role. I'm not going to say it doesn't have a role. It does have a role because it's going to catch upon the trophoblastic flow. The blood flow is going to be seen with the help of the Doppler, whether in the form of a ring of fire, whether in the form of a ball sign. It may just show you light up sign, or it could be a large vessel which could be approaching towards this ball of fire. So that is how the imaging helps you. Now, the most important feature is the assessment of the extra-ovarian nature of the mass seen in the adnexa. First, going to the splitting sign. That's the ovary, that's the mass. You push upon and you see that they split. They glide against each other, tells you that it's an extra-ovarian mass. But there is a problem to it. The problem is that every patient of ectopic may not be so comfortable with this sign. So we have more markers. Let's see the another one. We see this, we see an echogenic mass, and we see the ovarian tissue, which is seen, the antral follicles which face towards the surface of the mass. So, and another one, the Doppler. The Doppler of the mass and the ovary will have a separate, they will help you to differentiate both the structures because they will have separate vascularity. That means they have a different organ of origin. So these are the things to be exercised on grayscale and color Doppler. Rest is known to you all. We all know about hemoperitoneum, mild, moderate, severe. We know that this is a lady comes to us with gross hemoperitoneum right up to the diaphragmatic spaces, and there was a ruptured ectopic. So, and that was operated with right-sided self-injectomy. Another clue I need to emphasize here is you see this absolutely normal with a clinical history of ectopic. She's had previous 2 cesarean sections. History is not only important for you as gynecologists, it's equally important for us as radiologists or fetal medicine specialists who are performing that scan. Now, this lady with 2 prior cesarean sections will not show you anything on the scan. You need to increase the depth. The moment I increased the depth to 9 centimeters, there was a large ectopic with live ectopic sitting. And I tell you the importance of a transabdominal scan where I could see this ectopic on a transabdominal image very easily. So that's where you need to know your equipment. You need to search diligently for ectopic. And then 24 hours later, she had to undergo an ectopic. But this is just to show you few rare cases who show me with a beta HCG of 500, this turned out to be a stump ectopic. You can have 2 monochorionic, monoamniotic, twin ectopic. Coming to non-tubal sites, the first is the interstitial pregnancy, where you see a location of the gestational sac and the interstitial part of the tube. And of course, you see all this distance, the distance is more than 1 centimeter, thin myometrial rim, perichorionic flow, and yes, the most important thing in this is an interstitial line sign, which is a line which is echogenic line extending from the superolateral aspect of the endometrial cavity, reaching up to the center of the ectopic mass. And of course, it has 100% specificity and sensitivity sign. But sometimes you may have large ectopics. They may produce a bulging sign on the myometrium, and you may not see a sign which is called an interstitial line sign as seen in 3D, showing you a separate mass sitting in one of the cornua of the uterus, producing a bulging sign and separate from the endometrial cavity, what got operated. Another patient showing you the concomitant presence of an intrauterine and an interstitial pregnancy. This is what was a heterotropic interstitial pregnancy with a high beta HCG of 48,000, and 3D helps us a lot. I'm going very fast, but I will finish it, madam. Give me just 2 more minutes. So that's how you differentiate interstitial pregnancy from angular pregnancy. Thus to tell you that angular pregnancy, it's important to differentiate between interstitial pregnancy because angular pregnancy is potentially an intrauterine pregnancy. It has a propensity to give you live births. So we need to understand how interstitial pregnancy is different from the angular pregnancy. The angular pregnancy will be seen in one of the angles of the endometrial cavity and will show you a continuation with the rest of the endometrial cavity. And 3D is very, very useful in addition to your 2D skills. And if you have a large angular pregnancy, may produce a thin myometrial rim, which is as against the angular pregnancy, but is seen in 50% of these angular pregnancies where the myometrial rim is thin. So it's important, as I told you, why do we stress upon this? So cornual ectopics, the terminology has changed. What do you mean by cornual ectopic? I'm talking of ectopic. Ectopic means either it's an interstitial pregnancy or it's a gestational sac which is seen within a non-communicating or a communicating horn of the unicornuate uterus. These are cornual pregnancies. Normal intrauterine pregnancies when happen in the bicornuate uterus or happen in the one half of the septate uterus. Coming to the low implantation, cervical pregnancy is known to you all. 3D helps us a lot. The most important thing is we need to differentiate from an abortion in progress where we see no flow, sliding of the contents of the abortion, and also you may have open external and internal os. This is a lady who we had a concomitant presence of intrauterine and cervical, opted for KCL fetal reduction, had a normal live birth rate. Coming to cesarean scar pregnancy, we do understand there's a defect in the decidua bizalis, and you know all the features where you have an empty uterus and an empty cervical canal, and you have the location of the sac. Remember one thing, if you have a lady who's had a previous cesarean section and has a low implantation of the gestational sac, consider it to have a cesarean scar pregnancy until proved otherwise. Today, we have differentiation of two types of cesarean scar pregnancy. It all depends how it grows. It may grow into the cavity-producing endophytic. It may grow into the sac, into the niche, which you call it as exophytic. So if you have, there are differentiating features on ultrasound today, and they are all precursors for what we call it as placenta accreta spectrum of various grades. If you have an endophytic, you have an accreta. If you have an exophytic pregnancy, you would have a higher grade. What we call it as increta and percreta. And these features, mind it, are seen early in the period of cesarean scar pregnancy implantation. We call it cesarean scar pregnancy because it has a liability to give us birth rate. So just to finish, the take-home messages are heterotropic myometrial, yes. So history is crucial. Talk to your patient. TVS plays a tremendous role. Transabdominal scan is a must to have a global overview of the uterus, adnexa, and even the abdomen. TVS is today not only a physical exam, it gives you a clinical information. In every viability scan you do today, keep an alert for an ectopic every time. Empty uterus with a positive pregnancy test is an alert to tubal as well as non-tubal locations of pregnancy. While scanning IVF patients, think ovarian, think cervical, think heterotropic. In cases of pregnancy of unknown location, mention that you have not seen presently any intrauterine or extrauterine gestational sac. Call her for a follow-up ultrasound and a serial beta HCG. Thank you so much, ma'am. Thank you.
Dr. Ladban's call for your excellent talk. It was, but I suppose cesarean scar pregnancy, and these are the separate topics, and the placenta accreta spectrum, they have, itself has got a 15 to 20 minutes at least to cover very slightly. Thank you. But beautiful cases we have seen.
No, it's okay. Just exchange. ऊपर का
इसको चार है, इसको चार।
इसको बंद कर दो। Yeah, please go ahead. Just introduce sir. जो है आपके पास कनेक्टर।
So I would like to welcome Dr. Chaitanya Nagori sir, who is MD Gynae, infertility consultant from Ahmedabad. 13 years of teaching and 30 years of vast experience in private practice. He is director at Dr. Nagori Institute for Infertility IVF. He has got best papers at World Congress ISUOG 2008 Chicago. First stem cell pregnancy in India, versatile teacher and orator, has trained more than 900 doctors, and we are also looking forward to learn from sir.
Respected chairpersons and friends, I'll be talking infertility, what ultrasound can say about it. Ultrasound is a modality of choice for monitoring of infertility treatment, assessing ovarian reserve and response, assessing follicular growth, endometrial growth, and depending on this, planning the treatment schedules and diagnosis of PCO. How can ultrasound help to decide the stimulation protocol? Two things are very important. How many follicles I'm going to get at the end of the stimulation, and what dose of gonadotropin will I require to get this optimum number of follicles to grow. So reserve and response both are separate thing. Likely number of follicles that you can judge by AFC and ovarian volume, and response can be judged by intra-ovarian flow. AFC and ovarian volume provide direct measurements of an ovarian reserve, while all other tests are always the indirect measurements. And that's why AFC and ovarian volume are very important. This was one of our study which are published, that comparison of AFC and AMH for assessment of the ovarian reserve. For normal reserve and PCO, AFC and AMH are equally accurate, and AFC alone can suffice to ovarian reserve. I would like to point out that we have never undergone any time AMH in our practice. We always depend on AFC. AFC and oocyte-retrieved AFC represents the most useful ovarian response marker of the controlled ovarian stimulation. This is one another study. And combination does not help you to add something more in your practice. And that's why only AFC should suffice. Then second is an assessment of an ovarian response. Measurement of an ovarian stromal flow in early follicular phase is related to the subsequent ovarian response in IVF treatment. So if the flow is more, the response is better. If the flow is less, the response will be poor. VIFI and VFI of the ovary were significantly related to the ovarian response to the stimulation. Now, ovarian stromal PSV after pituitary suppression in an IVF cycle is predictive of ovarian responsiveness and outcome of an ovarian treatment. That's why if the flow is more drug will be delivered to the ovary, and the number of, the response will be very high. If the flow is less, then less number of the drugs will, less drug will be delivered and response will be poor. So as derived from the literature, the ovarian stromal RI and PSV, then you can decide whether it is an hyper responder, normal responding ovary, or the poor responders. On a baseline scoring system, we have devised this system. It has been already published, but with the help of the color Doppler, age, BMI, AFC, ovarian volume, stromal RI and stromal PSV, we decide the stimulation protocol. And this is the ideal way that we decide how the patient should be stimulated. And according to this scoring system, according to the markings, we can go for our IUI and IVF freezing cycles. So we never come across any complications if we follow this scoring system. Now for the IUI cycle, if there is no response, you can see that if the response is poor, particularly when the score is less than 10, then you increase 75 units. If the score is between 10 to 20, and if there is no response, then you add 37.5 to 75 on day 7 of the stimulation. And it is 10 to 20 or more than 20, then you increase the dose to 37.5, either from day 10 or day 14. This is Professor Roenberg has also said that chronic low dose stimulation, it is exactly when the score is more, then you have to add only 37.5 after 14 days of stimulation. Then you will never come across OHSS. This is the same way for IVF cycle also. If there is no response and score is less, you add 75 international unit or 150 of HMG. And if the score is between 10 to 20, then add 75 international unit recombinant FSH and add 37.5, particularly when the score is 20. So HMG is not to be added to all the patients. It is to be added to only those patients who gives you the poor response. Then the HMG will have some role in it. If elevated LH may be responsible for increased stromal vascularization due to neoangiogenesis, catalogenic stimulation, and leukocyte and cytokine activation, then why LH in poor responder? High resistance or the low ovarian stromal flow, mean ovarian response, and that's why the LH supplementation is required. Means low LH, low bioactive LH, or the LH polymorphism is present. So whenever you get a poor response, either the LH delivery, LH is low, or second thing is LH, bioactivity of the LH is low, or there may be LH polymorphism. And this is particularly very common after the age of 35 years. Now deciding the timing of trigger ultrasound will be very useful. This depends on the follicular maturity and endometrial receptivity, and how can this be rightly decided? Not by just putting the size and the thickness. By knowing the size and thickness, many a times the follicle may not be mature. By 2D ultrasound, we know the size We know that in some of the patients, we can see the cumulus and separation or the folding of the follicular lining 6 to 10 hours prior to ovulation can be seen. Now, Doppler reflects the functional changes occurring in the ovaries and uterus during the cycle. What you see in 2D is an anatomical maturity, and what you see in color Doppler is the functional maturity. So, pre-trigger, perifollicular Doppler, when we do, the vascularity should cover 3/4 of the follicle. RI should be between 0.4 to 0.5 and PSV should be more than 10. This is the right mature follicle. It is the time of giving HCG to the patient. If you give HCG earlier, then it's of no role. If you give late, then also it is of no role. That's why vascularity should cover 3/4 and RI should be less than 0.5 and PSV more than 10. These are very important features as far as the maturity of the follicle is concerned. Now, if the PSV of the follicle is less than 10, then there are all the chances that the embryo with the chromosomal abnormality will be there. And that's why never give HCG till the PSV is 10 centimeter per second. Follicle with more uniform polyfollicular vascular network are more likely to produce the pregnancy. So you can have a general view, a global view you can see, and if the vascularity is very good throughout the follicle, the pregnancy rates are very high. It is almost important to confirm the maturity of the follicle in at least 3 follicles in each side of the IVF cycle. You can see the cumulus, particularly when the number of follicles are less, then you can decide whether the cumulus is present or not. And when the cumulus is present, then fertilizable ova will be available to you. Now, with multiple follicles recruited, 3D with the sono-AVC is a preferred modality for the calculation of number of follicles and their size. Here you can do sono-AVC. So this is particularly very useful in PCO patients. You can exactly calculate how many number of eggs you are going to get from the patient. Now, how is this information helpful to decide the time of trigger, to decide the type of trigger? Now, here the number of follicles are more, so you have got an option. Instead of giving HCG, you should give trigger with GnRH agonist. This is famous Professor Humari's paper that when you get now number of follicles more than 25 of more than 11 millimeter size, then you should freeze all the embryos. All the embryos should be freezed, no transfer is done. But when E2 is less than 4,000 and number of follicles are more than 11 and 25, and the number is less than 25, you should give HCG at the time of pickup for a fresh transfer. For a fresh transfer, you can give HCG 1500 units at the time of ovum pickup. So whether to go for the fresh transfer or whether you should freeze all the embryos can be decided simply by an ultrasound with the help of the sono-AVC. Now, endometrial receptivity and assessment, whether the quality is good or not for IUI, for fresh IVF, for frozen transfer. It is not just the endometrial thickness and morphology are important. Peristalsis is also observed by some. But it is important to assess the endometrial vascularity for the actual assessment of the endometrial receptivity. This is in 2D, you can see in the follicular phase as well as in the secretory phase. Progesterone exposure to endometrium. This is very important because in IVF cycle, we are worried whether the progesterone is more than 1.5. But if you see the short-term and physiological exposure to progesterone, fluffy outer margin of the endometrium is necessary for the LH surge and further development. More than 24 hours if it has passed, then you will get the exposure to the progesterone hyperechoic outer margin. So this is the difference you can make out, that the progesterone has started and the progesterone has already occurred for more than 24 hours because of the fluffy margins that you can see. Endometrial and subendometrial vascularization may serve as a prognostic marker for ongoing pregnancy, unlike any other marker of the endometrial receptivity. And that's why the vascularity is very important. Vascularity, endomyo junction, zone 1, touches the outer wall, zone 2, enters the endometrial cavity, zone 3, and touches the midline is zone 4. The vascularity in zone 3 and 4 are the excellent markers where the pregnancy rates will be very high. And this was also one of the study we published that beta HCG is positive, particularly when vascularity is in zone 3 and 4, and gestational sacs are seen, and the abortion rates are quite low. It is therefore very essential to confirm the endometrial flow prior to IUI or prior to IVF or prior to prior to embryo transfer. So that is why the vascularity plays very important role to get the pregnancy. If the upper limit of the cutoff of the uterine artery PI, if PI is more than 3.3, no transfer should be done. See, this is how the color Doppler is very useful, that if uterine artery PI is more than 3.3, no transfers are done, freezing of all the embryos are done, and transfer in the next cycle. This is endometrium volume should be between 3 to 10. You can go for VI, FI and VFI values of the endometrium. And this is a very good study by Kupasik et al. That the lower resistance index, 0.49 to 0.57 in some endometrial vessel and FI. So higher the FI, lower the RI is the marker for the implantation. This was also one of the study we published, that 3D power Doppler are very important, particularly FI more than 40 and VFI more than 20 can give the excellent implantation rates. Significant increase in the resistance of the uterine after 48 hours after the trigger, and that is why all the parameters are always done before giving the trigger. After the trigger, the parameters change, and that is why assessment is always done prior to the trigger. Vascular changes at this time of impending ovulation includes increased vascularity of the inner wall of the follicle, coincide with the surge of the blood velocity just prior to eruption. Just 1 minute, please. So start of the surge is indicated, particularly when RI and PSVs are very high. This is recommended for early IUI. This was our paper, that when you go for double IUI, particularly at 12 hours and after 36 hours, particularly when PSV of the follicle is very high, then you do double IUI, first at the 12 hours, second after 36 hours. So always PSV is very important when you decide the timing of HCG. Thank you very much.
Excellent talk, Dr. Nagori. I know you are a very, very academician. So it was a beautifully, the 3D pictures and the power Doppler pictures have been shown.
Thank you, sir, for this nice talk. Now I would like to introduce Dr. Sonal Panchal, ma'am.
No, I don't want to ask because
Her talk is on IOTA screening, simple rules. She is an USG consultant at Dr. Nagori Institute for Infertility and IVF, Ahmedabad. She is a dedicated infertility-related USG specialist and practicing since 1999. She is very popular teacher and orator. She has more than 75 chapters in different books and trained more than 800 doctors. Please, ma'am.
Thank you very much for those kind words, and I assure chairpersons to finish on time, though I know that IOTA is a very big topic, cannot actually be completed even in 3 hours. I know I'm going to concentrate only on simple rules, but if we are talking about adnexal solutions, to cut down that short is really going to be difficult. Let me take a chance and try my level best. So the basic questions whenever you see any adnexal lesion is what? It is it ovarian or extra-ovarian? Second, whether it's a functional or a pathological cyst or a lesion, and that is a very important question because most of the times we as radiologists would report any cyst that has any echogenicities inside as complex cyst. And this is where I really want to make a point. We all report these cysts as complex cysts. These are most of the times corpus luteum. So it's very important to understand the reproductive physiology a little bit before we report this cysts as complexes. This raises a lot of anxiety in patients as well as in gynecologists. The third is whether it is benign or malignant, and the fourth, whether it is a specific, what is the specific diagnosis. Ovarian and extra-ovarian, I think Dr. Dr. Ladbans has also shown this very beautifully. Why is this clip not working? Okay, anyway, so she's very beautifully shown in one of the tubal pregnancies where you press the probe in and out, and you can see the sliding of the two structures, ovary and the lesion, side by side, and that tells you it is an extra ovarian lesion. So the same sign, if you can elicit here, if you can see the cystic lesion, you're seeing the ovary, you press with the probe, you can separate the two, you know it is extra ovarian. But if you don't see that sign, if you're seeing the beak of the ovarian tissue, or you're seeing the ream of the ovarian tissue, that will tell you it is intra-ovarian. So that tells you it is extra-ovarian, that tells you it's intra-ovarian. If both the signs are absent, that means you cannot separate from the ovary, and you are not seeing the beak and the ream sign, it is extra-ovarian lesion, which is adherent to the ovary. So now you know the origin. Coming to the functional or pathological part, information of the phase of the cycle is very, very important. Whether the patient has taken any drugs for ovulation induction or not is very important. And a thorough knowledge of the classical appearances of physiological structures like follicle, corpus luteum is very essential. This I'm making a point because, again, follicles are quite easy to identify. We all know they are anechoic structures with thin walls, but when it comes to corpus luteum may have a very varied appearance, starting from the typical fibrine strands in the anechoic cystic areas. It may be a cobweb appearance, it may be a fishnet appearance, but sometimes the corpus lutea are absolutely isoechoic. And unless you are very, you are looking this patient in a secretory phase, and you try to identify them and put on a Doppler and see a ring of color, it might be almost impossible. So mind you, please don't miss those things. Then coming to the last two questions, which is whether it is benign or malignant, and coming to the specific diagnosis. Of course, it is important to keep in mind the prevalence of the different lesions also, but let us not go into the more details of that and go towards answering these two questions, whether it's a benign or malignant, and whether we can arrive to a specific diagnosis just based on ultrasound. This is what is the strategic analysis of the lesion, and we call it IOTA, which is International Ovarian Tumor Analysis. It consists of course, the correct terminology for the description to be used. It consists of certain easy descriptions, say for example endometrium, ground glass echogenicity, and so on. And there are certain simple rules, and then you go for a logistic regression and expert opinion. So these is the entire IOTA, but we are not going to go into that. Today, I'm going to discuss only simple rules, and when I'm going to talk about the simple rules, it is very essential that before that, if I really want to say that I'm going to talk about simple rules, this 2 slides is enough. What simple rules is, when there's the IOTA says that when there's a unilocular cyst present of solid component of largest of less than 7 millimeters, acoustic shadowing, smooth multilocular tumors with the largest diameter of less than 100 millimeter, or no blood flow, color score 1, which means it's a benign lesion. And then there is a list of other characteristics which says it's a malignant lesion, like irregular solid tumor, presence of ascites, at least 4 papillary structures, irregular multilocular solid tumor of larger than 100 millimeter, and a very strong blood flow, color score 4. Now, if I just say this much, you all will be confused. What is an irregular solid tumor? When do I say this is ascites? When is it an irregular multilocular solid tumor? So it is very essential that before I actually finish the presentation right there, I have to tell you something about the correct terminology for description, as well as what do we mean by the correct pattern recognition and easy descriptors. The easy descriptors is a little short and easy to finish quickly, so that's why I've taken it first, and then I talk about the correct terminology used. For easy descriptors, you all know that we have certain lesions which have definite echogenicity, which have definite ultrasound features. and therefore they are quite easy to diagnose, and these are put as easy descriptors in the IOTA also. It has almost 92% sensitivity and 93% specificity for differentiation between benign and malignant lesions when we are talking of IOTA, but when it comes to truly easy descriptors, it's really not that huge sensitivity and specificity. But still, we can diagnose lesions like endometrioma, benign cystic teratoma, simple cyst, cystadenoma, cystadenofibroma, functional cyst, fibromas, borderline tumors, stromal cell tumors, and germ cell tumors, and still a few more quite easily. But as I told you, before that, we have to understand what is the correct terminology to be used to describe these lesions. The things that we are going to describe are septum, solid projection, papillary projection, because if I'm using these words, you must know what we mean by that: wall irregularity, shadows, ascites, etc. Directly going to the terms and their explanations: septum, thin strand of tissue running across the cystic cavity from one to another internal surface of the cyst is a septum. If on one or more sections you see that the septum is incomplete, it is an incomplete septum. That means it is not reaching the opposite wall. That is an incomplete septa, and those are complete septa. The thickness of this septum is important to be measured, and it is not to be measured where it is attached to the cyst wall. It is measured somewhere in between where the septum thickness is the highest. Then coming to the internal echogenicities, it may be due to clots, due to fibrin strands, can be differentiated from the septa by the concavity of the margin. Remember that whenever there is a fibrin strand and not a septum, as you are moving from one side to the other side or following the fibrin strand, you will see some concavity of that of the shape, and that concavity of the shape tells me it is not a septum and it is a fibrin strand. You are seeing that concavity here also. That tells me it's a fibrin strand, and this is very important. It is not always just the thickness which can tell you it's a fibrin strand or it is a septum. Solid component which exhibits high echogenicity, suggesting presence of tissue, irregular, thick wall, regular septum, or normal ovarian tissue is not considered a solid tissue. That means that you may have slight irregularity of the walls of the cystic lesion, or you may have a normal ovarian tissue just by the side of the cystic lesion. This is not a part of the lesion, and this is not also a solid projection. But whenever there is a doubt, there may be a blood clot or any debris, and you definitely have a doubt whether this is a solid lesion or not. It is always to be taken a benefit of doubt and said, yes, it is a solid lesion, to give a more a safer diagnosis. Remember that solid projections, they are attached to the walls, and therefore as you move the probe in and out, they will not move, they will not slide against the wall, which tells you this is not a solid projection, that is a debris. You are seeing a debris here which moves against the wall, whereas a solid projection which does not move similarly. Moreover, the solid projection may commonly have either a concave wall, a convex wall inside the cyst, or it may have a thick flattened plaque-like lesion, whereas when it is a debris, it is usually parallel to so it follows the gravity parallel to the floor, or the x-axis is the surface. Even if you move the probe, it will go and settle there. Reflective avascular area in the center of the dermoid or the sludge is not a solid component, and this is very important. Papillary projections are solid projections, so they are very small solid projections. They are usually less than 3 millimeters. The solid projection from the cyst wall into the cavity within, up to 3 millimeters in height, it's called papillary projections. Again, very important that you may have smaller lesions, and there even tiny papillary projections may look like solid projections because they proportionally appear large. But remember that you have to identify, even if it's a hydrosalpinx, you may probably not be able to differentiate surely between papillary projection and between the normal hostra, and there it is better to consider it as a papillary projections. The measurements are very important. Ma'am, I'll just take 1.5 minutes or 2 minutes more. And papillary projections or solid projections, how to measure them is very important. If you can still see the inner cystic wall, that's when you measure this height and you measure this as a base. But when the inner wall is not, inner cystic wall is not clear, it is almost, included into, and it cannot be differentiated by echogenicity also from the cystic wall. That is when you draw a line on the base of the solid lesion, where usually it is the broadest part, and measure the height there. And so that is your base and that is the height. So that is a bit tricky, but yes, that is how you measure the solid projections. Coming to the solid projections or papillarities, the vascularity details are very important. So finishing that, going to the internal cyst, the cyst wall, any irregularity of the cystic wall is important to be documented. Remember, whenever there are papillary projections, there are always irregularity of the cystic walls. But when you are seeing solid projections, solid lesions, that's when you don't have internal cystic walls. That's when you look at the regularity or irregularity of the outer wall and document it. Contents of the cystic lesion, they may be anechoic, they may be hemorrhagic, they may be ground glass, low level echogenicities or mixed echogenicities. Mixed echogenicities may be because of fluid level, they may be because of large clots, they may be because of abscess, pus collection, or they may be because of solid areas like in dermoids, which may be hyperechoic cysts, or hyperechoic balls. There may be hyperechoic dots or lines. Then it is important to document whether there is a caustic shadowing present or not. You document ascites, and I'll not go into the details of that. And then the final is the type of the lesion. You call it unilocular only when there are no septa. They may be anechoic, they may have ground glass echogenicity. But then going to unilocular solid, remember it's a unilocular lesion. Any single solid projection, it is a unilocular solid lesion. Then you may have a multilocular cyst, but no solid projections. And then you may have a multilocular cyst with a solid projection. That is what is multilocular solid. And then you have solid, where more than 80% is the solid component. That's what is a solid lesion. And there are some which are not classifiable. But remember that this final classification is very important about the total look of the lesion, unilocular, multilocular, with solid or without solid component, because the lesions with solid components and those which are multilocular have very high risk of malignancies as compared to the ones which do not have solid projection, solid components. Vascular score is very important. No vascularity, half a minute, 30 seconds more, 30 seconds. These are last 3 slides. So vascular score, no flow is 1, minimal flow is 2, moderate flow is 3, and strong flow is 4. And remember, score 3 and 4 may have a huge a doubt of malignancy. Now coming back to those same 2 slides, and if now I repeat this, you will definitely understand what I'm talking about. If it's a unilocular lesion, there's a presence of a solid component with the largest diameter of less than 7 millimeters. When there's an acoustic shadowing, when there's a smooth multilocular tumor of less than 10 centimeters in diameter, and there's no blood flow, that is a benign lesion, benign simple rules for benign lesion. Whereas when you see irregular solid tumor, presence of ascites, at least 4 papillary structures, irregular multilocular solid tumor of more than 10 millimeter, and very strong blood flow, that's when you doubt malignant lesions. But when you have doubt beyond that also, that is when you can use what is called logistic regression, which is again a part of aorta. But very important is what? Whenever you still have doubts and you have inconclusive diagnosis, that's when expert opinion is most important. And though the entire aorta protocol has a high sensitivity and specificity, only expert opinion without applying these rules also has a sensitivity of 90% and specificity of 93% for differential diagnosis of benign and malignant lesions. Thank you very much, and sorry for overshooting the time.
Thank you, Dr. Sonal, for excellent talk.
Thank you.
Just I would like to add one thing.
Yeah.
These ORTA rules cannot replace the good subjective assessment if you have good training and good experience.
Yes, of course. It cannot be applied. You need an IOTA certification. That's why I said you cannot just use it. I mean, you cannot even finish in 3-4 hours, but that's it.
And second thing I would like to add that poor quality imaging cannot substitute, this ORTA rules cannot substitute the poor quality imaging also.
That's what, yeah. That's why the expert
You have to
opinion.
use the good quality machines, good
It has to be. There are a lot of
imaging.
things, but because I had to talk only about simple rules, so, and 12 minutes, you know how short that time is.
It was an excellent talk.
It cannot replace your scanning skills. It cannot replace a good quality image. So optimization of the image comes the first. It cannot replace dynamic imaging. It cannot replace the vascular pattern. So there are a lot of things. It basically, I would say, when you have an adnexal lesion, when you are not sure about what it is, and you are only confused, I mean, you just want to make sure it's benign or malignant, that's when IOTA is to be applied. Otherwise, your clinical acumen, I mean, your scanning acumen, the correlation between clinical and ultrasound findings, as well as maybe even some biochemical markers, is all what needs to be put together to come to a correct diagnosis. This is just an additional tool for convenience.
Ma'am, we do
Thank
get
you, Dr. Sonal.
patients.
Yes.
One question.
Questions? Yeah.
We do get patients who have a long-standing endometriosis with borderline high CA125. So, do you find any difficulty, like to predict if it's a cancer or if it is
Never
still benign?
ever, because one, if it is malignancy, CA125 needs to be pretty high. Moreover, it is, even if the CA125 is normal or rising, so the rate of increasing of CA125 levels is what is important. Third, the vascularity. In endometriomas, it's pretty less vascularity. Of course, that vascularity also changes with the phase of the cycle, but it's usually described as short course vascularity, where the blood vessels come and approach the walls of the lesion, but they do not run along. It's not a low resistance vascularity. It is tender on probe pressure. And these are the findings which tells you, no, it's less likely it's going to. Yes, it's true that in endometriomas, if that patient undergoes, gets pregnant, there may be a decidualization of those lesions where you will see solid projections inside. You may also see vascularity in those solid projections, and that may raise a doubt of malignancy. But then if you have seen this lesion earlier, if there's still pain on probe pressure, you can probably correlate it better.
Yeah, thank you.
Yes. Thank you so much, Dr. Sonal.
Thank you.
In a short time, you have done justice to your topic.
Thank you. Thank you very much, ma'am.
That's all I can say. But I may say that it was a lot of problems were there. Since the IOTA has come, at least there is some standardization has occurred. So even people who are not that skilled, but they're having a good machines. They are not very skilled, but they're having a good machines. If they follow the IOTA classification, they can give the good report. Yeah, they can give the good report. Yes, and plus, if you are really worried about your malignancy, it has to be, everything now is getting multifactorial. So you have to put the classification, like yesterday I was talking about the P, that you have to fill the forms and you have to add age, menopausal status and everything, the family history, the genetic history, and then you put your biochemical markers and then you put your imaging markers and then calculate the risk. Only then you are going to get this thing. Otherwise, it used to be, I know many women who has been diagnosed as ovarian malignancy came to us as a second opinion, And we said there's nothing. It's because there's a pelvic vascular syndrome, like is a varicose veins in the males. It is also there is a female also. So it never, once the Doppler was not there. So it is only the fishnet appearance of the black and white used to be there, and people used to report it as a ovarian malignancy or something, because many of my friends' mothers were also diagnosed. Then we said, we just bought a Doppler at that time. So we said no. And they're still alive. They have 80 plus or something like that. So you can avoid the surgery. You can put them into this thing. You can avoid the anxiety. So many things can happen. So your skill is very important. Your machine is very important. But at least aorta classification is reduced the unnecessary surgeries, which used to happen. Yes. Thank you so much.
I would like to thank Dr. Sonal and Dr. Chaitanya for coming all the way from Ahmedabad and making us more wiser. And I'm thankful to our chairpersons, Dr. Yashodhara Madam and Dr. Rajiv Sir.
We can have one photograph. I know your name from my husband's, Dr. P. Srivastava. I remember that recently you were having some webinar or something. So I remember that I was cooking something in US. So and you was speaking something. Yes, I remember. So I remember. एक हमारे को एक फोन से ले लो क्योंकि मेरे पता नहीं कब मिलेगी जब आएंगे लो लेकिन बहुत एक
दूसरा अपना ही लगाइए मेरा ओपन कर दीजिए यही वाला है ना तो मैं एक स्लाइड हटा रही हूँ इसी वाली इसके ऊपर खड़े हो जाओ क्या ऊंचा बहुत सुनता नहीं अच्छा बात भी कर रहे
Thank you, everyone. Now we have a very beautiful lady with us, Dr. Nilanchali Singh. She is here for the Fogsi Dr. Kamini Rao Oration 2022. Fogsi for all, always, Dhira, Stop Violence Against Women. Dr. Nilanchali Singh is an assistant professor, Department of Ops, AIMS, New Delhi. She is a clinical fellowship in Gynae Oncology, TBCC, Canada, fellow IARC, IFCPC colposcopy. She has received around 50 awards nationally and internationally. She has more than 100 papers publications to her credit. She has rich experience in her field. I would like to call her upon stage for the oration.
Thank you for the kind introduction. At the outset, I would like to thank Fogsi and Yuva Fogsi for allowing me to speak on this topic of national, civic, and social importance. Actually, it is not a topic. It is an emotion, violence against women. It is a proud privilege to talk about this Fogsi initiative, Dhira. Dhira means courage, courage to stand against violence against women. The WHO has labeled violence against women as any act of gender-based violence that results in or is likely to result in physical, sexual, or mental harm or suffering to women, including threats of any such act, coercion, which whether occurs in public life or in her private life. And what is intimate partner violence? It's just an offset. Any behavior within an intimate relationship can be husband, can be live-in partner, or can be boyfriend that causes physical, psychological, or sexual harm to those in the relationship. There are many risk factors for violence against women. The WHO has said that low levels of education, history of exposure to child maltreatment, antisocial personality behavior, harmful use of alcohol, low level of women access to paid employment, and low level of gender equality are few of them. If we talk about the global burden of violence against women, globally, 1 in 3 women worldwide have been subjected to either physical or sexual intimate partner violence. And if we talk about the areas, Southeast Asian region, that is India, comprises of a very, very important part of it, 33% in Southeast Asian region. If we talk about Indian data, around 40% of women suffer from intimate partner violence. So I had a privilege of talking with the ASHA workers. I have got a grant from the American Society of Clinical Oncology in which I work with the ASHA workers where they do screening for cervical cancers. And this is one of the experience from the ASHA workers.
नमस्ते, मैं जिम्मेदारी में रहती हूँ। वहाँ पे मेरे एरिया में इतना अत्याचार होता है। एक लेडीज है, उसके 5-6 बच्चे हैं, उसका आदमी इतना मारता पीटता है और हाथ पैर तोड़ के पटक देता है और बच्चों को थाने को तक जाने नहीं है। और लेडीज बोलती है तो उसको कमाने के लिए बोलती है तो मारता है। दारू पीने के लिए पैसे देंगी पर खाने के लिए बच्चों के लिए बड़े मुश्किल से वो पालन पोषण करती है। बेचारी कोठियों में काम करती है, वो भी मार पीट के ले लेता है रात को दारू पीने के लिए। बच्चे इतने मतलब सूख के लकड़ी हो रहा है सारे बच्चे, मतलब कुछ पोषण भी नहीं मिलता बच्चों को, मतलब कि एक बाप की वजह से ऐसा ऐसा औरतों पर अत्याचार है। नमस्ते।
And this was from one ASHA worker. I mean, I have talked to multiple of them and each one had a story to tell. This is so prevalent in our society and we are so oblivious to it. There are many health issues related to intimate partner violence, not just physical injuries, but also mental injuries, depression, substance abuse, other physical illnesses, chronic pelvic pain, STIs. All these are so prevalent. And it is the responsibility of each one of us to stand up for our fellow women who go through violence and say no to violence. What is the role of obstetricians and gynecologists? Being the first point of contact for women's health and emotional needs, we have the responsibility towards providing quality care to our women. Fogsi is committed to rising, speaking up, focusing, and partnering with all the stakeholders and take this forward. What is our role as a leader and a stakeholder? The WHO says that we are advocates to make violence against women unacceptable, address it as a public health problem, prevent recurrence of violence through early identification of women and children who are experiencing violence, providing appropriate referral and support, and generate evidence by carrying out population-based surveys. We have to include violence against women in demographic, health surveys, surveillance, and health information systems. And as recommended by WHO, I did a very small part of it. I did collect some evidence. So this was an article which was published in 2016 on intimate partner violence, associated factors and acceptability of contraception among women with IPV. And the objectives of this study were to find out the prevalence of various types of domestic violence, to identify associated risk factors of intimate partner violence and to find out the relation between IPV and contraceptive adoption. And there were self-made questionnaires, very, very simple questions. Did your husband ever threaten you or beat you? Have you experienced any forced sex by your husband? Have you had verbal abuse or emotional trauma? How did he react when you talked about contraception? And how did you react when you talked about this? Or how did you react to the violence inflicted by him? And this data showed that education of women, education of partner or husband, and the monthly income are significantly associated. And this means that women's education is very vital, partner education is important, and the money earned in the family is also equally important. All these lead to intimate partner violence. And when we talked about the type of violence, forced sex, physical abuse, verbal abuse, they all were very prevalent. Now, if we talk about the response to these violence, to our surprise or to no surprise at all, toleration was the most common response. Women tolerated and tolerated. Only few of them informed their parents, and the parents also asked them to tolerate. So this is the response which is there in our Indian women. And if we talk about the contraceptive adoption, so most of the contraceptive adoption depends upon presence or absence of intimate partner violence. So the conclusion of the study were that violence against women is very, very common, and higher percentage of women with IPV accepted some forms of contraceptive methods as compared to those with IPV. And healthcare providers need to be more sensitive to issues of intimate partner violence. So now you may say that this was a small study. What impact did it make? So after the study was published, there were many, many media partners, many media or newspapers or televisions which quoted this study and published articles on intimate partner violence. This was from India Today, which talked about intimate partner violence. From India TV, again talked about intimate partner violence. Lokmarg, and not just English dailies, but also Hindi dailies, they talked a lot about intimate partner violence and contraceptive adoption. So one small article done at one center created this much uproar. And not just in India, the Daily Mail UK, the UK online daily, also talked about this study, and they said that women are beaten up and it is common practice. So a very small study created an uproar, and this must have affected the society for sure in a very small way, but it did. This is what WHO wants us to do as a gynecologist, as a healthcare provider. The 10 ways devised by United Nations women, which are effective strategies to end war, are: listen to and believe the survivors, teach the next generation and learn from them, call for responses and services fit for purpose, understand consent, learn the science of abuse, start a conversation, stand up against rape culture, fund women organizations, hold each other accountable, and know the data. And this data knowledge, the onus lies on us because we can collect the true data. We are the first-hand respondents. The Government of India came up with Protection of Women from Domestic Violence Act 2005, and it states that any act, conduct, omission, and commission that harms or injures or has a potential to harm will be considered as domestic violence by the law. And how effective it is. It takes into account all the types of domestic violence, empowers judges to implement restraining orders, requires abusers to pay maintenance to the victim, grant property rights, and right to shared homes. This is a very progressive move, and it covers the live-in couples as well. Even with this law being there, what is the ground reality? Some other ASHA workers spoke about it.
हम 100 पे कॉल भी करते हैं पुलिस वाले को, फिर भी वो एक सेटलमेंट करते हैं कि आपका किसी को बोलते हैं कि आपके घर में रेगुलर ही अत्याचार होता है, तो ये रेगुलर है, या तो आप हस्बैंड को छोड़ दो या अलग से रहो। ठीक है, फिर भी हस्बैंड नहीं छोड़ते। और किसी को ये बोला जाता है, जो और औरतें कंप्लेंट करते तो कहते चलो कभी कताल आपके घर में होता है तो आप सेटलमेंट करवा लो, वो पुलिस वाले खुद हस्बैंड को बुला के सेटलमेंट कराते हैं। तो ये होता है, तो ऐसा नहीं है, एक अलग से स्टाफ होना चाहिए कि जिनकी जो प्रॉब्लम है वो अलग से सॉल्व होनी चाहिए। अगर सभी हम
So this atyachar is very, very common. And even if one goes to the police, they are asked to settle. So we are nowhere near to uprooting this. And therefore, Foxy came up with this new initiative by Professor Dr. Santa Kumari ma'am to stop violence against women, Dhira. The main objective of this campaign is to advocate people and create awareness in violence against women and to sensitize self-victim male partners and the fraternity. Dhira was launched at the FIGO conference Rio in 2018, and FIGO declaration on no to violence against women in conjunction with the WHO was signed at FIGO. And then on all the pages of FIGO, the social handles, the media, our Indian gynecologists shouting about violence against women were there. Such was the importance. Dhira means courage. It has 5 pillars. One is Dhira Online School Certification Program to educate boys and girls. Pillar 2 is workshop and CMEs for obstetricians and gynecologists. Pillar 3 is online school certification program for 9 to 12 standard. Pillar 4 is intensive community level work, raising campaigns. And pillar 5 is engaging government, Ministry of Health and Family Welfare, Ministry of Women and Child, and Ministry of Education. And therefore, Dhira has incorporated NGOs, police, law, government, international professional organization, women commission, and human rights organization. The activities under Dhira are public forum, social media page, flash mob, walkathon, bikeathon. And the online certification course is very, very important. The sessions are structured by Foxy Expert, and the course is in collaboration with UNICEF. It stands for 9 to 12 standard children. And there are many, many workshops which are conducted. One was on the International Day for Elimination of Violence Against Women on 25th November. It was a great program. I happened to attend it, and it was an eye-opener for me. Then Foxy has the Anti-Violence Against Women Cell. There's a web page for it. And they came out with the position statement on violence against women, in which they state that Foxy recognizes that violence against women is a serious abuse of human rights beside being a public health issue. And Foxy is committed to empowering the youth by promoting sexual and reproductive health through education and advocacy. And here in the North Zone Yuva Foxy, we had the Dhira Walk. It was a very successful event. And this is such a lovely picture with the gynecologists assembled here. And I could not stop myself from stealing it from the Facebook page of Shanta Kumari ma'am. So this is a picture of it. So there are so many events which are being organized. And the final goal of Dhira is to engage the government and make it mandatory in curriculums. Men can be very important partners in preventing violence against women, change in their own attitude and behavior, and by intervening others to prevent men's violence is something which they can do. Just like COVID, there is a pandemic of violence against women too during this COVID. And the causes are loss of job, loss of education, loss of money. And because of this, the war pandemic has also been risen. So this article was published by us, COVID-19 Endangering Women's Mental and Reproductive Health, in which we talk about spikes of domestic violence, sexual harassment, and limited access to healthcare globally. And we talked in great detail about violence against women and intimate partner violence. And again, a very small move, but the effect is not so small as we think. This article was featured on the WHO page as the first article. That means even small changes which we want to make by writing small articles, small surveys, it brings about great changes. Also, gender-based violence is an obstacle to development. It is not just a problem with women. It is an obstacle to the overall development of the world. The UNO and the World Bank says that gender-based violence is an obstacle to development of new sustainable development goals which aim to eradicate poverty. So that will be a problem if intimate partner violence and violence against women persist. And data says that around 40% of murders of the women are by their intimate partner. And as long as this persists, we can never achieve the aim of ending it. Our Indian women, they are the epitome of tolerance. They tolerate, tolerate, and tolerate. सह रही चुपचाप ये अपनों से ही लाचारी है, इस दर्द का न अंत है, समस्या बड़ी भारी है, हर दिन बड़ा कठोर है, तपस्या उसकी जारी है, हिंसा और पीड़ा सह रही जग जननी ये नारी है. So this is what happens to our women. This is what happens to our women, and we have to change this. Otherwise, violence against women will persist forever. As a daughter of this lovely mother, as sister of two gorgeous ladies, as daughter-in-law of this adorable mother-in-law, as a mother of this beautiful 4-year-old, and as a leader of society, I pledge to stop violence against women, and so should you. Thank you.
Thank you so much. Thank you so much, Dr. Nilanchali ma'am. Now I would like to request Dr. Yashodhara Pradeep ma'am to please honor Dr. Nilanchali. Dr. Gini, please come on the stage. Dr. Anita ma'am, Dr. Sunita ma'am, please come on the stage. Now we have a very interactive session, Cancer Update. And we have as chairperson a very senior ma'am, Dr. Veena Jain. She is MD Gynae from Lady Hardinge Medical College. I request Dr. Veena Jain ma'am to please and be the chairperson for the session. Lady Harding Medical College. She is Chief of Gynecology Hospital. She has more than 40 years experience and more than 46 publications. She is a DNB teacher and examiner. The Director and Senior Consultant, Medical and Hemat Oncology at Deep Cancer Care, Deep Hospital, Ludhiana. He has more than 17 years of experience, has worked as a renowned mentor in various hospitals like Rajiv Gandhi Cancer Institute, Medanta Medicity, and he has also headed medical oncology in DA. Our first talk is by Dr. Nidhi Jindal. I request Dr. Veena Jain ma'am.
Good afternoon, ma'am. Good afternoon, everybody. The first presenter in this session is Dr. Nidhi Jindal. She is Assistant Professor at Dr. Rajendra Prasad Government Medical College, Tanda, Himachal. She won bronze medal in his PG. She has presented many papers in national and international conferences. Her topic of discussion is a very, very important topic. It's a most controversial topic, I will say. And still, I think we should listen to her. It's very important. Though it is very controversial, it's a very important topic. And she's going to speak on removal and conservation of ovaries during hysterectomy.
Thank you, ma'am. A very good afternoon to the house. I am Dr. Nidhi Jindal. I am Assistant Professor in Dr. RPGMC Tanda. So today we are going to discuss everlasting dilemma with us when we are proceeding for cases of benign hysterectomy. That is, whether we should remove ovaries or we should conserve them. Excuse me. How to proceed with this? It's working. So hysterectomy, we all know that apart from obstetrical procedures, it stands the most common non-obstetrical gynecological procedure all over the world. More than half of all hysterectomies, they are performed younger than age 44. So the age group of 40 to 45, that is the age window in a woman's life where they are most liable or risky for the hysterectomy procedures. So when we are doing the surgery, the biggest dilemma at this age window arises whether we should go for prophylactic oophorectomy or we should not do it. So first of all, what is a prophylactic oophorectomy? So this is the removal of healthy ovaries and fallopian tubes, that is bilateral salpingo-oophorectomy at the time of hysterectomy in the cases of benign disease. And in the commonest stated reason for doing prophylactic oophorectomy, what a gynec explains or patient is concerned about is for the reduction in ovarian cancer risk. So if we discuss about the global data, BSO, it is routinely offered to the women 40 years or older at the time of hysterectomy to prevent the development of ovarian cancer, which carries a lifetime risk of approximately 1.4%. And bilateral salpingo-oophorectomy, as we see from the data, as the age increases, the rate of oophorectomy increases, like 40% in the women between age of 40 to 44 years, 60% of hysterectomies accompanied by bilateral oophorectomy. Surprisingly, it has doubled from 1965 to 2000, that is from 25 to 55%, in spite of so many guidelines. And data from the CDC, it states that 30% of the women, they have concurrent oophorectomy between the ages of 18 to 44 and 78% between 45 to 64%. So it's a very high number. So from all this data, what we need to understand in today's session, first of all, we need to understand what is the function of ovaries even after menopause. Why we are so much concerned whether to go for oophorectomy or not. Then what can be the risk and benefits of elective oophorectomy? Any specific indications of oophorectomy where we have to do it even in benign conditions, and how to do patients counseling. So coming to function of ovaries after menopause, ovaries, they continue to produce significant amount of testosterone and androstenediones for many years after menopause. And these androgens, they are converted to estrogen peripherally. So if they are combined, that is estrogens and progesterone, they are source of estrogens in premenopausal women and endogenous androgens in postmenopausal women. And why these hormones are important in a menopausal lady? They are important for maintenance of their bone mineral density, prevention of cardiovascular diseases, maintenance of their cognitive and neurological functions, and they take care of their vasomotor symptoms. And these factors, they are significant for a woman's quality of life and her life expectancy. So women, it has been seen, even if a woman is undergoing hysterectomy and not bilateral oophorectomy, even these women, they experience ovarian failure at a younger age than women with a natural menopause. And hypothesis it's behind this phenomenon is that surgery, it compromises the blood flow to the ovaries, which could result in reduction production of hormones leading to earlier ovarian failure. Secondarily, it is stated that uterus per se, it has an inhibitory influence of pituitary FSH secretions, and consequently, it has an effect on follicular atresias, which it enhances. And removal of the uterus, it allows FSH levels to rise and accelerates follicular depletion, leading to earlier menopause. So, by hysterectomy per se, it may reduce the risk of ovarian cancers, and various studies, Parker, WHO, it has been a study published in Clinical Obstetrics and Gynecology in 2007, and later on ACOG also supported this study, that hysterectomy alone, it has been shown to reduce the risk of developing ovarian cancer by as much as to the tunes of 46%. And basis behind, again, by decreasing hysterectomy, it decreases uterine growth factors that may be involved in ovarian cancer development. Secondarily, it is reducing blood supply to the ovaries. Next, it increases the likelihood of anovulation according to the ovulation hypothesis. Like uterus has an inhibitory effects on FSH secretions. Then it may block the access of ovarian carcinogens that enter the peritoneal cavity via the vagina. So the most common confusion here comes, what are the common fears while you are going for a hysterectomy for benign indications? And these fears, they are not just with the patient, they are with the gynec also. So what are patient's concerns when she is undergoing a surgery? Number one, she has an apprehension for need of repeat surgery, even for the benign lesions like residual cysts or something else. Then she have a fear of developing malignancy in the future. She may show an inability to follow up in future. And previously, if she has underwent one or more abdominal surgeries like cesareans or some other indication, then she is apprehensive, like I have to go another surgery after hysterectomy if something happens. And what are gynec's concerns while taking a decision? If a lady is more than 45 years, it's a common practice like why to leave the ovaries inside. Then women with endometriosis and severe adhesions, we are concerned like women will keep coming for pelvic pain, and that is why we want to remove the ovaries. Then women with postmenopausal bleeding with the concerns of developing malignancy in future. Women with moderate to cervical dysplasias. So before coming to any decisions, what are the benefits of elective oophorectomy? We should know that. Everyone knows that it has a preventive role on ovarian and breast cancer reduction. Then 1 to 2% of hysterectomized patients, they require subsequent surgeries because they develop benign pathologies in the form of residual cysts, for which you may have to undergo a repeat surgery. So this can be avoided if you are going for elective oophorectomy at the time of benign hysterectomies. Then, but what are the risks? That is important. So increased mortality due to coronary heart disease, then due to osteoporosis related fractures, out of which hip fractures are the most common. Then increased risk of cognitive dysfunctions, including dementia and Alzheimer's. Increased risk of depressive and anxiety symptoms. And in premenopausal women, if you are going for an oophorectomy, then there are more severe and prolonged vasomotor symptoms than in women having natural menopause. And it has been seen a reduction in libido and sexual dysfunction also. Again, it affects the quality of life in women's life. And importantly, it has been seen that if you are undergoing an elective oophorectomy before 50 years of age, these symptoms are more severely affected. Secondly, another thing is that prophylactic oophorectomy, it doesn't completely eliminate the risk of breast cancer reduction in primary peritoneal cancers, because for the primary peritoneal cancers, another etiology and pathogenesis has been explained apart from origin from ovaries. But we should know that in certain conditions, we may have to go for concurrent oophorectomy also, and these are endometriosis, benign or borderline ovarian cyst already present at the time of surgery, then any TO masses or abscess, then pelvic adhesions or pelvic mass. So this is a difficult decision because we have to outweigh risk versus benefit. We have to decide between these factors. So here comes the role of guidelines, how they guide us. First of all, our standard body, ACOG, where the upgradations keep on coming time to time. Earlier, the first guidelines came in 1999, then they were upgraded in 2008. And ACOG, here, ovarian conservation has been recommended in premenopausal women, apart from the indications where you have to go for oophorectomy. Then a lady, she should have any absence of any genetic risk or ovarian cancer or breast cancer, absence of any gross ovarian pathology, and absence of familiar cancer syndromes in the family or the lady herself. So this is the guideline, this is the line which has been recommended by ACOG, that women younger than 65 years of age clearly benefit from ovarian conservation, and at no age is there a clear benefit from prophylactic oophorectomy. So this was the study included in ACOG guidelines before they gave the recommendations for the cutoff of age 65. If you go by these data, then you can see that ovarian conservation or oophorectomy, where we are not even studying the role of estrogen therapy, there was a significant difference between hip fractures. That women having oophorectomy, there was a proportion ratio of 4.96, and women having ovarian conservation, it was 3.38, which has a significant difference. Similarly, in coronary artery disease, there was almost double the rates of coronary heart disease in women undergoing oophorectomy. And if we study the ovarian cancer risk, for which we dread the most, there is very less rates with oophorectomy 0%, but in ovarian conservation, it is just 0.4%, which is very less as compared to the other complications. And if we go, why ACOG decided an age of 65 for the women having for a decision of oophorectomy, it was seen that at the age of 64, if we discuss about the women's mortality, the 95% confidence interval in women's with two groups having oophorectomy or not having oophorectomy, it started merging. That is, their mortality rates are same after the age of 64 years, irrespective of oophorectomy or conservation. So ACOG has recommended the age of 65 years for the cutoff. But still they say, even after 65, if you are doing hysterectomy in a lady and ovaries are okay, then you should better try to conserve them. Then came the Australian and New Zealand guidelines in 2017, a very recent one. They put a lot of emphasis on patients' counseling. That is, a discussion of the benefits and harms of concurrent removal of ovaries. It should take place before hysterectomy. Should I continue, ma'am? There are just 3 4 for benign gynecological conditions, and you should consider potential risk and benefit as discussed. And women, they should be part of your counseling and decision. These were various prospective trials which supported it, out of which Nurses Health Study and Women's Health Initiative were major studies which supported the role of ovarian conservation. Then comes the biggest dilemma of unilateral versus bilateral oophorectomy. Like, as a gynec, we want to be safe, that women will be fine. But it's okay. In order to reduce the risk of reoperation, it's common practice. It was thought to be safer. But what are the problems? So this was a study, very old study, which was done in back to 1995 by Fogsi et al. It was a prospective random trial, and they compared the residual ovarian function between patients undergoing abdominal hysterectomy with and without unilateral salpingo oophorectomy. And they observed that there was a significant difference in the levels of gonadotropins and E2 levels between two groups 6 months after the operation. And women had a very premature ovarian failure in women having USO. Similarly, this was a recent study published in Menopause in 2014, and it was a very, very large 58 years long data about USO, and where they discussed, it was an observational study, and again, they didn't support USO. And what were the risks with unilateral salpingo-oophorectomy? As I told, there was earlier ovarian failure, so your purpose of conserving one ovary is not being fulfilled. Then it was observed that there was increased risk of Parkinsonism, cognitive impairment, increased risk of mortality, and surprisingly, there were more increased risk of reoperations for benign pathologies. Surprisingly, it was 5.9% almost with the women having USO. So this data was supported by these studies. These studies didn't support unilateral salpingo-oophorectomy. And pathogenesis, again, here was like we are decreasing the blood supply by conserving one ovary, and we are diminishing the ovarian tissue also. So what is the carry-home message after all this discussion? Now, first of all, assurance and counseling of the patient that the continued hormonal function of the ovary has greater benefit below a certain age than the risk of ovarian neoplasm. It's far way more than the risk. Then mortality, it has a greater effect on the decision for or against bilateral salpingo-oophorectomy than the risk of reoperation. But still, decision for oophorectomy, it must be considered on the individual basis, keeping in mind her baseline risk for developing breast and ovarian cancers, her family history, any coronary artery disease risk, and risk of osteoporosis. And women, they should be made part of its counseling. Their family members should be made part of it, this counseling. And even if they are apprehensive about their ovarian cancer risk, then still you can think of oophorectomy. Thank you, ma'am. Thank you.
Talk. And the last slide, I think the carry home message was very well taken, very nicely summarized the whole topic. Any questions? Actually, according to ACOG, you have said about 65 years of age.
Yes,
like
ma'am.
below 65 years, the ovaries should be conserved.
Yes, ma'am.
And after 65 years of age, you can remove it. Lately, there is a publication in December 2021 only in British Medical Journal. They have written as 50 years of age as a cutoff. This was a large study for more than 2 lakh women, which was observational study. And the patients are divided into 4 groups, and it was seen the all-cause mortality, because the heart disease and osteoporotic disease are the 2 things which we are really concerned about. So when it was seen the all-cause mortality, the people who were less than the population who was less than 50 years of age, there was no difference in all-cause mortality. Rather, there was a definite difference, because these people have less of ovarian cancer compared to the heart disease and osteoporotic fracture. That's due to heart disease was more in people who were less than 50 years, and it was really significant. And it should not be done less than 50 years. But after 50 years, all-cause mortality was same in both the groups. So more people were dying of ovarian cancer rather than the heart disease, but the total all-cause mortality was the same. So I think they have taken 50 years as a cutoff point, that we can preserve the ovaries if the patient is less than 50 years, and we can take it off after 50 years of age. But the patient counseling and telling her the pros and cons of the situation, I think, are very prone. And this is a general population who doesn't have any other high risk factor. If there are any other questions, I think, yes.
It's called evidence-based medicine, and there is something what we practice.
Yeah.
So there is a difference in those 2 things, and when we are practicing, we have to be very sure about the counseling of the patient. And when we are leaving the ovaries, what I personally feel is that we should tell the patient she should be well informed that her ovaries have been left. And I recommend follow-up to that patient, because in India there is nothing like preventive healthcare. So people don't come till they fall sick, and even then they spend some time coming to the doctor. So she should be well aware of the fact that her ovaries are still inside, and it would be nice to follow herself up to the doctor every yearly or whatever. I mean, this is a gap that I
Yes,
see in
ma'am.
our
It's a
system.
huge gap actually. Patient even doesn't know that she is having ovaries
Yes,
inside,
yes.
even after hysterectomy.
Yes, and then I mean, your whole effort is lost.
Yes,
if she
it's
comes
lost.
back with a problem, your whole effort is
Thank
lost.
you.
So I
Thank
think
you,
the
ma'am.
study I
Written
quoted,
consent
it was
is always taken before the surgery, whether we are going to leave one ovary or both ovaries. So the patient.
Not a question of consent, it's driving it into her mind that her ovaries have been
And the
left behind
importance
so that
that
she's
she
not
can
lost to
have,
follow.
yeah.
It's not a
I
question
think
of
as
you're
far
leaving
as
for
one ovary is concerned, I think that is taken off. She has already explained it very nicely that
Yes.
you should not leave one ovary.
Yeah, that's
Either you
like-
should
it's
leave
like
both
actually you're putting
or you
her on
should
a risk.
remove both. It doesn't give any benefit because the functioning goes away within 6 months.
Yeah, so
So
that's
there is no point in leaving that ovary.
Single
Also, either
ovary.
you remove both or you leave it. And removing the ovary at 50 years of age, that's another point, because if you are telling the patient that you are keeping the ovaries inside, you are continuously giving her that sense that she has to keep herself very aware of it.
Yes, I
So
think that is
once you
important.
remove it, then that fear is also like taken care of. The incidence of peritoneal carcinoma is very, very low. So you are little on the better side, and otherwise the non-malignant cyst,
Yes,
there
ma'am.
also you are taken
Yes,
care of.
yes,
Endometriosis.
Yes.
So these things will also be taken care of. So ACOG is still 65, but I think 50 years
50
of
appears
age
to be
is,
like a respectable age group,
age
ma'am.
to remove
Yeah.
it.
Thank you, ma'am. Thank you. Thank you.
Excuse me, ma'am. Good afternoon, everyone. Ma'am, I wanted to ask, you said either remove both the ovaries or leave both the ovaries. There is no use of removing one ovary. Ma'am, but in some scenarios, we see that one ovary is cystic or diseased and the other one is healthy. And the patient is perimenopausal age group. So, ma'am, in those cases, won't it be beneficial that we remove the cystic one and leave the healthy one behind?
See, this whatever we are discussing is a normal, absolutely normal ovaries where we do not suspect anything. In case you are suspecting that there is a cyst in one ovary and the other ovary is liable to develop a cyst, you can remove it.
Okay.
Yes, thanks for the input, ma'am. It's a very long discussion. We can take up more questions at the end of the session. Now, I would like to call upon the stage Dr. Shireen, whose talk is Sentinel Lymphadenectomy in CA Endometrium. Dr. Shireen is a senior consultant at Mohanday Oswal Cancer Hospital since last 12 years. She is an ex-trainee from Tata Memorial Hospital, Mumbai. Welcome, Dr. Shireen.
A very good afternoon to everybody. Good afternoon, ma'am. She's our teacher, and nobody goes beyond. I mean, in gynae oncology, she's whatever she says is it. So today I'll be giving. So while in cancer endometrium, while we are still debating whether we should remove lymph nodes or not remove the lymph nodes, a middle path of lymphatic mapping has been proposed, practiced, and now very much into practice. So the most common cancer in developed countries is cancer endometrium. And it usually presents in a very early stage because patients come to us with bleeding in postmenopausal age groups and we can detect them very early. So all these early stage cancers and also advanced undergo surgical staging. The most important prognostic factor in cancer endometrium is the lymph node status or the lymph vascular space invasion. So if we go to the staging of cancer endometrium, the first stage is when the disease is confined to the uterus. Second is when the cervix gets involved. And it is the third stage where the disease becomes extrauterine. And it is 3C1 and 3C2 where the pelvic and the paraortic lymph nodes get involved. So the prognosis of the disease it becomes worse as the stage progresses. So here lies the significance of the lymph nodes in cancer endometrium. So, and this is a very busy slide. So what NCCN or FIGO has proposed as surgical staging, there are many routes of doing surgery for cancer endometrium. We can adopt robotic, laparoscopic, open, vaginal with assisted laparoscopic. So, and what we have to do is basically, first of all, do a pelvic lymphadenectomy, followed by a hysterectomy. Paraortic lymph node dissection depends on the stage of depends on the grade and the histopathology of the tumor. High-risk tumors needs to have periodic lymph node dissection. Then mental biopsies need to be done in high-risk endometrial cancers. And though peritoneal cytology does not impact the staging, but still FIGO suggests we should do the peritoneal cytology. So why do lymphadenectomy? Because the prognostic value, the prognosis of a patient, the 5-year disease-free survival falls from 90% to 54% once the lymph nodes come out positive. There has been no therapeutic value of doing a lymphadenectomy in cancer endometrium, but it also helps us to decide on what adjuvant therapy we need to give to the patient. So as per the NCCN guidelines, if the lymph nodes are positive, the patient comes out to be stage 3 disease, we do need to give her systemic therapy with chemotherapy along with plus or minus radiotherapy. So the whole adjuvant therapy status of the patient changes once the lymph nodes come out to be positive. But there are many complications of doing lymph node dissection. So the most important are the formation of big, huge lymphocytes. Some patients end up with huge lymphocytes of the size of 15 centimeters. And then they end up with having lymph stasis in the legs and then followed by DVT. Also, there can be increased blood loss if there is a vessel injury. This can happen in the hands of experts also. There can be an injury to the obturator nerve. It prolongs the surgical time, and it can be tremendously difficult in obese patients. So can we avoid lymphadenectomy in early stage or low risk endometrial cancers? No, we cannot avoid it still, because nearly 10 to 15% of these early stage cancers have metastatic disease in the nodes. And 15% of those diagnosed as grade 1, stage 1 on office biopsy will be upgraded grade-wise post-operatively on final histopathology. Thus, we may falter in the kind of adjuvant treatment given in early low-risk endometrial cancers. As well, we increase the chance of recurrences. So a new thought was thought of, a middle path, that is sentinel lymph node biopsy. This was introduced by Burke et al. In 1996. So what is the sentinel lymph nodes? It is the first draining lymph node. It's the first node receiving lymphatic drainage from the primary tumor. And its pathological status reflects the overall status of the entire basin. And it is 3 times more likely to harbor the tumor than the sentinel lymph node. So what are the principles of sentinel lymph node mapping for endometrial cancer is, this is also a very busy slide. So I'll just tell that after the patient is taken under anesthesia, we give injection in the cervix at 2 places at 3 o'clock and 9 o'clock positions with a lumbar needle. And there can be superficial and a deep injection. Various dyes I'll be discussing on later on. And then we take up the patient for surgery and map the lymph nodes. So the technique is intracervical injection of a blue dye. Blue dye can be isosulfane blue, 1% methylene blue, or a radioactive tracer, technetium-99m, or ICG, which is indocyanine green dye. So people do combine ICG and technetium-99m also. And how do you read the lymph nodes? Either by naked eye, if you're giving a methylene blue injection, we can read it by a naked eye, or we can use gamma probes. In lab and robotics, we use infrared fluorescence imaging. So the site of injection is 3 and 9 o'clock position, and we can give a superficial and a deep injection. So that is how we see the lymph nodes on while doing sentinel lymph node biopsy. So what are the common sites of lymph nodes involved in cancer endometrium? Most of the lymph nodes involved in cancer endometrium are the pelvic lymph nodes. So the most common sites are near the external iliac vessels, ventral to the hypogastric vessel, and the obturator nodes. Very few cancer endometriums have skip lesions. That means the pelvic lymph nodes get skipped and they go to the periaortic lymph nodes. So there lies the importance of doing a pelvic lymphadenectomy more than the periaortic lymphadenectomy. But there can be unusual sites of spread, that is the presacral lymph nodes, when the tumor spreads along the mesoureter into the presacral lymph nodes, or they can be parametrial lymph nodes or high parametrial lymph nodes. These lymph nodes can actually be missed while we are doing a routine lymphadenectomy in these patients and can be picked up while doing a sentinel lymph node biopsy. So that is the intraoperative picture of how you see the sentinel lymph nodes with ICG or a blue dye or methylene blue dye. So for the pathologists, it is very important that once we have harvested the sentinel lymph nodes, it has to undergo various cuts to the level of 3 millimeters to look for metastasis. So it is positive if there is a... so what they do is on the lymph node, they can put an H&E staining and also do ultra staging by putting an IHC stain. So macrometastasis is when the tumor clusters are of more than 2 millimeters. Micrometastasis is when the tumor cluster is between 0.2 and 2 millimeters. Then there are isolated tumor cells with single tumor cells or tumor clusters of less than 0.2 millimeters, and it is designated as PNO1I+. So sentinel lymph nodes with only isolated cytokeratin positive cells should be considered negative for metastasis. So what is the aim of sentinel lymph node biopsy? It is to reduce the false negative rate by detecting the disease in discovered sentinel lymph nodes by IHC and ultrastaging. So how do you go about it? So once you have given anesthesia to the patient, you have injected the dye, you go inside and you look at the peritoneal and the serosal surfaces first of all, and then you go in for a retroperitoneal evaluation. So you look at both the hemipelvises and all the mapped sentinel lymph nodes are to be excised and sent for ultrastaging. Now, if the node is not highlighted but is enlarged, that also has to be removed and sent for frozen. So if there is no mapping on hemipelvis, a site-specific lymph node dissection has to be performed, and the periodic lymph node dissection is left to the discretion of the attending consultant. So this was a large trial, a multicentric prospective cohort study, which included a large number of patients and studied about the lymph node dissection in the cancer endometrium. So they used fluorescence imaging for robotic endometrial sentinel lymph node biopsy, and the method they used was to inject ICG after anesthesia, identify sentinel lymph nodes at least one in each hemipelvis, and send it for frozen, where it was seen by H&E staining and ultrastaging and IHC, followed by a complete pelvic lymphadenectomy plus minus periodic lymphadenectomy depending on the clinical relevance. So the primary endpoints were the sensitivity. Sensitivity meaning the detecting of positive lymph nodes accurately in actual node positive patients by positive sentinel lymph nodes. And the negative predictive value meaning negative sentinel lymph nodes in actual negative non-sentinel patients, sentinel lymph node patients. So of the 340 patients that they studied, 293 underwent sentinel lymph node biopsy. And of the 293, 36 patients were detected as node positive. And out of the 36 node positive patients, only one patient had negative sentinel lymph node. So the sensitivity of sentinel lymph node biopsy is to the tune of 97%, and the negative predictive value was to the tune of 99.6%. And there is only a 3% chance of missing, but a 99% chance of detecting a positive sentinel lymph node. Other cancers where sentinel lymph node biopsy can be done are vulvar cancers, breast cancers, and melanoma. This sentinel lymph node biopsy is still being evaluated, studied, and being put into practice. So there's still a lot of scope on improving on it. So the scope of improving lies in the hands of the surgeons because there's a long learning curve, and then the pathologists who need to know how to ultrastage and do IHC techniques. There are low volume metastasis in lymph nodes. The prognosis still needs to be determined. Improvements and definitive protocols in adjuvant treatment modalities still need to be decided. But we must encourage sentinel lymph node biopsy, and it should become the standard of care in cancer surgeries. Thank you.
Flow on sentinel lymph node biopsy.
Ma'am, we can take questions at the end of the session.
Okay, okay. Thank you. Thank you, Dr. Shireen.
Thank you, Dr. Shireen. Thank you so much, Dr. Veena, ma'am, for making it so interactive. Now, our next is a panel discussion which is used in our day-to-day practice. Get your grip, obstetrics genetic case scenarios. Our moderator is Dr. Deepika Deka. I request the panelists to please come on the stage. Dr. Richa Kansal, please come on the stage, ma'am. Dr. Richa Kansal is Professor and Head OBGY at Kalpana Chawla Government Medical College, Karnal. She has a vast experience of 20 years as a teaching faculty. Our next panelist is Dr. Veronica. Dr. Veronica is working as an Associate Consultant, Assistant Professor in JIPMER, Sir Gangaram Hospital, New Delhi. She is a gold medalist, Best Resident DNB 2019, and has published 47 papers. Dr. Pardeep Kumar Sharma. He is a DM neonatologist, AIMS, New Delhi. He's a Senior Consultant Neonatology at Deep Hospital, Ludhiana. He's ex-Associate Professor, MAMC, New Delhi. Dr. Ritika Bajaj. She is Consultant Obs Gynae and Fetal Medicine at Jindal IVF and Sant Memorial Hospital, Chandigarh. She has several national and international publications and more than 12 years of experience. Dr. Harpreet Ishar. She is MD, MRCOG and DNB from GMC Jammu. Currently, she is a Senior Consultant, Fetal Medicine, Motherhood, Chaitanya Hospital, Chandigarh. She has several national and international publications to her credit. She is FMF certified practitioner. I welcome Dr. Aradhana Agarwal Bhalla, who's a consultant fetal medicine at Apollo Hospital, Head Fetal Medicine Department, Amritsar. Dr. Bhalla's Center for Imaging and Fetal Medicine, 6 years of experience in fetal medicine. I request Dr. Deepika Deka ma'am to please moderate the panel. Dr. Deepika ma'am is a very senior consultant fetal medicine at Cloud9 Hospitals, Gurgaon. She is ex-chief maternal fetal medicine professor and unit head OBGY AIMS, New Delhi. We can go on for hours to introduce Dr. Deepika ma'am.
A very good afternoon to everybody. I was thinking we are going to be later, and so I'm so sorry for just rushing in now. So I don't know if you all have had lunch. I had my lunch, so I might be tempted to go on early. So let us start. This one? Okay. So thank you, first of all, the organizers for inviting me here and giving me a topic which is very close to my heart. And I'm really thrilled that my panelists, Dr. Aradhana Bhalla, Harpreet Ishar. I'm so happy that Harpreet and Ritika, they are my ex-fellows, though I did not get a chance to directly teach you, Harpreet. Then Dr. Pradeep, so nice to see you. I have known you as an undergraduate, postgraduate, senior resident, so welcome. And Veronica, Rita Kansal, welcome again. And Veronica, she's an obstetrician turned geneticist, so it's a new addition to the group. So let me introduce my esteemed panelist, Dr. Aradhana. She is a consultant fetal medicine at Apollo Hospital, Amritsar. Harpreet, she did a PG and she is a gold medalist, very nice. And she's trained in fetal medicine. Then Pradeep Sharma, he's the neonatologist from AIMS, as I said. And we need the neonatologist, part of the fetal medicine team. Richa Kansal, again, professor in head. And she is also into fetal medicine. And Ritika, she's in Chandigarh. She is my ex-student and is working in fetal medicine. Veronica is from Gangaram Hospital. And the interesting thing is that she has worked on whole exome sequencing, and she just delivered a very interesting lecture at Cloud9. So let us go straight to the point. Just to set the ball rolling, how important is fetal medicine? We all know that in state-of-the-art obstetrics, everyone has to know a little bit about fetal medicine and genetics. We don't expect you to be geneticists, experts, but you really need to do the postgraduate level. What is a congenital malformation? What are birth defects? What are the genetic problems which are common? And then what to do the basic investigations and when to refer to a fetal medicine specialist. And you must know an idea about what is going to happen in the fetal medicine specialist's office so that you can counsel your patients at your level. So, Dr. Aradhana, what would you say? Is it a very major problem, birth defects?
Right, so thank you for that question, ma'am. And yes, it is a problem because if you look at the overall picture, almost 4% of the babies are affected with with any sort of a birth defect. And if we look at the worldwide picture, it's almost 6 million babies a year. That's a huge figure. In fact, if you look at the neonatal deaths and the stillbirths, almost up to 11% of them are, because some sort of an aneuploidy. So if we look at the most common ones, we have cystic fibrosis, neural tube defects, even congenital heart defects. And the most common, trisomy 21, everyone is very afraid of that. An incidence of almost 1 in 700. But not to scare you, the good news is that if we follow good screening protocols, timely protocols, we can actually prevent almost 70% of these problems.
Yes. And with a population like ours, 3 to 5% becomes a very, very big number. So you need to screen of your 100% patients, that particular 3 to 5% whom you need to refer to a fetal medicine specialist. So what is a screening test? It is something, as you know, which is performed on all women, all asymptomatic women, and then you pick up the person who is at likelihood of having a birth defect. So we just want to know from you, Harpreet, what congenital and genetic conditions should we screen for in early pregnancy?
So when it comes to screening in early pregnancy, we should never lose importance of the fact of history taking. So a good history taking into consideration the obstetric history.
If you could just name, because we want it to be very fast and crisp.
So
what are the conditions? I mean, you look for malformations, or
we
you look
for hemoglobinopathies, especially beta thalassemia. So, and then we talk about the various screening tests available for aneuploidy screening.
Yes.
And then we
Aneuploidy.
talk about the first trimester combined screen, which includes a good extended first trimester scan, where we are not just looking at markers for aneuploidy, we are able to detect at least 50% of the major malformations, like the list shown in the previous slide, as well as screen the patients for high risk for preeclampsia and fetal growth restriction. So these are the conditions we can screen for and take preventive measures right at the first. And last point is that before prescribing any kind of dual test, NIPT, it is important to do adequate pre-test counseling.
We should know what conditions we are looking for. And as she said, the important things are, first of all, would be the malformations, congenital malformations, structural malformations. Then we have the chromosomal disorders, the commonest being trisomy 21. Then we have 13, 18, and XY, and also the genetic disorders like thalassemia. It's very common in our country. So then we know that the screening after birth is in place. So I think more and more diseases are being screened for at least after birth, though it may be too late, considering that we could have screened them during pregnancy. But even then, we must have an idea about what are the conditions we should screen for after birth. Dr. Pradeep?
Ma'am, the most important conditions to be screened, one is congenital hypothyroidism, which is one of the leading causes of mental retardation if not detected in time, and is totally preventable. Another is congenital hearing or congenital deafness. We should screen for anterior segment. We do an eye examination for anterior segment problems. Then the others in line are the metabolic disorders like inborn errors of metabolism, cystic fibrosis. So these are some of the tests that most of the times we are routinely asking the parents to get for their babies thyroid, hearing test, and one more I want to highlight is pulse oximetry to rule out congenital heart disease. It screens most of the diseases as a simple test. And if we find something abnormal, when we get an echo done.
So I think congenital hypothyroidism. So we also, Dr. Harpreet would say that we should screen for hypothyroidism during pregnancy. I mean, I hope it is a routine with everybody. Yes. Now, of course, we screen everybody for aneuploidy, but then there is a high-risk group who are more likely to have problems. So, Dr. Richa, who would these high-risk women be? And it's very important.
Thank you for the question, ma'am. And very aptly said, this group has to be identified if we have to work to reduce the load of these babies who are born with some congenital malformation or Downs, as you said, is the most common. So as such, as a dictum, definitely it has to be offered to all because 4% is not a very small percentage. But at the same time, while identifying, say, if we have a couple who is having an affected child prior born or is having a family history in which an affected child has been there, there has been an incidence wherein some disease or medication has been there for that particular individual, which can increase the possibility of congenital malformation. But the most important thing is maternal age. If maternal age is more than 35, that definitely strongly increases the risk of aneuploidy and other congenital malformations, and that should not be forgotten. So any translocation in the parents or other conditions that we can think of.
Yeah. When I started doing fetal medicine, when I joined as an assistant professor, before you people were born, even 88, maternal age was one of the indications for doing amniocentesis. So we used to put in a needle to every woman above the age of 35. There were not too many. But now, of course, we'll talk about the different things coming in. So, Ritika, I would like to discuss a case with you. This is a primary gravida, 26 years old. And you find that there is an increased nuchal translucency here. And this was a dating scan. It wasn't the 11 to, first trimester screening scan. Do you think this is abnormal? What is your diagnosis? How will you manage?
So whenever we have this kind of a finding, we do tell the parents that there is an increased chance of the baby having either a genetic abnormality or a structural malformation. But we do not act upon it at 10 weeks itself. So we generally call them back again at about 12 weeks. And at that time, we can do a detailed anomaly scan also. So if we find other anomalies, like if we are suspecting a congenital heart defect or some skeletal dysplasia, then maybe sometimes parents don't opt to continue. Even in those cases, we do stress about the need for genetic testing for future counseling. If we do not find any structural abnormality, only an isolated increased NT, then we counsel them according to the previous table which we showed. Even with an NT very high, there is still a sort of a 15% chance of the baby being alive and well at birth. So we offer them invasive testing by CVS. And the important thing is nowadays we are not doing karyotype. We offer high resolution microarray in these cases. We also counsel the parents for DNA storage, so that if this NT persists into the second trimester, we can even think of doing an exome sequencing in these cases, because some of these babies may be having Noonan syndrome. So it's a step-by-step approach, and we need to counsel them. If everything is fine, so in 9 mm, we know that the chance is very low, but if everything is fine, all the tests are fine. So there is no structural anomaly at 20 weeks, fetal echo is normal at 24 weeks, and our genetic tests are normal. So then sometimes parents say, can we continue? So at some point we have to tell them that, so if by 24 weeks all our reports are clear, then maybe we can counsel them that there is a 98% chance of the baby being fine.
Yeah. So this definitely is very abnormal. And frankly, is in a case like this so big, 9 mm, you really need to go in straight away. Even at this point, I knew that there could be a very high, almost a 60-70% chance that there would be a chromosomal abnormality. So I did a CVS, and this is a report. What is your comment? It's a 45XO.
Yes, so this is a case of
Yes.
monosomic chromosome X.
Yeah. So a increased nuchal thickness. By chance, we discovered at 10 weeks. I did a CVS only at 10 weeks because I thought that it is a very high risk. Okay, this is for Veronica. Gravida 3, it's your case. Non-synchronously married woman, presence at 90 weeks of gestation, ultrasound diagnosis, bilateral enlarged kidneys, echogenic, with severe oligohydramnios. And she has a very strong family history. And the previous baby also was like that. And a family history also. The paternal grandfather died of renal failure. So this is what the kidneys look like, huge kidneys, multicystic. So what is your diagnosis?
Thank you for the question, ma'am. So we have a third gravida, and this is a recurrence of a genetic malformation. So as we know that if there are bilateral enlarged cystic kidneys and there is a recurrence and there is a family history, we will think of a genetic abnormality. So the first thing is obviously to talk to the couple to tell them about the situation. So also it is very pertinent to draw a 3-generation family pedigree to understand the pattern of inheritance. For example, in this case, we have a recurrence and the parents are apparently asymptomatic. So this is most likely to be an autosomal recessive condition. And in this case, most probably an autosomal recessive polycystic kidney disorder. So we then talk to them about the risk of recurrence. This pregnancy may be discontinued, but we have to offer and tell them the different genetic tests that are available and that can be done in this situation. So for most of the fetal malformation, the first test that we offer is a chromosomal microarray, but for certain conditions which are restricted to one organ, for example, in this case, which is an autosomal recessive polycystic kidney, we already know that there are 2-3 genes which are known to cause it. So we can do a clinical exome sequencing or a whole exome sequencing. In fetal cases, it is better always to do a whole exome sequencing and then proceed so as to look at all the genes together. So that's what we will do. We will counsel them in a way that they could discontinue the pregnancy, and all thanks to the MTP bill that now we can discontinue the pregnancy till before 24 weeks of gestation. So in this case, we have to
And this was a report.
Yes, this is a case which is published as well. So we have to offer a fetal autopsy after discontinuation of the pregnancy, and on the fetal sample we have to go for exome sequencing and also with histopathology and X-ray image so that we can prevent this happening in the next pregnancy by appropriate prenatal diagnosis or even IVF with PGT-M.
Yeah. So the message, take-home message is that if you find an abnormality, just don't say terminate the pregnancy. Please have a genetic counseling. This is going to be important for future pregnancy, how to deal with in the future. Thank you. This is for Aradhana, a 34-year-old lady with triplet pregnancy conceived after ovulation induction and IUI. Then she had a reduction to twins at 12 weeks. And the problem doesn't end there. The one baby had a choroid plexus cyst, and the other baby has an echogenic cardiac focus in the 18-week scan. So now what to do?
That is indeed a very interesting case, ma'am. Now we know the triplets have been reduced, and we know that when there's a higher multiple order pregnancy, we do rely a lot on our ultrasound markers as well. Now, we know that one fetus is having a choroid plexus cyst. It's a very common finding, and everybody must have seen it in their day-to-day practice. But you know, it's a prevalence of 1 in 50, which means that more than 90% of them actually resolve by 26 weeks. We do have to, however, look at the number, the size, follow up, and not forget that it is associated with trisomy 21 and
that's
18.
the concern.
Yeah. Now, the other one is having echogenic foci, but it is an isolated finding. Though we know that 30% is associated with normal Asian pregnancies, it is also a soft marker for trisomy 21.
But they're very, very scared. You know, the couple they are
So now that
anxious.
we
It
know,
is. So
yeah.
can we do an NIPT?
Yes, now the question comes with NIPT, and a lot of recent scientific research is verifying that, the feasibility, sensitivity, and the specificity of NIPT in twins is actually quite good. So yes, we can opt, but there are shortcomings. So pre-test counseling is very important here, because we know that NIPT is not, it's actually checking the placental DNA of the fetus, not the fetal DNA. So if there is a genetic aberration in the placenta, it may be different from the fetus. So this is something the couple should be told beforehand. Other than that, fetal echocardiography, follow-up scans. Now, the question of invasive testing, that comes, it's not exactly indicated in this case per se,
Yeah.
but we have to give this option to the patient. Suppose they have, a previous obstetric important history, or they have a wish to get it done. Then a DCDA twin pregnancy, we would check for both the sacs. MCDA, we could go for a single placental sampling in such a case.
Yes. Again, the take-home message is that what you said, the risk is low, but we must never take the decision for the parents. So if the parents want an invasive testing, despite your counseling, and if the NIPT turns out to be low risk, then it's very good. But if it turns out to be high risk or something, then you can do. So it should be a very unbiased counseling. So you talked very well about the NIPT, and this has really changed our management of simple markers that you get. And also, there are a lot of recommendations from the ACOG practice bulletins that have been put in here. So would you like to say something about this?
Well, this is what we were discussing, ma'am, that they are opting for this now.
Yes.
A lot of scientific research has been put into this, and they are saying that the false positive rate is very low.
Yes.
So it has become a very sensitive test, but we mustn't forget it is only, it's very good for T21, and that's only 50% of the chromosomal abnormality.
In twins, the sensitivity decreases a little bit, but it can still be used, and it has really taken over invasive testing by a large number of cases.
Absolutely.
As there are studies where they have seen that even in twin pregnancies, you can do NIPT. Because there's a very low false positive rate, and so it is a very good test even for twin pregnancies, but not for triplets. Okay, this is another case, Gravida 1, 33-year-old. She came at 20 weeks of pregnancy, very late. She was referred to me with a quadruple test of 1 in 57, which means that she really didn't have and 1 in 57, what should you do?
Right. So,
Dr. Harpreet, yeah.
Right. So this quadruple test of 1:57 definitely is a test which indicates high risk for trisomy 21. I believe it is for trisomy 21.
Yeah.
And however, one has to take it with a little pinch of salt, because quadruple test best is done between up till 18 weeks, but again, it varies from lab to lab.
Should have been done earlier.
Yes. And I would have really liked to look at the scan at any other additional findings. I would advise in this patient an amniocentesis. We have to do that and confirm whether this baby is all right. At the same time, telling the patient not to be worried too much, because most of the times, if it's more likely to be a normal baby, but obviously we have to confirm it.
Yes, we should also do a little bit of positive counseling. We shouldn't scare the patients. If she has a risk of 1 in 57, then there is a 56% chance that the baby could be also okay. So quadruple test is something, okay, you do it in the second trimester when the patient comes late. But we discussed already that first trimester is a better, more sensitive screening test than the quadruple test. And even then, it still has a sensitivity, still has a role to play. In this case, you said that we would do a fetal karyotype and confirm with an amniocentesis. So it was done, amniocentesis was done, and the fish test showed trisomy 21.
So 2 points I want to emphasize here.
Yes.
So one, that even if the fish has confirmed a Down syndrome, we need to follow up and find out what kind of a Down syndrome this is for predicting.
So we need the karyotype,
Right.
we need the culture. So, but can you take a decision of termination based on this? Because fish, the report comes in 3 days.
Yes.
The culture or microarray, those things would take about 2 weeks.
I believe we can.
Yes.
Agreement with the geneticist.
So then termination of pregnancy was done.
And just one more point, ma'am. There
Yeah.
are situations where both the first trimester screening is done as well as quadruple is done, and the results are contradictory. So if we have a good combined first trimester screen, I would suggest not really to go for a quadruple test.
I would suggest an NIPT.
Yes,
I don't
yeah.
want to take a risk.
Yeah.
Rule of the thumb is when in doubt, do it. Okay. Anybody would like to ask anything? Everything clear? The audience? Okay. Though we go on to the next case for neonatological
Someone has a
consumption.
question, I think.
Somebody? Yeah. Previous case?
This is in accordance with what Dr. Harpreet was saying. We have in private practice, we are getting the dual marker done and we are getting the NTA
Yes.
scan done. And then again, we are going in for a quadruple marker, even if that is normal. I think we should deviate from this practice.
What do you say, panelists?
Yes.
This is what I'm seeing every day,
Yeah.
that people are doing the dual marker and then again they're doing the quadruple marker.
And then
Anybody would like to say
Yes,
anything?
please don't do after a good first trimester combined screen.
Yeah,
we are
that's what
very
I said.
happy and we must not.
If we get
repeat.
a normal first trimester combined screening, I think we just should not do
ma'am.
it because then it is just landing yourself
No,
and
okay, I'll give my comments.
I'd like to add
Anybody
to that.
wants to say anything else? Yeah.
Ma'am, I feel that that's fine. We should not go for quadruple, but a good level 2 scan should be followed.
Yeah,
if the
definitely.
age
Scan
is more,
has to be done.
Yes.
That is done, but the screening, dual and quadruple, and then there is a discrepancy, and then you are at a loss. and the
Definitely,
patient
ma'am.
is also-
Definitely.
Okay.
But
You
it
know,
should not
I was
replace
talking-
other things.
That is what the books tell us. That is what the articles, this is what Fetal Medicine Foundation tells us. But what I have found in my practice, let me tell you my opinion, and that is not, of course, evidence-based, but practical. And this is, with the practitioners that I'm working with. They do everything possible that there is no chance. And then I asked them, why are you doing? And they gave me a very reasonable reply, that dual marker, what is the sensitivity?
85
Sensitivity.
85%.
Okay, you're
around.
still leaving 20-30%
Right.
to chance.
Right.
And so then you're again doing the quadruple. What is the sensitivity of the quadruple?
It's a little lesser than.
It's lesser.
lesser.
So, but that doesn't mean that you are picking up only the percentage that was picked up by the first test. Maybe you are covering another group of patients and you've picked up. That was the reasoning given. मैं तो करूँगी. No, and I thought it really made sense. Unless you do a test like amniocentesis for every patient, how can you say with 100%? No, even amniocentesis is not 100%. It is 99.9%. 0.1% still left to chance, culture problems. NIPT is still better. But you can't do NIPT for every patient right now. So I really don't go against. But please, that is not the recommendation by any of the societies.